There's Lena. Okay, good morning, everybody. So you're all very welcome to the PANDEM-2 final conference, which we are holding in conjunction with eNOTICE and Proactive Consortia. It's a great pleasure for me to be here in the final 6 weeks of our PANDEM-2 project to showcase the work we've been doing since we started in February 2021, a year into the pandemic. It's probably the best possible time that we could be working on pandemic preparedness, given the focus now on what the lessons that were learned in Europe during the pandemic. So I'm going to speak today about just an overview of the project. If you could open the slides there, that'd be okay. And the next one. Oh yeah, I've got them here, yeah. Can you put on the slides again? I don't know what happened there. Here we go. Okay, so where are we now at this point in time in June 2023? So we're all aware of the devastating impact that COVID-19 has had on European citizens. We're looking at a disease that had a mortality rate of about 1% and in people with pre-existing conditions. But despite this level of mortality, it's led to considerable social, economic, educational, and health and security consequences. There's an estimated 780 million cases have been officially reported and almost 7 million deaths. But the reality is a lot higher than that. And WHO has estimated that there are almost 24 million excess deaths that occurred during the COVID-19 pandemic. So these are people who would have died from COVID, but also died due to lack of care, lack of access to healthcare services, delays in diagnosis of cancer, lack of treatment for acute episodes like stroke or myocardial infarction, and that they also contributed to the death toll. And we've looked back at Spanish flu of having a death rate between 25 and 50 million, so we're up there in terms of the impact of this disease. And the IMF estimated the cost to be about $12.5 trillion, but the cost is still ongoing. And I think we'll all know in our individual member states the impact on children. Some of our member states continue to maintain schools open, others closed, universities closed, and we're still dealing with the impact of that loss in education, in addition to the social and economic consequences. So what I'm going to talk about in this overview this morning is to look at pandemic threats. We are a security project. The big concern is that obviously we are at risk of biological threats as human populations, and this threat has gone back through the millennia. I'm going to look at the current context in Europe in terms of developments in the EU agency landscape and the current focus on preparedness. And then I'm going to give a brief overview of the PANDEM-2 project outputs, which are going to be presented over the course of the morning, with the demonstration then at 2 o'clock this afternoon. And I think the key part will be the panel discussion, which will be moderated by Anders Tegnell, and we will have our key colleagues in EU agencies to discuss the future priorities in research and training and how PANDEM-2 outputs and the outputs of the other two projects can contribute to a more prepared Europe for a future pandemic. So the risk factors are continuing, and the risk today is greater than 10, 15 years ago. And the reasons for this include deforestation. We saw with the Ebola outbreak emerging in West Africa, with encroachment of human populations into forests. We will never know where exactly COVID-19, SARS-CoV-2 came from, but there was obviously concern about wet markets and pangolins and trades in exotic animals poses a risk of a spillover event. Intensive farming practices leads to avian influenza passing on to poultry workers. And we've also seen considerable advances in the area of genetic engineering. And the technology that we have now allows biohackers to edit existing natural viruses and bacteria. And that can lead to, again, a virus that can be transmitted from human to human. There have been biosecurity lapses in biosafety level 3 and 4 labs across the world, leading to accidental release. So a laboratory accidental release affecting laboratory workers. And again, that's something that we're concerned about from a security perspective. And the final risk factor there is the deliberate use or gain of function biological warfare research, which is research on pathogens to try and make them more transmissible or more virulent. And there's work ongoing, for example, on H5N1 to make it more transmissible in ferrets. There's work being done on polio and a number of other viruses that, again, it's very important that there's some regulation or oversight, because accidental release or deliberate release could again lead to a future pandemic. So what biological agents pose the greatest threat? And I guess the one that we're concerned about is influenza, H5N1 or other strains, another coronavirus. There are 10,000 coronaviruses out there in nature that live in bats. We know of 7 that have infected humans, 3 more severe and 4 that cause the mild head cold. So what's out there could be a lot more serious. We saw with SARS-1 death rates of 10%, with MERS, another coronavirus, a death rate of 30%. So this particular coronavirus was a lot milder than what we had previously experienced. There's also the risk of resurgence of known diseases such as Zika, Nipah, Ebola hemorrhagic fever, Lassa fever, Rift Valley fever. And there has been work on Rift Valley fever in certain countries looking at trying to weaponize it as a possible agent of warfare. In terms of deliberate release, the concerns in terms of public health are anthrax, botulism, Marburg virus, Ebola virus, and plague as potential bioweapons, in addition to genetically engineered pathogens. And then the final threat there is that of antimicrobial resistance. And we heard yesterday about the investment by the European Commission in antimicrobial resistance. This is hospital-acquired infection, bacterial infections pose a significant risk to humans. And we could be back to where we were in the 40s and 50s with bacteria that are resistant to our antibiotics. So again, this is a big priority health issue for the Commission. In terms of the landscape and the risk at the moment, a novel strain of influenza A remains the most likely source of the next pandemic. And this is linked to large livestock farms and the intensive poultry farming practices, which allows infection in birds to cross over into humans, into poultry workers and then into humans. There have been a number of cases. There's been cases confirmed in Spain and in Cambodia. In Cambodia, there was a 50% mortality rate, and the cases confirmed there. So again, we're monitoring the situation, but avian influenza and a strain of 1918, which is what we used in the functional exercise, would wreak havoc on our healthcare system, even despite the advances in the last 100 years in our healthcare. So in terms of the current context, so yesterday, those of you who participated yesterday would have heard Cynthia Menelemos from DG Sante speak about the new regulation on serious cross-border threats to health. This came into force in October 2022, and this was on foot of the original serious cross-border threat decision 1082. This confirms the central role of DG Sante and the Health Security Committee. They're included in this as an extension of ECDC's mandate, building on their key roles in epidemic intelligence, risk assessment, scientific advice and training. So going from a preparedness role to a much more response role. A priority will be the development of a digital platform for epidemiological surveillance and investment in the EWRS system, which our work can contribute to and we also interacted with the EWRS simulation exercise platform during the functional exercise in March. Within this plan of action is establishment of an EU health crisis and pandemic plan and national plans by member states using an all hazards approach. And this links into the work we've been doing over the last 2 days on CBRN. So it's not just biological threats, it's chemical threats, environmental threats, and nuclear threats. And that all comes under DG Santé's mandate. And the Commission has committed to facilitate stress tests to ensure the operation of EU preparedness and response plans. And this is taken a lot from the defence sector, who do stress tests on a regular basis. And being a security project on a health topic, we've learned a lot from the security world in the past year and a half, 2 years. I think from the experience of the last 2 days, how the CBRN community organised their stress tests has been very impressive in terms of their field exercises, and I think that's something that we can learn from in the health domain. We've also had the establishment of the Health Emergency Preparedness and Response Authority, or HERA, that was in September 2021. HERA's mission is to prevent, detect and rapidly respond to health emergencies, and we will have a participant from HERA representative here this afternoon, as we did yesterday. So HERA is developing mechanisms to ensure the production, distribution of vaccines, medicines and other medical countermeasures. It's modelled in some way on the BARDA US structure. And a major part of HERA's work will be on joint procurement of medical countermeasures, which was done very effectively during the COVID-19 pandemic. And key links, obviously, for HERA's work, Santé, ECDC, the European Medicines Agencies and GG Home. So WHO headquarters in Geneva, the European regional office is in Copenhagen. The Health and Emergencies Programme played a central role in the global coordination of COVID-19 in terms of the analysis of epidemiological data, in terms of the updating of advice, guidance on clinical management, diagnosis, and then the vaccine approval process. A WHO pandemic hub has been established in Berlin and is working closely with the Robert Koch Institute on data intelligence. WHO has just published new guidance on integrating planning for responding to any respiratory pathogen such as influenza and coronaviruses, and this takes into account all of the experiences during the COVID-19 pandemic. And significantly, in the World Health Assembly just held last month, a strategic roundtable has been established to focus on 3 key member state-led processes. The first is a working group on amendments to the international health regulations, which need to get more teeth, I guess, is probably what the concern is. In terms of early reporting, if the initial cases of SARS-CoV-2 were reported earlier to WHO, perhaps at the initial phases with the reproduction number of 2.5, that virus could potentially have been contained. But because of the late delays in reporting, it had got to a point where spread had made it global transmission inevitable. The second is an intergovernmental negotiating body to draft a WHO convention, agreement or international instrument to strengthen pandemic prevention, preparedness and response. And note here, prevention is really important, and that's linking into the animal world, into the whole area of agriculture, of farming, of poultry farms, to try and avoid spillover events. And then thirdly, a high-level meeting of the UN General Assembly. So what we've seen is an unprecedented level of interest and prioritisation of pandemic preparedness and response, both at European level and at global level. And so our project outputs are coming at a really positive time and a fortuitous time in terms of making Europe stronger for a future pandemic. So the background to the research project. So the phase 1 project, and we had our final meeting or final conference here in March 2017 of the PANDEM-2 project. We looked at gaps in surveillance, communications and governance. WHO Euro were on the consortium and ECDC on the advisory board and helped guide the recommendations, of which the key one was that a major gap in Europe was that IT systems to support preparedness and response were inadequate. And we saw that at the beginning of the COVID-19 pandemic, how countries scrambled to try and get their data systems to manage the volume of laboratory data, of hospital data, of mortality data that was being sent to national public health agencies. And we saw a considerable investment then by governments in the infrastructure, which led over 2 or 3 months where it got scaled up. So we were in the fortunate position to be able to work with countries, with member states, with public health agencies, and to do an analysis of the best dashboards out there. What was actually working? What did end users need? What worked and what didn't work? And then the PANDEM-CAP resource modelling tool, this fed into models. This is work done by Professor Jim Duggan at the University of Galway, fed into models developed by the Irish government in response to COVID-19. So our PANDEM-2 project, our partners, we are 19 partners in 13 countries. We have representatives from 6 national public health agencies, the Radboud University Medical Centre in the Netherlands, and 3 first responders. And we're all represented here today. Our budget was €10 million, and we were funded under the Disaster Resilient Society's thematic area of Horizon 2020 security. On our advisory board, we have ECDC, Agrista Baca will be joining us today, WHO, the Irish Defence Forces, 2 colleagues here at the meeting today, and the American Red Cross. The aim of our project is to enable member states to better prepare for future pandemics through innovations in IT and training. The objectives are to identify, map and integrate pandemic-related data from multiple sources, develop a dashboard, pandemic prediction tool, a toolkit for pandemic communications and pandemic scenarios for cross-border exercises and simulations. And we will be presenting this work over the course of today. The surveillance work package led by EpiConcept has developed a PANDEM source database, and that will be presented using data from TESI, from ECDC surveillance system, WHO, InfluenzaNet, social media. Amnia is going to present the social media analysis tool, the work that she's been doing with Paul Butler in University of Galway. Jean-Luc is going to talk about the integration of next generation sequencing and the development of a multi-parametric simulation tool, which links patient data to laboratory data. The situational awareness dashboard, this work has been led by Clarisoft and with the visual analytics team in Galway. So this essentially is a decision support tool for pandemic preparedness and response, collects data on cases, hospitalizations, deaths, testing and contact tracing, and also on interventions. So what works, what doesn't work. Included in this are non-pharmaceutical interventions, and examples of this are stay-at-home orders. We're all familiar with them now. We may not have been 4 years ago. We all know what quarantine and travel bans entail, and border closures. And then most importantly, vaccination. And this was a game changer in the pandemic. So we saw the first diagnosis in January 2020. There was a vaccine available by December of that year. And that's an unprecedented timeline for development of a new vaccine, a brand new vaccine to a virus that was never, that had not been known before. And this allowed society to get back to some level of normality, but it still has had, a significant impact. Pandemic planning, led by Galway with UCL. So Jim and the team, Mart, have worked on predictive modelling, an epi model of disease transmission models to predict progression of a pandemic. Linked to this, a resource planning system to look at what the demands will be on your healthcare system to see how well prepared you are. This can be done in either a response function or as a preparedness function as part of a simulation. Lena THL, Ricardo in INSA have developed a workforce mapping tool, and this is for member states to evaluate themselves what their capacity is in peacetime in terms of public health workforce for emergency response, emergency preparedness and response. And this includes both qualitative and quantitative measures. And UCL team have developed a toolkit on guidelines, protocols and resources on biosafety and biosecurity for first responders, clinical staff and laboratory personnel. So the training and simulation work has been led by Claudia and RKI. We developed 3 scenarios based on real pandemic events, from peacetime planning to response to post-pandemic recovery, in the setting of a public health emergency operations centre in a national public health agency. So there were 3 scenarios. The first was a pandemic influenza scenario, second Ebola, and third disease X or SARS-CoV-2. So we tested and evaluated the dashboard and tools in a tabletop exercise in June of last year in Berlin, and the functional exercise in March, which was done between RKI and RIVM. And we'll hear more detail on that later this morning. And then finally, the operational strategy, and this work is ongoing. We'll be taking the feedback from today's session into this operational strategy, and the plan really is the sustainability of the PANDEM-2 project. How do we ensure we link in with current and ongoing initiatives? How do we build links with eNOTICE and Proactive and the CBRN network? And how do we look at the long-term sustainability of training activities using the PANDEM-2 preparedness platform? And then finally, on communications, this work is led by Fraunhofer with CAR Communications, and that focused on 3 areas. We had a wealth of information from COVID on pandemic communications. So one of the tasks was to look at the area of trust, of disinformation and misinformation, and lessons from marketing and public relations. So some very valuable insights there in terms of how to do pandemic communications, what worked, what didn't work, what could be done better next time. A number of resources and tools will be outlined, and it was interesting to see the work that's done in Proactive as well in terms of communications, crisis communications toolkits. And these again are resources that are targeted at public health agencies. And CAR have developed a media training handbook for public health spokespersons. So that's essentially an overview of the PANDEM-2 project. Over the last 2 days, there were a number of really interesting initiatives that are being implemented by the other 2 projects, the CBRN projects. And I think we have a lot to learn in the area of risk communications, in just-in-time training. I think also the whole area of full-scale exercises. And I know the DG Sante have said that they want to engage in more hands-on, practical field exercises in the health domain. So this afternoon we will be having a panel discussion then to look at the sustainability issues and see what exactly are the Commission's research and training priorities and how we can perhaps contribute to that work in the coming months and years. So I'd like to hand over to Jean-Luc, who is going to present on the multi-parametric simulation tool. Thank you.
Hello, everyone. Good morning. Good morning to those I have seen over the last 3 days, and good morning to those I see today. So I'm going to speak about the design and use of a multi-parametric simulator for integrating patient metadata with the genetic data. And the genetic data, these are the data that characterize pathogens with pandemic potential. So this work I presented to you, but has been developed by my engineers, my collaborators, Jérôme Ambroise and Maxime Bonjean. They are here at the back. They are very shy, so they are at the very far back of the room. But in case you have questions, please address them. But I'm going to present this collective work on behalf of all team, including EpiConcept, with whom we discussed really weekly for 2 years about this development. So we really believe that a step forward in pandemic preparedness and response. Why? Why do we think it is an essential tool for now? That's because you have to realize that, of course, genetic data of pathogens, they are available now. Technologies allowed us to characterize pathogens quite quickly. And we have patients' data. These data are basically produced in hospital and or reference lab, but they are never merged together. You cannot find all this data in one single place. Genetic data are separated from other data, and one of the problem, and why is it so? One of the reasons that was discussed, by the way, yesterday, is the GDPR that prevent us from using, I would say, overusing clinical data. That's to protect yourself, that's to protect myself, that's to protect the citizen. But this has detrimental effect when you want to plug and link together all the data that are available just to ask queries about relationship between parameters. So basically, this prevents us from answering queries like, is this a relationship between a mutation or the genetic evolution of a virus and the efficiency of a vaccination? Can we see if there is a relationship between? We can't. We can't because these data are not plugged together. So this has really a major effect on cross-border response, and we need to do something about it. Having done this long introduction, I'm going to explain in very simple terms what we mean by NGS, so next generation sequencing. These are powerful technologies. Basically, what you have to know that you have an equipment, that is the picture in the middle. With this equipment, we can analyze patient samples. And in the patient samples, the question is there any pathogen? And if there is one, can we retrieve the genetic code of this pathogen? So deciphering the genetic code is a key issue, and this technology allows to do it quite quickly. And all the information, the genetic information that we call the whole genome sequence, or WGS, you get it in one single shot. And with this information, this is very precious because you can characterize the strain, to know the taxonomy, to see the resistance gene, to appreciate how virulent the strain can be. And as Moira stated absolutely rightfully, it also allows us to see if this strain has been genetically engineered, if there is a gain on function, natural or intentional. So this technology is actually crucial. It's not a new one. It exists in 2005, has been used mainly to decipher the cause of human genetic diseases and the causes of cancer. But now, since the pandemic, this has been boosted, and we used it increasingly to characterize the causes of infectious disease. So this is NGS. And with the NGS, we focus, of course, during pandemic on the COVID-19 because that was the pandemic running at the time. So you have in the top right corner representation of the SARS that is basically the representation of its genome. And once you have this information, you know all about the virus. You know exactly all the protein that it produced, so you know how it is going to evolve. This has a major benefit that it allows us to follow the evolution over the course of the pandemic. It also allows us to investigate the relatedness or the relationship between the SARS and other type of viruses like coronavirus that are present in bats, or close neighbors like the MERS, which is affecting Middle East. That's why we call it Middle East Respiratory Syndrome coronavirus. It's a very close friend of the SARS-CoV-2. So you see, this WGS is really something we need when we want to respond to a pandemic properly. It's really a key tool. So how does it work? Without any technical words. But basically, you have an infected patient on the left, and you have the lab represented by this equipment to retrieve the genetic information, so the WGS. What is the lab doing? The lab has not all the information of the patient. The lab has some information, sample identifier, and he is going to produce this whole picture, genetic picture, WGS, and is going to send it to National Public Health Institute. But not all the genetic information. It just will send what is the variant that we identified, just that. All the genetic information related to the virus stays in the database of the lab. So this is already some information lost. And the National Public Health Institute send it to ECDC database, which will aggregate the data. So you have another information that is lost, that's the individual nature of the information. Now you have aggregated data. But the lab has another task, is he can send, and he does send, the whole genetic information to other database. Then CBI, that's the arrow that goes down. And this information is also something we can access, open access, and this is the representation that you probably are used to see. That's the evolution of a virus during a pandemic. So you see already that these information are all there, but never at the same place, and some of them are filtered out in the process of reaching the database. So an example taken from Germany, because we were to the preparation of Claudia and the Emergency Operations Center of RKI to the functional exercise. So I took create artificially a link, and as this database all exists, we see that it's realistically representing the situation at the time. So the scope of our application, we developed, of course, the tool first, and we use different databases, as said already. We tested the simulator with RIVM, which provided us anonymized data, but real clinical data, their own data, and we could plug the own genetic data of the patient, and we could see that it was working very well. But we cannot do that at the European scale, unfortunately. And we used this tool to support Claudia in her functional exercise, as I said. So what to recall about this tool is that it's applicable to any type of pandemic pathogen, not only the SARS. We just focus on the SARS. And we can, with this tool, select absolutely any parameters on Earth that we would like to see in a scenario. So it is an ideal tool to prepare in, I would say, a context of public health emergency of international concern. This is a concept that WHO has put forward, or a CBRN incident. It's excellent for the GITT, and it could also be used in stress tests, as Moira said in the introduction. To illustrate you this very quickly, you have on the left panel a database from ECDC that shows you the variant of concern in a country in a period of time, and you see this evolution. In the middle panel, you have the same, another ECDC database, and there you have age group cases classified by age group. Again, there is no link. The simulator just add a plus. And equal, what you see on the right panel, it is a mixture of different parameters where variants of concern and age group are now visible. So this is something that we can use easily in functional exercise or a tabletop exercise. So the multi-parameter training tool does much more than just linking age and variant, because this was good for SARS, but we need to do more if we want to pretend to be efficient in preparedness and response to future pandemics. So here you see the case of the SARS. Even for the SARS, we can do more. We can do more if we plug other database that are in NCBI database, which contain all the genetic information, and then we connect it to the age of the cases. And because these databases exist and are connected by the simulator, we call it the data-driven simulation. But if you are creative and you want to use data that do not exist, there is no database, but still you would like in your scenario to play with some disease outcome. Let's say a virus affects more young people or more the elderly or a specific comorbidity. Then you create your own database and you can actually run a random simulation. And this allows you also to work on other pathogens and on antimicrobial resistance, which is also a pandemic, and characterize all the pathogenic agent in virulence, resistance, plasmid, all the characteristics that make them nasty. So to conclude this, we train the consortium member as a GITT exercise to the functional exercise of Claudia in February 2023. And we asked the team to learn certain feature of the tool. And then there was a hands-on training activity where we designed ourselves 3 scenarios, and they had to use the tool and use the database to solve the issues. This was brilliantly done. And then we come to the functional exercise of Claudia. Claudia asked, in her inject, this was the evolution of case of H5N1, new agent, pandemic agent, and she asked us to represent the occurrence of a new variant during the course of the exercise, which we did, and you see the occurrence of this gamma variant in yellow. So this is actually applying the tool to functional exercise. Now, 1 minute of video, if I have the time. You can launch the video. You will see concretely what it looks like. I will not comment. I shut up, and you read just the subtitle. Thank you very much.
Thanks very much, Jean-Luc. That was superb. And I suppose one key message is we have lost so much data in the NGS world during the pandemic. You know, some countries sampled 1%, 2%, 5%, but that was just a laboratory sample result without the contextual metadata. So this is a significant innovation and an addition to the tools available to manage pandemic-related data. So what I suggest is we're going to we'll do the presentations and then we'll have a short question and answer session. So at this point, I'm going to hand over to Omnia, who's going to describe and outline the social media analysis tool for two-way communication that was developed during the project. Over to you, Omnia.
Thank you, Maura, and good morning, everyone. I'm really delighted to see as many faces this time as previous meetings. It's very lovely to see you in person again. So today I would like to give you an overview of our journey through social media. I bet the majority of you now are tweeting and sending social media posts about what's happening today and the past 2 days. So let's see what was happening on social media during pandemic. I want to start with a comment I got from the police officer at the airport when I came last night. He said, you're going to give a presentation on social media. And I quote, "It is a bad thing that happened to humanity because with all of this variety of information, you don't know what's good and what's bad anymore." And I agree with the second part, not that it is a bad thing. Besides it's dangerous, so social media is a good thing. But yes, it is with this huge influx of information. You are, especially during crisis or during a pandemic, you not only fight this crisis or fight a pandemic, you fight this influx of information, which is called infodemic. So let me give you a kind of retrospect of what happened back in the Netherlands in end of 2020 and 2021. If you remember this strong word tweets about the lockdown, which was enforced during Christmas. So these strong words means what? Means that people are angry, right? And what do angry people do? They go to the streets. So if we had back then a tool that can measure the temperature of the people, not because of COVID, but measures the emotions of the people and measures the sentiments of the people, we could have avoided such a situation by giving the government heads up of what's going on, to calm down the people, to adjust the message, and so on. And there is another also situation that happened in Ireland. If you remember, a lot of us took the third shot. I bet some of us got really sick, sicker than the first 2 shots, including myself. I swear I didn't tweet about it, but people did. And what happened with a lot of tweets like this? Any guesses? It's still fear. And fearful people will not take the third shot. It's reasonable, but this will not end here. It ends by a lot of vaccines were thrown away, millions of doses, because people did not attend their appointment with the GP or the vaccination center. If we had a tool back then that can understand the language and can understand the fear of the people, we could at least give a heads up to the vaccination center not to defreeze the vaccine, or at least adjust the message again to calm down the people, to tell them you might get sicker than the first 2 doses, but don't worry, it's okay. So what we wanted to do in social media analysis under pandemic is to automatically analyze people opinions, to analyze opinionated text on social media, on Twitter, on Reddit, on variety of platforms, to understand sentiment, so what people like, what people dislike in terms of positive things and negative things. We wanted to take this also deeper into emotions, what people are afraid of, what people are angry about. Do they have joy? Do they have trust? And then we wanted to analyze suggestions, so people can suggest to you what is the best place to buy Belgian chocolate here in Brussels, or they can suggest, please speed up the vaccination process because we want to open schools. So you want to listen to what people suggest. And finally, we wanted to understand topics, or let's say subtopics, because the main topic is, for example, COVID or specific pathogen, but subtopics could be vaccination, could be lockdown. In the avian flu exercise, it could be farms or could be eggs or something like this. So our goal here is to help understand reactions to government measures. So some government enforce some measures, so we want to understand the reaction to those by the people. And we also want to support two-way communication between public health agencies and government authorities and, of course, the citizens. And this will take me to what is two-way communication, and probably my colleague at car communication will talk better about this, or even Benjamin will highlight this, that in two-way communication, it is, as the term says, it's two-way street. You don't want only to send messages, you want also to receive the message to make sure that your message was understood and adjust accordingly. So you want to ensure that you listen to the citizens and your citizen listen to you. So what is this tool does in a nutshell? I mean, on a high-level technological thing. So it's kind of give me a text, I will give you an output. So we have our magic toolbox here, but you give it a text, any sentence. And by any text, I mean any social media text, for example, Reddit post, tweet, even we support news headlines. And for the last couple of months, we also supported multiple languages. So we now support 7 languages for analysis. So any text, any language, that's cool, right? And you will give an output here. So we cannot reshare the text because of legal and GDPR issues, but we will, to keep track of the posts, we will give back the post ID. We'll give back, is this tweet or is this sentence contain a suggestion, yes or no? What is the identified suggestion? Because you are busy, you don't want to sift through millions of tweets, you just want like touch and go on what is the suggestion. What is the sentiment of the people? Is it positive, negative, neutral? What is the emotion of this tweet? Is it angry, sad, disgusted? It's very strong emotion. And finally, what are the subtopics? Is it lockdown, vaccination, mental health? So let me give you an example. I'm sorry for the angry tweet, but I didn't write it. It was during COVID in Ireland. So it reads, the government in Ireland are doing a job altogether, vaccine everyone at this stage and get Ireland back up and running. Lockdown till May, how about you open the gyms for people who need them for mental health? Lockdown, Ireland, Dublin, mental health, COVID. So what the tool will give you, it will give you the post ID. Yes, this tweet contains a suggestion, and the identified suggestion is vaccine everyone, open the gyms. The sentiment is negative, of course. The emotion is anger, anticipation, because they want the government to do something, and disgust. And the aspects here, or the subtopics, is vaccination, lockdown, and public health. And public health covers the mental health thing. So what this tool would offer you as member states. So let me give you a scenario. Suppose that the Ministry of Health in Germany asked RKI to write a report on vaccination in Germany, like to track what people liked, what people disliked, emotions, and maybe this could lead to misinformation detection. So what people in RKI do 2 years ago, they would meet, I mean, given the COVID restriction, sift through tweets or public social media posts on Facebook or Reddit, because some of them are private, you can't access them. They will sit together wearing masks and trying to analyze these posts manually, of course. They might use something like commercial, like Sprout Social or TweetDeck. They will just help with giving some keywords like hashtag COVID, hashtag mental health. They have to come up with these keywords by themselves, predefine them. And again, it is a commercial tool, so maybe legal department will say, no, sorry, I will not finance this. But now what they will do, they will just log into the Pandem dashboard and go to the social media page and just analyze the top 10 topics and go to vaccine and analyze the emotion and sentiment around this. They can even during a specific period. So now, because we are after COVID, they can sift through the whole 2 years of COVID. They can analyze all emotions here. You can see several spikes in this chart. I'm sure Claudia could help me here. So One of them was during the release of the vaccine, and there was a slowdown because Germany wasn't getting enough of it, so there was a mixed emotion. Most of them were angry and sad and anticipation for the government to do something. Another one was during Easter, and people also was not getting enough vaccination, and with the lockdown was enforced just before Easter, people were angry. And finally, this little spike here was when we were about to vaccinate children, so also people get a lot of mixed emotions. So Claudia and her team can analyze this chart and relate to what happened, because this is, a retrospect. But during COVID, during a crisis, they can see the spike here. I'm not sure. Oh, sorry. I thought I can use. So she can see that there is a rise before the full spike. So she can analyze, and the team can analyze the tweets there or the social media posts and start adjusting the message and start acting upon it. The team can also check suggestions. So what people suggest, like prioritize vaccination for elderly or for children, open school, and all kind of suggestions. It will be really helpful also. So what if, and we have seen this in the functional exercise already, Germany wants to compare herself with its neighbor. So they will collaborate with RIVM and maybe send this report to the ECDC. What should they do? So back 2 years ago, they couldn't fly to meet each other. They will just meet via Zoom or something and start analyzing things the same way manually and sift through millions of data entries. But nowadays, what they will do, again, each member will just sign in as a dashboard, and they can compare both countries together in terms of emotions. So if I will pretend that I'm a pandemic manager here. So in the Netherlands, as you can see, and you can help me here, this is during the lockdown, the enforced lockdown. So you can see kind of a steady anger signal. But in Germany, it was just spike in July, and I think it was related to something for AstraZeneca or something. I'm not sure, but it was related to a certain event at that time. So Netherlands can relate to what's happening in Germany, why they have kind of less angry people, and they can adjust the message or learn from them and so on, so they can help each other. And they can export these images to a report and send it to the ECDC. Other countries can do the same. For example, we can track the difference between sentiment in France and in Ireland. As we can see here, there is 1 or 2 spikes in France about the COVID topic in general, but it's kind of, downfall in Ireland. So we can also, as public health agencies, relate what's going on, or as a government official, we can relate what's going on. Another thing is that we added recently is you can add a non-pharmaceutical intervention on top of the signals you have for emotions and sentiment. So you can relate with, for example, mask wearing or school opening and so on, and put this nice chart on top of each other to compare, okay, during mask wearing, there was a happy phase, but then when we enforced lockdowns, there was an angry phase again. And one important thing that you can track trust also, like spikes of trust in government opposed to non-trust. Let me give you a quick overview how we did the development of the tool. So we started, it's kind of a pipeline. We started with data preparation we used various benchmark existing data sets from Twitter and Reddit. We also sampled our own COVID data because COVID was a use case for the tool. We did the development on various stages for classification, for aspect mining, for suggestion extraction, and we used deep learning and most state-of-the-art models. We did evaluation on a technical level, either quantitative evaluation using some technical measures that we use in natural language processing and AI, or qualitative measures by getting a piece of the data and staring at it, see what's went wrong, what's went right, and why. And then finally, we shipped everything to our colleagues at CAR and to the VA team in order to employ them, at Clarisoft, in order to use them as a back end for the dashboard. And then so our colleagues were able to integrate this, and I will also show you the journey of the tool during the integration. So you get the tweets or any social media platform using the API. So Francesco here can just plug in the API. And then he will run the magic of Pandem source, like pre-processing, geotagging, and so on. And it will come to us. You will just plug the text in, and we will give you the output. This output will be back to Pandem source for aggregation, and these time series will be given as a backend for our colleagues at Clarisoft, and finally for the VA team to see this very nice look on the dashboard. So I really thank all my colleagues for their collaboration. And then out of this, we have our standalone tool as well. So it is not only plugged into the dashboard, we have our own tool, because it depends all on the data. So if you have new chatter about avian flu, we needed to adjust this. We needed to retrain the model. So we thought to give your IT team kind of a package tool to allow this. And it will also was selected as part of the exploitation. So what is the future of this tool beyond Pandem-2? So it is not only tailored for public health or for pandemics. It could be used for any public health emergency, and also for the CBRNE. So it is any kind of disaster management. It is not only for the pandemic disasters. And out of this, we were able to we were able to plug the same thing into urban development project in Ireland. So we are going to use the same tool to track what people like or didn't like, or how people see the future of Galway City. And also we will be working, so starting in September, we will be working on kind of a holistic tool or holistic approach for social media language analysis, including misinformation, because working with you, I learned that misinformation is a request that you want to track automatically. That's basically it from my side. I will be happy to take questions after the session. Thank you so much.
Thanks very much, Amnia. And I think it really was a team collaborative undertaking among the consortium. So well done. I think what's very clear is that, again, big data is a hugely valuable resource for future pandemics, and it has applicability not just in a pandemic but also a CBRNE event. I think that there's certainly a lot of interest among public health agencies, and one of the comments that Cynthia from DG Sante made yesterday is that really it was up to us also to go back to our member states to see what the utility is, the potential utility of the tools that we use. So I think it's something we should commit to over the course of today, to go back to our public health agencies and actually see, well, what can the SMA tool, how could be further developed to provide that kind of information. And I think not only is it useful for CBRNE and pandemics, it also is valuable for vaccine programs, strategies on obesity, diabetes detection and treatment. So there's huge potential there to monitor what is actually how your population is responding to government strategies or government plans. Okay, so what I'd like to do is hand over to Benjamin from Fraunhofer INT to discuss pandemic communications, lessons learned from COVID-19.
So thanks. I'm going to get started here. So I'm going to talk briefly about our take here on pandemic communications. We heard quite a bit about this yesterday from the previous or the collaborative projects about risk communication. So this is work we've been doing at Fraunhofer, and with the strong support of CAR Communications, Trilateral, NUIG, and with the strong support of a lot of our end users, many of which are here in the room. So I just wanted to briefly, we heard quite a bit about risk communication, as I said yesterday, but I wanted to invite you to go back in time for a second and think about the beginning of not just the COVID-19 pandemic, but also previous outbreaks, where the communication, the information flow in the beginning was really an essential and crucial thing. So I think in many ways, when we're thinking about the SARS outbreak in 2003 and the Ebola outbreak, The most dramatic risk we've been facing here in Europe was actually linked to communication and less so maybe to the pathogen itself. So this high uncertainty, this feeling of rapidly evolving facts, that induced a lot of fear in the population. So here it was really important and essential always to really like jump on this communication issue. There was fallout, particularly in 2003, remember that, of discrimination where people were marginalized, looking Asian or things like that. So these are the things we need to be aware of and do better. So this really highlights the central role of communication strategies in the public health response. So this is kind of what we did in the very beginning. We've been inviting our end users to identify with us like what needs to be avoided. So in a workshop we start with this a bit ironic take on this by collecting negative examples. So we've been like creating the communication failure in a hypothetical country in Absurdistan, and we've been like really like collecting like what is it what we need to avoid at all costs. So like in general, like what we've been prompting the topics of two-way communication, as we heard just before, and trust, and what is it we need to avoid at all costs. So like if you have a negative or no relationship at all between public health and the public, then you're really gearing up in the wrong direction. If you're sharing only ambiguous or not univocal messages, it's getting complicated. Not being transparent in your decisions and processes is an issue. Only communicating in scientific terms is a real problem, and not responding directly to the actual fears and concerns of the public. And if you're not communicating in time or not communicating at all, it's you're also like giving room for misinformation. And if you're not actively contesting it up, that's going in the same direction here too. So our overall aims were to create some practical tools for pandemic communication and to really like look if there's novel concepts for two-way communication, but maybe in the social media landscape as well. That was one of the ambitions. And then how to make it useful, how to actually train stakeholders in effective communication. So I'm not going to go into our workflow here, but in general, we've been looking into a conceptual phase, state of the art in the beginning. We've been moving that to a practical phase where we've been like trying to create resources and test these resources in a training phase. And all that meanwhile, we've been like looking in innovation phase, like what else is out there, like particularly in this when to interact with social media. Overall, I think we've been here focusing on non-technical solutions that might be important to highlight. So in our state-of-the-art analysis, we've been looking into a number of different directions. So first it was a structured review of existing literature, and we've been also like building on the pandem phase 1 scenarios, which were resolving around Ebola, influenza, and SARS. And we've been looking at existing tools. So at that time, for instance, there were contact tracing apps of COVID, which were of relevance. We've been also discussing guidelines from civil aviation, which has this communication ready-to-go packages and whenever there's a disaster. And we've been looking at what all the other Horizon 2020 projects have been doing and which directions they were identifying. So we've been then trying to really summarize this in what we've been then calling knowledge bases. So we've been creating one around how to establish trust and maintain trust. How to combat misinformation. Misinformation here being the deliberate spreading of wrong information as opposed to disinformation, which is just unintentional potentially. And we've been looking into lessons from public relationships and marketing. So like what can we learn of how to communicate? And then we've been comparing it to also like what's out there, what is actually the applied practice, what is it our end users are doing, what lessons learned they can share with us. So one of the things we use to group and these different informations there is that we've been like looking at the preparedness cycles. I mean, there's a number of different versions of it. Here we've been focusing on preparedness, response, recovery, which is an overall familiar concept here. And we've been then identifying with our end users a number of like talking points, for instance, like how important it is to have a well-trained media team, how important it is to have like a core team, which you can potentially expand then, for instance, for contact tracing in case of a disaster event. And during response, like how important it is to have good infographics, but really to maintain good working relationships with the local healthcare, and how to reach out to minority or vulnerable groups. And in that moment, we've been then really discussing heavily like that we're having a problem of defining the end of a pandemic and how to really engage with the public to avoid pandemic fatigue. And just to bring this up here, that was then something we've been discussing in the aftermath of it quite a bit, is that a pandemic is like particular because it has these numbers of different waves. So while, and that has impacts on communication. While the population feels like we are over the hump, we're like the numbers are going down and we're now gearing up for recovery, summer is coming, everybody feels like they can let go a bit. The hospitals may still be very much in response. There might be still people for months on breathalyzers and just need to have care, continued care. And in public health, you may have people already who are actually in a preparedness phase because they're preparing for the next wave to come. And this can very easily create a communication disconnect. Just to briefly show a bit like what our knowledge bases are, I just pulled a few talking points out of them and grouped them here now by the different pandemic phases for the different knowledge bases we've been establishing here. So that is that, like in the preparedness phase, how important it is to really build these active relationships with the public. This is the trust you're banking on, and when in case of a disaster. How to generally promote fact-checking tools and overall education, that people are actually understanding what you're trying to communicate, and the importance of having communication experts really included in your response teams from the get-go, from the beginning. When you find yourself in a response to an outbreak, then it is how important it is to have these clear and evidence-informed messages, but to really acknowledge your uncertainties, like your facts may change, and it's going to be very important for the public to understand that you are communicating what you know in that moment. How important it is to engage with local community leaders to really like become facilitators to spread the information, and to have these core principles at your disposal of like how to set up messages and have like consistent messages you can use then. And in the recovery phase, how important it is to continue the public engagement, to continue having this trusted relationship, to evaluate your audience interactions, but to really also communicate what you're doing to the public, like how you are looking at recovery, what your next steps are to improve your response the next time around. Yeah, I want to just briefly also bring this up, like to look at a bit like the larger landscape of like international responses. I mean, there's a lot of negative examples. I don't think we need to get into those too much, but we had across the Atlantic a number of countries where politicians were actively contradicting the public health communication, particularly in populist-led countries, and that created like the very well-known fallout from that. But we did had like a number of countries which did a number of things quite well. So we've been looking at the case study of New Zealand as well, where we've been like just recently discussing again. They had very simple, very clear recommendations. That was like in terms of like what's happening, what needs to happen. They were not talking about like, well, we're in preparedness. They were talking about like, we need to plan for it. They didn't talk about cluster control. They were saying stamp it out. And these things, like to really like select this very easy language, made it very accessible. And in addition, for instance, they've been like creating this traffic light alert system, where it was very clear, not like, oh, we're like adjusting slightly the next step, or maybe masks indoors, or in Germany it was 2G, 3G. That was very complicated. Here they've been like really going with the system. We are now like on yellow, we are on orange, we are on red, something like that. And it was very clear then what that meant for the population. So these versions we've been looking at, and what we can learn from that, and which kind of recommendations are coming out of this. Here in Europe, we also had obviously like communication at the EU level, and we had communication at EU member state level. And very recently we were discussing this again, that we have a different structure in the public health systems here in the European member states. And some are more centralized and some are more decentralized, and that also has an impact on on communication. So particularly now when you have a decentralized structure, the people who need to communicate are not necessarily just the very well-trained core personnel at the federal level, but it might be really local healthcare which needs to communicate, and they need assistance. And we've been also trying to come up with something with that, like to assist them in their work by helping them identify like what are the stakeholders around you, what's your stakeholder landscape. So how do you ensure that everybody else who needs to get information from you will find you? How do you know like who to approach? It's as simple as like really having updated phone lists of your neighboring communities and knowing like who's going to be responsible for what. How to support agencies or first responder organizations around you also with action plans. And then we've been creating a number of guidelines and templates of like how you're actually going to set that up, like press release templates, how to create web information, how to set up a social media strategy, the importance of FAQs and helplines, and that's something that we've been discussing and validating with our end users in our consortium. We've been also like trying to bring this then into the demonstrations, so like these hands-on templates, so that these decision trees, the importance of stakeholder context to like when you should start a communication, so like what are the communication triggers, press releases, and also press conferences, how to set that up in interview situations. Another thing we've been looking at was like really the overall role of social media interactions, because I think during COVID-19 it was very prominent, very clear that we had a number of influencers. Here we've been more coming to the term of key opinion leaders. With influencers, we didn't mean anybody who's sharing beauty videos on TikTok. We were talking about the people who are like sharing information relevant to the COVID response. And we've been trying to identify a number of those across European countries, and like by following and how well known they were and how influential in respective countries. And a number of them we were actually winning for interviews with us. So we've been really wanting to know from them like what their take is on how to build trust, how they deal with misinformation, what things they use to actually really ensure a two-way communication with their audience. So that could be like by really like having Q&As on a radio show, or by actively really engaging with their audience in social media. So this was for us to really get a bit of an outside view on the public health care communication, and to really identify with them like where they saw gaps, what prompted them to actually fill a particular role. So we had some experts here from Portugal, the Netherlands, and Ireland, with which we talked, and then we've been inviting some of them back to talk with us, in a workshop with our end users, to identify like if there's particular lessons learned, or if they see different communication needs, and overall like how we can strengthen two-way communication. So I'm just bringing up a few talking points. I mean, again, it was highlighted like how to have like clear and simple and very consistent messaging. The timely responses on social media was also a thing that was for me very interesting, that one of the interviewees said that she realized a lot of the social media interactions and discussions are unfolding in the evening, so after business hours. So she's been like at 8 o'clock when everybody else was at home, she's been like really trying to engage in discussions before they branched out in a particular direction. A lot of them were saying that they found themselves in this role by just giving basic information to really like improve science education, really. What is a virus, what is a vaccine, and found themselves in this particular role. And others were saying to us that like for them it was also like really to provide data and data transparency, to make sure that like the data was continuously available, that the decisions were transparent, and that this was another role they took for themselves to support the public health communication. And in general, like they were saying, like, well, they've been really finding themselves to reply to a lot of questions, to really give the evidence, to really link in scientific articles, but also really to give hope. Like a lot of people were engaging in these conversations out of fear, and it was really like a matter of also like sharing, a positive outlook as well. And I think that this is like what's been quite interesting for us, like how to utilize these external communicators, because they come in a complementary role. Like public health is often bound to give particular information, and it's not easy or not good to publicly contradict political decisions, whereas like an external communicator can position themselves a bit differently. So it's not just important to like how you communicate, but also like really who you can win to communicate with you and for you as well. I'm briefly just going to brush this because I said we were going to training and demonstration, but we're going to hear a bit more about this from Ima later. But obviously we've been like looking at the importance of training these media interactions as well, like when you are really put in the spot and need to engage with in interview situations with the real media. So this action learning was then tested and had like particular number of techniques were trained to how to control the interview and like how to mind potential pitfalls and have like your opening statement, your outgoing statement. I found that very brilliant, but Ima is going to talk about that a bit more. And this training was then also brought back to our demonstrations, so tabletop exercise and function exercise. So how to give information to the public, to just be like that tangible, how to compose press releases, have interactions with the public on social media. We heard about the SMA tools just before. And yeah, to your role of addressing concerns and fears and really like setting up and hosting a press conference. So yeah, just as an outlook here to finish maybe, I found that very interesting, as I said, this particular role of external opinion leaders, and I think there's something we can definitely look into more. So like how these non-governmental influencers actually rise into popularity and influence public opinion, and why and how they actually establish themselves as an authority as well. And what lessons we can really learn here to improve the communication of public health during a crisis. And the second point, I think, is I just wanted to thank everybody from Proactive yesterday for this beautiful white paper they shared with us, which is summarizing risk communication on a very good level. But I looked at the conclusion, and the conclusion is beginning with many of these recommendations are not new. And that is true. I think like a lot of those things, like you come to very familiar grounds again and again. So what we need to continue looking at and research on is like what are still gaps in communication? So what has been repeatedly suggested, but what is lacking still implementation and why? I think this is really like a direction we need to explore more. So for us, I'd say like it is really important to continue training, to retain the knowledge we had now, and particularly after COVID. And maybe like a regular training day will be important. It's going to be very important, I guess, like when there's like a generational shift from in a number of institutions to really make sure these lessons learned are retained. And that can be done via regular training, I think. And also like what we've been also hearing a lot when we are looking at the function exercises and the tabletop exercises, how important this cross-border aspect is for a number of organizations to really train this. Comparing communication between countries, I think, can be an important part of it. But to continue looking at like finding maybe a voice between the different EU countries and finding a shared communication strategy that could be of huge advantage in the future. Yeah, thanks. That's for me.
Thanks very much, Benjamin. I think one positive thing is that we've seen our communication structures in member states, in public health agencies, have been invested in considerably. So there's a lot more experienced spokespersons out there in the public health world, but that experience needs to be tested and needs to be repeated in terms of exercises. We can't just say, you know, we have 2.5 years of experience of a pandemic. That experience can be lost unless there are repeated exercises or stress tests. So I think that's something we need to look at. In terms of gaps, one of the gaps that was raised over the last 2 days, on day 1 and day 2, was the communications with vulnerable groups. And I have to say, I think within the CBRN community and within pandemics, we actually have overlooked that area. So you assume when you do an exercise, you do it with volunteers that are between the ages of 18 and 50. You don't bring children, adolescents, people with either hearing difficulties or people who are blind or people in wheelchairs. So again, communications, both the communications with the public, they need to take into consideration language issues, cultural issues, and then issues of disability. So I think for future pandemics, we need to be looking at the research question, how to better engage with vulnerable groups in future pandemics. So I'd like to hand over at this stage to Lem, and Lem isn't here with us today. If you're online, hi Lem, and I'm going to ask the IT guys to, we got a video clip. Okay.
Hello everyone, I don't know if everyone can hear me. Good morning to everyone. It's a pleasure for me to be able to participate in the conference today. Unfortunately, I wasn't able to be there in person, but I want to express my gratitude to the coordinators for allowing me to be able to present online. So I'm Lem, and I'll be talking about social, legal, and ethical considerations for pandemic preparedness and response on behalf of the team that carried out this work. So just a brief background, COVID-19 brought many lessons about the impact of pandemics on society and the implications on public health, on economy, on healthcare systems. And it's also important for us to understand that the consequences are far-reaching and extend beyond public health. Most of the time we think about pandemics in the context of the biological and the medical implications, but it's also really crucial to consider the social, legal, and ethical implications in addition to the medical and scientific aspects, and that's what I'll be talking about. So before we go into these issues, I wanted to start with some definitions. Social considerations include things like how pandemics affect different vulnerable groups, vulnerable populations, the mental health implications, and also the ways in which different communities are engaged during pandemic response. On legal issues, this involves things around legal frameworks for pandemic response, including privacy, data protection, liability, and accountability. And finally, societal impacts, ethical impacts, look at things like the allocation of resources and the application of ethical principles, including fairness, equity, and how we balance between individual rights, the public goods, and also things relating to research ethics in general. So starting with social considerations, one of the main lessons we learned during the COVID pandemic is that pandemics do affect some certain communities more than others, and it widens the inequality gaps between the general population and these groups. And some of the we identified 4 priority vulnerable groups in the context of pandemics, and these were healthcare workers, older adults, people of migrant origin, and people with disabilities. And pandemics do affect various aspects of their lives, and there are challenges to their physical health, physical well-being, as well as psychological challenges, things like isolation, loneliness, fear, grief, and uncertainty. And so it's very important to be able to take into consideration the social determinants that contribute to these inequalities and contribute to these increased impacts of pandemics on these vulnerable groups. And that includes things like their vulnerability to illness, their access to healthcare and resources, cultural factors, their living conditions, their working conditions, their language and communication needs, and their access to technology. So it's very key, it's very important to prioritize the needs of these vulnerable groups and to promote equitable access to healthcare, and also to integrate mental health support into preparedness and response plans. In the COVID-19 period, some of the lessons that were learned as well were how measures like social distancing had adverse mental health impacts on these groups, leading to things like loneliness and several other mental distress. And also, community engagement and trust is very crucial. So it's important to engage with the leaders of these different population groups to understand, to identify and understand the needs of the different populations and incorporate this into response plans. For healthcare workers, one of the main things that came out was that we identified was occupational risks that they face during pandemic. So they're usually at the forefront, being exposed to high levels of risks to infectious diseases that can have adverse impacts on their health. And they do have a duty to care for populations and to provide care in their line of work, but it's also important to have a balance between their duty of work and their personal safety, and recognizing that strengthening healthcare workers can contribute to a sustainable healthcare workforce. So it's important to prioritize the mental well-being of healthcare workers and to recognize psychological factors that can contribute to their ability to provide care during pandemic situations. On legal issues, legal frameworks they are very helpful in outlining the responsibilities of different authorities and governments, public health workers and healthcare systems, and actions to take during pandemics. And another lesson that was learned from COVID, for example, was the role of robust legal frameworks in ensuring security and safeguarding both individuals and communities. And the goal of legal frameworks is to enforce and encourage behaviors that promote public health and address the risks posed by pandemics and infectious diseases. And EU agencies play a key role in guiding the development of these legal frameworks. They help in facilitating the coordination and collaboration amongst member states. So during the pandemic, we identified there were lots of challenges that came about in different countries across the world, and which can be addressed by legal frameworks. So some of these challenges were around issues like surveillance, quarantine, travel restrictions, and the implications of these on individual rights. And there are legal frameworks that do exist to address these issues, but some of these legal frameworks are not legally binding, and there are also some legal frameworks that do not have any formal sanctions for non-compliance. So one of the key lessons around legal considerations was the need for cross-border cooperation and coordination, and the need to strengthen existing legislations around these issues, including addressing actions that can be taken in situations where there are breaches, negligence, or misconduct. So several actions have been taken both at national and EU level already to guide decision making and to guide the legal considerations and legal sanctions concerning these issues during pandemics. But also there are still some gaps that need to be taken into consideration and need to be addressed. One of them that we identified in this work was the need for a comprehensive legal framework at EU level, defining the scope and limitations of emergency responses during pandemics. And also, it's well documented and well evidenced that there are strong GDPR legislations in place, but there were still challenges with things like contact tracing, data sharing, and there's a need for further clarification and guidance around GDPR to balance public health needs with privacy rights. And there's also a need for legal clarity in decision-making, and that includes clarity around the roles, responsibilities, and powers of national and EU institutions, and how to ensure transparency and establishing accountability mechanisms. And lastly, one main challenge that we identified, and that also had implications as well on the PANDEM-2 project, was around data sharing and cooperation between member states in sharing of resources, and there's a need for more legislations to be able to encourage these practices during pandemic preparedness and response. On ethical considerations do play a key role in guiding decision-making processes, and ethical frameworks are essential for ensuring fairness, for ensuring transparency and accountability. So there's various ethical principles that are being taken into consideration in different member states. So the image on the right shows the different ethical principles that we identified as key in different studies and in different frameworks. But we also identified that some of these ethical principles are conflicting, and that makes decision-making challenging and inconsistent. So there's a need for an ethical framework to guide decision-making and to provide guidance around which of these principles are priority to take into consideration during pandemic preparedness and response. Some examples of areas where ethical principles were conflicting were around the allocation of resources and how to balance between individual rights and public benefit. So this is just a summary of the main issues that came up on ethical, legal, and social issues. Around legal issues where the availability of adequate legal frameworks to support legislative preparedness and resource mobilization, and also the coordination and harmonization of legal frameworks at national, regional, and international levels. And as I said before, on social issues, identifying the needs and prioritizing the needs of vulnerable groups, and communicating with these groups, and also integrating mental health support in pandemic preparedness and response, and engaging with different communities. So we developed some recommendations based on these findings and discussions between the project team and various stakeholders that took part in this work. So on ethics, a main recommendation was the need for an ethical framework defining priority ethical concepts. On social issues, the consideration of the needs of vulnerable groups and pandemic communication, ensuring that it's clear and consistent and engaging different stakeholders. And on legal issues, strengthening legal policies and ensuring consistency across member states and internationally. And two other recommendations were ensuring that tools and used during pandemic preparedness and response are constantly evaluated, and continuously doing further research to ensure compliance with these ethical and legal standards, as well as social considerations. And also taking steps to educate the public on the complexities and the realities of pandemics, the complex nature of good pandemic management, to enhance their understanding of pandemic decisions. And in so doing, it could help in promoting adherence and encouraging the public to adhere to measures that are being taken during pandemics. And so just some final key messages around these issues. The consideration of ethical, legal, and social issues is essential in ensuring that we're able to take a comprehensive and effective approach to safeguarding individual rights and promoting social cohesion. This also helps to cultivate a sense of trust, to build trust, inclusivity, and shared responsibility, and also to enhance cooperation. And finally, being able to address these issues requires a multidisciplinary approach between different stakeholders, and also requires taking a whole of society approach that prioritizes the health and well-being of all individuals and communities, both during pandemics and beyond. Thank you.
Okay, thank you very much, Lem. Thanks online, and it's a pity you didn't make it here, but that was a really useful overview of ethical, social, and legal issues during a pandemic. I guess this was an issue very much to the fore, the legal underpinning of pandemic measures. Many member states had to scramble to put legal mechanisms in place to allow quarantine or travel bans, and we saw a constant dilemma between protecting the health of a population and ensuring individual rights to freedom of movement, for example, were protected. So it was a challenge, and I think The work with the Commission now with Member States will be updating our response guidelines to ensure that we take the social, ethical and legal issues, that they are updated. So we'll do it better next time around. It's good to see the work on vulnerable groups that it's been addressed. And again, these are all potential areas of work for future projects. And I think on the social side of it, we saw a number of minority groups who really struggled during the pandemic in terms of the burden of disease, in terms of lack of access to care, in terms of vaccination uptake. They suffered a much higher burden and impact. So again, that's something we need to be looking at for the future. And the whole of society approach, we've some member states who, had a very different approach, where other countries had very severe lockdown measures with severe restrictions on people's mobility. So what I'd like to do at this point is open the floor to questions. So there are 2 microphones. There's one there and one there. So for people online, so they can hear you, would suggest that you use one or the other of the microphones. So we've only time for 2 or 3 questions, I think, because we're going for coffee in 5 minutes. So if there are any questions from the audience, Anders.
Thanks. Very nice presentations. Congratulations. And it's really impressive to see the total of all that's been done over the years. I'm especially happy that you're bringing up the legal and ethical issues, because I think they were really the most difficult one during the pandemic. So I think that's really good. And 2 questions really about that. I mean, we often talk about ethics in healthcare, and there is often quite good sort of ethical platforms in healthcare, but not so often when it comes to public health. And if you have any thoughts on that, how we can move that area further. And the second one is really, and that's also connected to what Jean-Luc has been doing, this very problematic question about how much we can combine different data sources, and to what extent is, for example, the thing you have done now, Jean-Luc, how well is that sort of scrutinized by legal advisors and so on? And what do you think is going to happen to the new EU suggestions on the EU data space? Thanks.
Well, difficult question, Anders, but we debate about this yesterday, and with DG Santé and DG HERA, they were there. They're still there today also, but maybe not exactly the same people. But one of the conclusion was that GDPR, of course, it is something that's like a major protection of the citizens' personal data and should be kept as such. But in a time of crisis and pandemics, this slows down, and this really prevent people from sharing essential key data. So we have certainly to revisit the GDPR to keep it, but amend it maybe in exceptional situation, and see how to compromise and balance the right of the citizens to be protected in terms of personal individual data, and the public health interest to share some of these data, just to protect the citizens as well against the bad effects of the pandemic. So, protecting the citizen is not only protecting the data, it's using the data to protect themselves, meaning designing better prevention strategy or better therapeutic strategies. And for therapeutic strategies, we need, for instance, genetic data. We cannot progress if we do not exploit the characteristic of a pathogen that is a pandemic pathogen, and we need to follow this up. But these bring really valuable information that were absolutely not exploited during the COVID. The only thing we had was variation and evolution of variants across the time. That's absolutely not enough. And we could do much better, because all the data are there to link this evolution, genetic evolution, with the impact in terms of public health on the population. and in terms of mortality, and in terms of hospitalization rate, and in terms of who was finally the most affected by different types of variant. Was it an evolution in the target group? Could have been, but we were totally blind. We still are blind, simply because this connection between real data, they do not exist. And they do not exist not only because the GDPR, of course not. This needs to be organized. But GDPR didn't help, actually, to really manage properly all this bunch of data. So billions of genetic data have been produced, billions of them. It has never reached that scale before. And NGS is now something that not everybody can do, but everybody understands the needs of it and the benefits of it. And still, it is totally unexploited for the moment. So in the next pandemic, I think that this is not only me, I mean, everybody thinks that if there is an improvement to be made, that's in connecting data better and allow our researchers to answer queries that are crucial to better protect the citizen. Am I answering your question?
Thank you. On the issue of ethics, I think the area of resource allocation was another gap that we need to be looking at more carefully. Issues around ventilators, around patient care, even the initial distribution of the vaccines. There were a lot of ethical questions about how were certain groups prioritized and others not. So I think there's a body of information and experience there that will feed into the work of DG HERA and DG Santé, and our role as a research project is to make sure these issues are highlighted. Because as we all know, within political systems and within our governments, there's a whole move now to move on. It never happened. It's like our war in a way. So the ethical issues of, they always were at the bottom of the line, and the work that Richard Coker did and presented here in phase 1, all of the issues around ethics and the lack of ethical frameworks underpinning pandemic preparedness plans, that was demonstrated then at the outset of the pandemic when we really were scrambling to ensure that our measures and government interventions had an ethical approach. So it's work in progress. Any other questions from the audience? Yeah, Alma?
So is this only on the legal presentation or everything?
Everything.
Right. So I had a question for Omnia that I was thinking about while you gave your excellent presentation. So thank you for that. It was really interesting. So you presented an example of how you used a case of the COVID pandemic to sort of retrospectively predict some events like the riots in my country, which were very impressive. But my question is, do you also have an idea on how you might be able to use this in a prospective way? So I can imagine that you could get very much false signals. And if you would like to predict, it's one thing, but I guess you want to predict in order to prevent. So how is your expectation of the prospective use of these social media analysis tools?
Thank you so much for your question. So there is kind of two parts to answer it. The first one is that initially the tool was developed to work on real-time data. So what we did is kind of test it on COVID because it is a use case. But when we are in a new pandemic, you will have an influx of data coming in from different sources like news headlines or social media platforms. And the data will be coming to the PANDEM source through the dashboard. And then with our tool, it will analyze all the 4 signals of sentiment, emotion, suggestion, and topics. And then maybe the only thing is how to detect the aspect, but we provided this standalone tool to kind of retrain the model for new incoming data. Like, for example, for the avian flu, we can just retrain these models to get subtopics, but everything else will remain the same through the dashboard. The other thing that you mentioned, it is in retrospect. So now we can kind of relate to what's going on because we have a huge amount of data from COVID. So this is why we just get it as a use case. The second part is about a false signal. The current evaluation is, as I mentioned, is from a technical point of view. So we just run the model, see, for example, get 80% accuracy, try to check what's went right, what's went wrong. But we are currently researching different kind of validations. And of course, with the help of you, we might, if there is PANDEM-3 or in future projects, we will ask you or make a survey. What do you think is a validation process, is a correct validation process to trust the tool to give the correct, or let us say the absolute truth outcome. Yeah, so it's kind of still research from the part of if it give a false signal or not, and also the validation part. But for the real data, yeah, so right now it can work on real data. So it is just give it a data and press a button and it will work. Yeah.
Okay, thank you. Francisco?
Yes, is just trying to comment into the question about the European health data space. I think, so the European health data space is going to be a place where primary healthcare data is going to be stored and is going to be able to be reused for secondary purposes, which is I was looking here in the definition of the European health data space, mainly for research and for policy making, but actually the surveillance part on the European health data space is not already clear in my opinion. And I think it's going to be a key element that public health surveillance is done using the European health data space, because this is going to solve the GDPR issue about sharing data. So a public health agency could connect to the European health data space to do surveillance based, by example, on electronic health records. And I think that the idea is great. You can go to the data, do the analysis, but in order to data to get there, we need clear governance about, like, people is going to be able to say, I don't want my data to be in the European health data space, but what is not clear is what level of leverage countries can have to allow or not allow particular data processing objectives. And I think that element is not really clear yet. Mm-hmm. And I think we need to advocate for using this as a key tool for public health surveillance.
Mm-hmm. Okay, that's a very valid point, and I think something we can discuss in the afternoon with the EU agencies. So I think it's important to raise that. Okay, so we're going to break for coffee. We'll be reconvene at 11:30. Okay. Thank you. Thanks to the team.
So, is everybody ready? So we're coming into the second session of today, where we're going to look at more now on the workforce part of this, and with the workforce assessment, the training of media, and the modeling part. I think Jean-Luc already sort of touched on modeling, and I think one question we can ask was what's sort of the difference between what you are doing and what the modelers are doing. I think that's something we can discuss. But let's start with the workforce and what the project has done to try to find ways to define what we can do in the area of workforce. So, Lina from THL Finland, who has taken this work package further. Please tell us what you found so far.
Thank you, Anders. Do you hear me? Yep, great. And hello, everyone. My name is Liina Voutilainen, and I'm really happy to be here presenting today, and happy to see you all, and very unhappy if I don't see this group of people at the same time in the same place in the future. So let's go ahead. What I'm going to present is the tool for workforce self-assessment for public health emergency preparedness we have developed in PANDEM-2. And this has been a collaboration between the Finnish Institute for Health and Welfare and our sister institute in Portugal with Marta Barreto and Ricardo Mexia. So for backgrounds, it's obvious and evident to us all that the pandemic has really shown the importance of the public health workforce in responding to public health threats. And during the pandemic, all sectors having to do anything with health suffered from workforce deficiency, and that happened both in terms of capacity. The number of people was just not enough because especially those who were taking care of patients, they fell ill themselves and had to be in isolation and quarantine, and also there was a lot of burnout and fatigue in the personnel in all sectors. And also the capabilities, the right capabilities to respond to the pandemic were not always the right. And also from the perspective of the public health institutions, we lacked the personnel for numerous functions, and also lacked any plans for surge capacity staffing. So when there is an emergency where you need surge capacity, where do you get the personnel, and how do you know that they will have the right competencies? How do you define them? And just as a little side note here, as we are talking about public health workforce here, that is restricted to the workforce needed in pandemic response and for public health emergencies in general, so we use the term public health emergency preparedness. And the two outcomes we have from PANDEM-2 workforce regarding workforce are firstly the review of current methodologies there are to assess workforce. How do the existing tools enumerate, map, and assess public health emergency preparedness workforce? There are tools from WHO and ECDC. For example, also there are many tools developed in the United States and in European and Western countries. This is a work under progress. Marta Barreto here, she's finishing a literature review that will be published as a peer-reviewed, in a peer-reviewed journal. And the second outcome from our work is the PANDEM-2 tool for public health emergency preparedness workforce assessment for national public health institutes. And this is the part that I'm going to talk about here. So why did we focus on public health institutes alone in our work? Immediately when we started looking at the literature for workforce assessment in the context of public health emergencies, there are great challenges in enumerating the workforce across the whole public sector. So there are a wide range of professionals involved. It's not just doctors and nurses. There are most of the professionals that are needed in the pandemic management, they only would do it partly, so that not all people are 100% involved in the pandemic, and they have other duties and other functions. For example, people in border control, etc. That are not even in the health sector. And so far there is no pan-European classification for this personnel available. And also in terms of the public health workforce capacity, there is an ongoing initiative by WHO to tackle the public health workforce capacity questions in a broader sense and in a wider geographical scope. So also we had, in our consortium, we had 6 national public health institutes involved, and we had focus group discussions within these partners. And already in those discussions, the institutes identified that there is a need for a practical level tool to assist the national agencies in preparedness planning. And as I said, there are tools from WHO, the Joint External Evaluation, the self-assessment tool SPAR for the international health regulations. There is HEPSA tool from ECDC. ECDC also takes surveys for the European and EEA countries on workforce capacity and training needs every year. But we saw that these tools do not enable the national institutes to assess or plan their own workforce needs on the practical level. And we had the benefit of having such a wide composition of European NPIHs included in the consortium, so we could involve them for their wide practical experience on the work of the institutes during the pandemic. So what we did develop this tool for workforce capacity and capability assessment for national public health institutes that they could use in preparation for the next pandemics and also for other public health emergencies of a smaller scale. We didn't start from the scratch. The tool is heavily built on existing ECDC tools or frameworks of competencies. Firstly, the public health emergency preparedness core competencies for EU member states that was developed already before the pandemic in 2017. So this was a great opportunity to look back into those competencies and see what needs to be changed and which are the relevant competencies after pandemic. And also we included some core competencies from the framework of applied infectious disease epidemiology in Europe. And apart from these frameworks, we took some specific markers on leadership and management skills, scientific skills, and cross-cutting competencies from other frameworks, which are from American origin, the Council on Linkages between Academia and Public Health Practice, and the Beaumont Foundation of America, where these skills also have been defined on an organizational level, or competencies to say. So what we did, we took these frameworks and involved our 6 national public health institutes in a Delphi study. So we had our experts from these institutes to rate which are the most relevant indicators for their context of work. And this process resulted in our tool, which now has 9 capacity indicators, which shows how many people are needed, also during peacetime in normal circumstances, and on the other hand, how many people should be there for surge capacities. And for competencies or qualitative indicators, we have 100 competencies on the organizational level, what the personnel of the organization must be able to do as an organization together. And these go to, I'm sorry, there are 5 categories, but there are actually 6, because we have the 6th one, which is the cross-cutting competencies that was added from non-European frameworks. Now, here's a visualization of the tool. This is the capacity side, which is to say the number of people, but since, as I said, whole persons don't work for the pandemic alone. There are people who put 20% of their time for managing the pandemic. For example, statisticians that also do other statistics for the Public Health Institute, etc. So that's why we enumerate the workforce in full-time equivalents. And there are some obvious groups of personnel that we enumerate. Oh, sorry. Yeah. The epidemiologists and public health microbiologists, they are the cornerstone of public health agencies, obviously. And also data scientists and statisticians are an important part of our institutes. Modelers and communication specialists, they are something that were really critical during the pandemic. And for example, in our communications department, they hired at least 20 more people during the pandemic just to run the everyday communication. And there are two groups of people or personnel that we identified together with the other consortium public health institutes that proved as a lessons learned from the pandemic to be important. Firstly, the management and support. Clearly, somebody has to manage the pandemic or the response in the institute as well. Also, although we work very well as scientists and researchers and experts together, when there is an emergency, somebody has to take the control and delegate the work so that everybody does their share. And also, management is needed for the recruitment of new people to define the job descriptions, to interview job applicants, etc. And the second group was the doctors with expertise in infectious diseases and public health, and other specialists like public health nurses that have experience in infection prevention and hygiene. These are really important people in terms of the practical response, who are able to write guidelines to the field, how to manage patients who are positive for COVID-19, who understand what the needs are in the field, what kind of guidelines they need, etc., to communicate to the field as well. So these groups enable the operational functions in the day-to-day pandemic response. And also we have the total numbers of workforce for preparedness, and also just as a reference, the total workforce of the National Public Health Institute. And then I go to the qualitative side. These are the workforce competencies. This is just an example. As I said, there are 100 indicators in these 6 categories. There are for example, the 2 categories, detection and assessment and health services, and then there are explanation of what these areas include, and then they are broken down to competencies, which you see in the light blue and white and light gray column. And then I think, because it's not very visible, this is how you rate the competencies. First, there is a question of how well is the function performed, and this is then scored from not well in 1 to very well in 7. And then there are 3 questions on ways which could improve this function. Is it to train the current public health emergency staff in this competency? Could it be improved through training other staff within the Public Health Institute, like statisticians that are not specialized in communicable diseases, to support the staff? Or could it be done through recruitment of new staff if there is just enough people, not enough people in the institute? So that in the case where the score is low in the performance of a certain competency, and any of the scores are high in these measures that would improve the performance, then these would trigger the need for training or recruitment in this competency. So finally, what this tool could be used for, as I see it, firstly, it's of course to assess the needed workforce capacity for public health emergency functions during normal circumstances. And secondly, to plan the needed surge capacity under the public health emergency situation. Just not enumerating the need of experts needed for each competency or for each personnel group, then gives you the idea that, oh, okay, well, you can use it, for example, on looking back to the pandemic period, seeing that, okay, we have hired 20 more communication specialists. Next time, where are we going to get them, and how should we have job descriptions ready, and how can we prepare for that so that we wouldn't be in great trouble just recruiting? Because from the communications department in Finland, they said that actually they would have needed 1 person just to manage the recruitments alone. So these features that enable the planning of the capacity, they could complement the human resource planning at the National Public Health Institutes, because that's done yearly anyway, to say how many people are needed for certain functions and how many FTEs go under preparedness, communicable disease surveillance, etc. So then the 4th point is, of course, to analyze the gaps in staff competencies clearly, and these gaps that appear from this tool then will identify and help to prioritize the training needs and recruitment needs. But in the European context, this tool could also be used to benchmark and compare the capacities across the European countries, so that you will, both in, for example, in ECDC and also within our countries and governments, we could understand where our deficiencies are in regard to other European countries. And enumerating the personnel would also advocate us to get additional investment in public health emergency preparedness workforce at our national institutes. And lastly, this work could complement the ongoing work for the EU for Health initiative on EU preparedness, analysis, planning, reporting, and training programs for health specialists that is just commencing these months. And a couple of things for future research. Obviously, we will need indicators for pandemic workforce capacity throughout the sectors. and also to define competencies across the public health response. But in this respect, the categorization of professions and needed and enumerating the personnel, that's a challenge, especially for healthcare worker capacities, because in many European countries, the healthcare system is really decentralized. So it will be a challenge to get a clear picture countrywide. And one advance could be costed tool that would give us more leverage to advocate the investments on the capacities that we have, both during the peacetime and also to prepare also in terms of financing to the next health emergencies and pandemics. So that's all I had for today. Thank you very much.
Thank you very much. I think this is a very timely tool in a time where many of our agencies are facing cutdowns. I mean, many of us got more resources during the pandemic, but now we're getting into a new phase, and many of us most probably need to cut down. And then I think these kind of tools to be able to see what we really need are going to be very important. Thank you very much. Let's move on to another part of the workforce capacities. The media, we talk a lot about communication. In practice, a lot of our communication went through media, and that's why media training has become so important. So, Imai from Car Communications, please.
Hi, everyone. Thanks, Andrew. I'm Emer. I'm a board director at Car Communications in Dublin, and I know a lot of you. We work on the PANDEM-2 project, and we lead on the communications, dissemination and exploitation. And I'm going to talk to you today about the media toolkit that we've created in this project. First, just a little bit about us. We are the longest running communications company in Ireland. We're actually celebrating 50 years this year, and our founder, Bunny Carr, pioneered our approach to media training, which is still used today. We work mainly with government bodies that focus on issues of societal importance, as well as working on a number of EU projects as well. So we have a unique insight into communicating within a public context, but we also have a huge experience in preparing people how to communicate during those crisis situations. And during COVID-19, we would have worked with organisations involved in the vaccine strategy, also organisations and individuals who had to suddenly act as spokespeople on behalf of their organisations, having never performed that role before. Sorry, I'm going forward on my slides 1 second now. I suppose communicating during COVID, as Anders said, was hugely difficult for many people, and it was a real challenge. There was no playbook for how to do it. Some people got it really right, some people got it really wrong, and some people found themselves having to act as spokespeople without ever having performed that role before. So it really highlighted the need for that engagement to be really good and really structured and really focused whenever you had to do it. And I think what it also showed was that a poor media interview had the potential to really undo an awful lot of the good work being done on the ground. And it also highlighted for us a lack of practical resources. Sorry, I'm trying to go back. 2 seconds. There we go, we'll stay there. What it also highlighted for us was a lack of practical resources for how to engage with media during a crisis. And we know this from speaking to our public health partners and the end users on this project, who all had to perform this role at some point during the crisis. And what they felt they needed was a very practical resource that they could take off the shelf and use to help them to prepare for a media interview. And that's why we've created a media toolkit. So it comprises a handbook, practical templates then for press releases and social media posts, training, supported by training, and also self-evaluation. So it's a very practical guide, and the handbook is the key component that underpins everything else. And I'd just like to acknowledge our colleagues as well in Fraunhofer and in University of Galway who supported us in developing this toolkit. So the toolkit itself is really for anyone that may need to engage with media in a pandemic, a crisis, or a hazard situation. So that could be somebody who suddenly finds themselves acting as the voice and face of an organisation. It could be somebody who's called upon for expert opinion. And it's also for communications teams. Lena mentioned the expansion of their communications team by 20 people. So all of a sudden you have this group of people who need to know how to engage with media, particularly if they're the point of contact between, pandemic managers, public health officials, and the media. They need to know how to communicate effectively with media also. And this handbook will help to, or the handbook itself will help to ensure that anyone who interacts with media during a pandemic understands what to do, but also very importantly, what not to do. It's not a crisis handbook, I just want to say that. It's not a crisis handbook. This is really about how to do a very good media interview. So the purpose of the media training toolkit and the handbook itself is to provide guidelines for communicating during a public health crisis. The guidelines focus on defining the target audience, and as communications experts, we know everything starts with an audience. You have to know who you're talking to in order to know what to say, and you have to understand that audience in order to know what they're going to take from the messages that you communicate. But it also gives guidance on how to overcome specific concerns. So that might be how to use your nerves during an interview, or how to handle a difficult conversation or a difficult question. And anybody that we ever work with in a media training capacity usually talks about those two things being their main concern. What do I do when I get very nervous, or what do I do when I have a difficult question and I don't know how to get out of it? So this guidebook is going to help you to overcome those things. It's also underpinned by behavioural science-led approach, and that helps the reader to really identify approaches to messaging, which are going to, I suppose, influence a change in behaviour among the audience. And that's really important. So we have to know our audience, but then we have to know what to say to that audience to influence how they're going to act as a result. So how did the handbook come about? Well, first of all, we started with desktop research and into different approaches to communications during COVID. So we looked at all of the different available research to see what happened during COVID, how did people communicate, what worked, what didn't. And then we have our own experience. So we work with a team of media coaches, but we also work as communicators in very big crisis situations. We have our own experience, and we brought that to this as well. We conducted interviews and workshops with our partners Fraunhofer, and this allowed us to back up our own research with real-life input and experience from our end users. We then tailored the media training handbook based on their needs, and we pilot tested it with our end users, getting feedback on the content, refining it, and making sure that we had the best possible output at the end. Our own research then showed 5 key learnings. The first, an obvious one, there was a patchwork of communications approaches during COVID. Some good, some bad, but largely inconsistent. Another finding for us, and I'm sure everyone can agree with this, was that there was an over-reliance on data and science, which for many audiences, particularly in vulnerable groups, or for whom maybe language wasn't, they might have different language needs or language or cultural needs, it was often too complex to understand. And that's even more important in a crisis situation when people need to hear simple instructions and simple advice. There was also evidence of limited preparedness among key spokespeople. So I've put the point down there, but I'm an expert. But we've come across a lot of people during that situation where they think by virtue of the fact that they are an expert in their area, that makes them a good spokesperson. It doesn't, because everybody needs some support in terms of how to really focus on an audience, on a message. So oftentimes they almost had to make the mistake of doing that in order to come back and realize that they needed the support from media coaching. Also, too many voices created inconsistent messages, and that got diluted over time, or the overall message got diluted over time, and people started, we talked about information overload and the infodemic, but that really had, I'm having real trouble with this remote, but that really meant that the audience didn't end up hearing what they needed to hear. They just started hearing a multitude of messages and couldn't grasp onto any one in order to influence a behaviour change. And then finally, messages didn't take into account people's intrinsic behavioural biases. Our end users also highlighted a number of areas they found challenging when it comes to engaging with media. I won't go through all of these because I'm sure you can all identify with what's on the screen. But I'll just pick out a couple. For example, one of our end users spoke about the over-reliance on one media channel, and a lot of organisations focus on mainstream media, whether it's TV or it's news, and they might neglect other media channels. For example, in Ireland, local media is probably the most powerful way to get to a rural audience, but often we can focus on what generates the most listenership at one point in time, whether it's primetime news. Or they might have relied on traditional content like press releases, rather than more engaging content that younger audiences engage with, like, for example, infographics or video content. Vulnerable groups, and we've heard this mentioned across a number of presentations, vulnerable groups weren't adequately addressed or communicated with, and probably most importantly, and again from my own perspective as a communications person, there was no real focus on audience. And audience for us is the most important part of any communications. You have to know who you're talking to in order to tell them what they need to hear. And you also have to know what influences what they hear. So in our handbook, we've provided guidelines on how to ensure you put your audience front and center of any communications piece that you're doing and any media interview that you're doing. We also know that media is a hugely important channel to get to your audience. And we, in our work, always talk about media as a channel to get to your audience, but media as an audience themselves. So in our handbook, we have looked at how, as a channel, you need to consider them. So how does this TV, radio, print, social channel get to my audience? Who's going to be interviewing me? These are key questions you should be asking yourself. What does that person think about what I'm going to talk to them about? Have they got views that's going to dictate how this interview goes? What is the tone or style of this program? Is it informative? Is it combative? Is there going to be someone on the program with me? Is that going to end up in a head-to-head discussion about a particular issue? And then most importantly, what do I want the reader or the listener or the viewer to take away from this interview once I'm finished? And then as an audience, and I've heard a couple of people, and Ricardo in fact mentioned this to me, not today to call you out, Ricardo, but at the plenary mentioned how important it was about communicating with media and helping them to really develop their own understanding. And I think a lack of understanding among media can really lead to skewed reporting. So as communicators, we have an opportunity, but I suppose also we really have to look at media as being an audience that we have to help understand things. Do they understand the data? If not, how can I help them to understand the wider scientific, societal, environmental, economic context? Can I give them extra references, sources? What sources do they use? How can I help them to understand what I'm talking about better? So now I've given you an overview of the toolkit, what's in it, how it came about, who it's for. I'll take you briefly through the handbook itself. And this is the central component of the toolkit. It is really simple and easy to follow. And so it's got 4 specific sections, which are really straightforward. And it's laid out really nice. It's a short handbook, about 20 pages or so. So it's a very practical resource that you can take ahead of any media interview to help yourself prepare. Each section then has clear objectives and learning outcomes, so you know what you're setting out to achieve, and then you also know by the end of that what you should have achieved. And it can also be used as a learning guide for individuals or in a group coaching session. And in time, it's going to be supported by downloadable, shareable formats and also video-based content. So they're the contents of the handbook. So section A focuses on setting and achieving objectives, and that's really, really important to do. I can't stress that enough, that really preparing for a media interview is so critical to make sure that that opportunity is as good as it possibly can be. Section B then is about how to prepare and effectively and efficiently. I think oftentimes when people do media interviews, they think the more information I share, the better the interview will be. Actually, no. The fewer, more strategic, structured messages that speak to a core point, that have a clear call to action, that are relevant to your audience, that's how those interviews should be structured. Section C then looks at an evidence-based system, because once we do our interviews, we want to make sure that we have achieved the objectives that we set out to. So that looks at opportunities then for development in future interviews. And then section D looks at those concerns that people have spoken to us about, channeling their nerves in an interview. How do I deal with a difficult interviewer? How do I get back on message if I feel a bit derailed or if I've gone a bit off point? How do I do that? So all very, very practical things. And here very briefly is how it's going to look online. So we've got our sections there, and you can dip into any one of those pieces depending on your needs or what point in your journey as a spokesperson you are. And as I mentioned, it's going to be interactive and supported by video content and resources. And then finally, it's really important to consider future applications of the handbook. And as I mentioned, it really is an entry point into preparing for a media interview. But again, as communicators, we would always advise that coaching is a secondary point as well, and that really helps you to get the most out of any opportunity that you have. So it would really benefit from that bespoke media training, whether on a group or a one-to-one basis. And also we can see it potentially being used in future research, European research projects, maybe about some of the European agencies. And here's where you'll find it. It's not there yet, but we will be communicating about it when it is. It's going to be hosted on our website, which is pandem2.eu, and then also on our social media channels on Twitter and in LinkedIn. Thank you very much.
Thank you very much. Very quick and concise. I hope you also mentioned the most important lessons. Never believe that the microphone is turned off. So let's move to the next part of workforce capacities. That's really had a big hit off during the pandemic, if you might say. So communications, media became very important, but modeling also had a completely new and much more prominent role than we ever seen before. So looking forward to hear what you're going to say, Jim.
Great, thank you.
Galway, Ireland.
Thank you very much, Anders. It's great to be here today, and you're very welcome to our summary of modelling for pandemic preparedness and response. Just to acknowledge my colleagues here, Ger and Caroline on the modelling side, and also Martin Berend. We've worked very well together as a team over the duration of the project. Many Wednesday afternoons we spent kind of going through the models and getting feedback. So it was a great process to work with domain experts like Martin Berend, and it was very valuable for the modelling as well. So I start off with a definition. This is my favorite modelling definition. I use it when I teach modelling, and it's by a guy called Michael Pidd, who is actually an operations researcher. So he works in the area of, I guess, modelling supply chains and these things. But he mentions a couple of words there are the external and explicit representation of a part of reality. And then we go on and say, because we want to understand, to change, to manage, and to control that reality. So what isn't mentioned in here, which is really important as well, is that people have mental models. So everyone here, in a way, is a modeler. You've got a model in your head of how things might happen. So, for example, if we had a workshop and we asked people to say, there's a new disease X happening, here's a whiteboard, I want you to draw what you think is the trajectory of the disease over time. And everyone then would draw what they think would happen, and that's their model. So the challenge then is to get the model from inside your two ears out on the whiteboard and have a process for model building. So model building is really about engaging with domain experts, looking at the theories behind the model, looking at the key parameters, and bringing that to a very formal way. And that formal way is something that's explicit, and people can look at it and say, oh, I understand your model. So that's the process that's very important in model building. So that's the process that we followed a lot during the duration of the project. So the presentation today has, I guess, a couple of main sections. One is to give you a sense of the inputs that we used as part of the model building. So it came from multiple sources, and again, working with our experts in public health. Just as an aside, a really fantastic thing about the project is we got to meet so many people from different backgrounds, like public health, first responders, and all of this helped us get a very good understanding of what we had to model. So basically it's the inputs, the modeling itself, and then some of the outputs. So one major input that was really important was the study done by RIVM, the Delphi study, and the parameter study as well. Just to give some context on the importance of this, so when you're trying to model something at the start, you don't know the answer to every question, so having a systematic review to find out things like, well, what's the average length of stay in hospital for a 75-year-old? What's the average number of resources needed to support someone in ICU? So a key challenge there is to be able to go into the literature and find out what are the values that we can know, because when you're modeling, there are things that you can know and estimate very well, but then things that are very, very uncertain, like how many contacts somebody might have per day. So this is a really valuable study done by Martin Berend and the team. Again, systematic reviews are a really good way to find out this information. You do search queries, you find out the set of key papers, you go through all the studies, and you come up with these parameter values. And these parameter values were crucial in terms of building the models, because we have a process of identifying parameters and including those and not including them. But what RVM also did, which is really, really powerful, was we had a Delphi study then to get people's opinion on which parameters were important, and eventually that helped us bring these into the model itself. So as part of the model building process, what I really liked about this process is it was group model building, really, because lots of people were experts in terms of looking at the values and saying, well, I think this is important, this is not important. They had a very nice system whereby for example, a threshold of 70%. If 70% of people thought it was important, and these are people with expertise in the background in the area of public health, we included it, otherwise we didn't include it. So there was a good process to include things in the model, and that was one of the key inputs to the model building process. And again, things like, for example, average length of stay in ICU, resources needed, these are all things then that worked their way into the model. So when I show a snapshot of the model later on, there are elements there that really came out of this process, and that's a really important part of the model building process. Another input was myself and Professor Connolly were part of the Irish Government Response Team. They set up a group called the Irish Epidemiological Modelling Advisory Group, and some of the work that we did there also helped us with the model building process. So for example, and this goes back to, I think, Andrew's point as well, the whole area of capacity, public health capacity. In March 2020, Ireland didn't have any modelling capacity, so they brought together a team from academia and health to actually do the modelling as part of the pandemic response. So we contributed to this. One of the models built was an age cohort model. The reason it was age cohort is because people wanted to find out what might happen when we start to vaccinate, for example, children versus elderly, what impact that might have on the overall cases in the population. Another point worth making is that when you're modeling, it's very important to have a purpose to the model. So the purpose here was to generate projections of cases so that we could then feed that to another model, which was a hospital model that would then model what would the potential load be on ICU, for example, because that was a very important policy piece of information. So if the government could see, well, maybe our ICUs are going to be overwhelmed, that would be a disaster. So therefore, we used our outputs to send to another model, and that was used then to help generate projections of what might happen in the healthcare system. Okay, so moving on to the model itself, we split our model into two parts, and this is similar in ways to what we did with the Irish modelling as well. So we have an epi part where we model the progression of the disease through a population. So here we have, this is called the SEI3R model. It just means that the boxes in red are people who are infected but can also transmit the disease. So it's important to capture this in the model. So on top of that, then we had public health policies that can be actually activated. You'll see this in the demo later on, that you can activate parameters to do this. But things like vaccination, because vaccination means that people are no longer susceptible, but they have immunity that they can then no longer be infected. Things like contact tracing. So do we have capacity to find out people who have been in contact with other people, so therefore we can actually reduce the burden of disease. Testing and isolation, so this is really important to test and then also to get a good signal of what's happening in the population. And obviously at the early stage of COVID-19, this was a challenge because the testing capacity wasn't high enough. But also things like mobility, and this was a non-pharmaceutical intervention, so basically that was a huge factor at the start of COVID. Can we reduce mobility? And even if you think back to the data from phones like the Apple iPhone, for example, you could go online and see mobility really has gone down in certain places because people were reacting to the spread of the virus. So our model then, this is what we call the EPI model. The EPI model then feeds our hospital model. So when I mentioned earlier on the previous slide, the work with RIVM, those parameters are part of the hospital model as well. So things like your average length of stay based on your age group, things like the infection rate, the mortality rate. We have a thing called a patient pathway. So it just means that somebody gets infected. Unfortunately, some people will have to get medical care. They basically go in an ambulance into the hospital, and then they flow through the hospital depending on the severity of their condition. And in the end, they then move away from the hospital. So basically, this was our hospital model. It captured the patient pathway from start to finish. But also, what's really nice about simulation is you can actually connect different resources in the model. So, for example, we know from talking to clinicians that in ICU, you not only need a bed, you need a ventilator, but you also need someone to staff the bed as well. So, in our model, we were able to combine these together. So, if one of those was missing, we couldn't use capacity in ICU. So, these are important things in the model that allow us to really, again, the purpose there being what is the impact on resources of a pandemic wave. So within the hospital model, we have these structures in place. I think a really nice innovative part of our solution is that we have we created a simulation server, and this just means that we built the model with its components, and we can package this on a computer, and then it can be called from the dashboard. The advantage here really is that it's fully separate from the dashboard. So what we can do, say, for future projects, so for example, yesterday was a very interesting point on counterterrorism, for example, so which is a security challenge. But for example, we could look at building a model for, say, counterterrorism, maybe a network model, and that could then be put in a simulation server, which could then be called from a dashboard. So our conscious design decision was to separate out these two areas. The dashboard, which you'll see later on this afternoon, sends parameters, things like length of stay, to the simulation server. It takes in all these inputs, and then it generates the output, and they go all the way back to the dashboard. Just to say that this part of the project, it was great to have such fantastic collaboration with EpiConcept, with Modus Create, and also with the VA team in University of Galway, because this is where it was so important to have this interaction. So, for example, we could generate the data from the simulation, but a huge challenge was to be able to visualize this, and then also to make sure that the data we're using was from a good data source. So we worked really well with the other teams to make this possible. So here, you'll see this later on. Basically, the modeling user interface, the model we have is avian influenza, so it's based on the 1918 model that's already published. So basically, you can set some parameters. There are many parameters that you can set, including things like vaccines, mobility restrictions, and basically all of those parameters are every time you change one and if you run the model, you get a different result. So and this was used then in the functional exercise as well, where you can run the model and then look at the different outcomes from the different policy options. And the policy really was in terms of what can people in public health do to stop the pandemic, and then what can people do in the hospital settings. So for example, adding more resources, trying to reduce the length of stay of people in the hospital, these are things that can be done at the hospital level. So these are just, again, really nice user interface work here as well. I'm not doing justice to it here, but basically there's, you can tailor your own graphs, you can do different scenarios, and this is fantastic work by the VA team, and then also the team in Modus Create to make this a very interactive web experience, which again is very good to support preparedness planning exercises. So then we can look at things like the capacity in hospital. So we can see there that the red line there is almost like a fixed capacity that we have. And the thing about an epidemic wave is, when it hits, then it hits the hospitals, and you either have enough capacity or you don't. And if you don't, then obviously your population will suffer quite a lot because they cannot get access to the care that they need. So then we look at things like the deficit in capacity. And then also very nice diagrams like patient flows. This is the Sankey diagram at day 90, where we see where people are in the process. And this again is your patient pathway. So people come into the hospital, they go through different stages, and then they leave. But these are visualizations that you can have on the dashboard. So in terms of utility of the modelling we've done in the EU context, I think the model is a very nice model. It captures the dynamics of novel influenza with age differentiation, which is important for things like hospitalizations, because one of the case studies we took was from 1918, and a unique feature of that virus, so I'm told, is that it attacked people in the younger age groups. So we were able to do this by having an age group, for example, from the age of, I think, 20 to 30. So the tools and the models we developed can support pandemic preparedness for member states. Maura mentioned yesterday that you could do this on a country level. You could even do it on a regional level in a larger country. But also, I think a really valuable one is to get an EU-wide level exercise where representatives from many different countries can come together and really do pandemic preparedness within that context. It's also designed for extendability. So Emer mentioned this yesterday as well. We have separation of functions. We have designed this so that it can change. Because the models that you might need tomorrow are very different from the ones you need today. It all depends on the virus. So basically, I think we've done a nice job of creating a flexible architecture that can be used. I'm just keeping an eye on my time here. I have 30 seconds left. So conclusions then is modelling is an integral part of generating scientific evidence for pandemic preparedness. We've seen this throughout COVID. All the countries in the world use modelling to help support decision making. You can use it in the preparedness phase, which again, with the FX, we've shown that in Pandem. And then also you can then use it in the response phase. And then we also have a structure that could be used in response as well, because we have this flexible architecture that you can plug in other models and get the results back. But also looking to the future, challenges like long COVID, healthcare system impacts are important as well. So that's it. Thank you very much. And
thank you, Jim. I guess we have time for a few questions. So we have a rather long lunch break. So we can take a few minutes. Please.
Thank you very much for this brilliant presentation. That really gives a good flavor of what eNOTICE has achieved. Do you hear me? Okay, thank you. So a question to Lina. I mean, yes, indeed, planning trying to describe workforce capacity and surge capacity under PHE situation, it's something we should do for the next pandemic. My question is, and I refer to the Belgian situation, we have actually a huge shortage of nurses and medical personnel, and even medical doctors now are no more attracted by hospital for different reasons, which I will not comment, but pandemic has indeed markedly boosted this problem. I don't know if the Belgian situation is equal to other member states. In Sweden, I see that Anders is actually approving this. So what do you want to, what could you do, or what would you like to do to improve the situation? Because, this is really detrimental to all the planning that you would like to do.
Well, our work, thanks for the question, Jean-Luc. Of course, I can only really answer only for the, considering the public health institutes that our work concerns. And I recognize the problem also in Finland. I think there are many underlying reasons that have led to the current situation, and the COVID-19 pandemic didn't make it any better. And we do also suffer at the Public Health Institute. We could see during the pandemic, we could see a pattern where in the beginning of the pandemic, everybody wanted to rush in to help in the war, to volunteer. But then again, when it just continued and continued, then you could see that everybody's silently escaping. So yes, the reasons go deep, and the cures are difficult. That's all I can say. Maybe Anders can have more.
No, I mean, you're pointing to a problem I think we have in most countries in Europe and maybe all over the world. But I don't think that should stop us from pointing to the problem. and I think we really need to have sort of good data to show it, because I think politicians and decision makers and financial people are getting a bit tired about healthcare just saying we need more and more people, because actually in healthcare, at least in Sweden, we are more and more people. Every year there's more and more people in healthcare, but there is always a bigger lack than that. So I think to have this kind of tools that you can really look into, and you can question how valid they are, and then probably need to adapt it to different places. But in the end, you need them to be able to come with some kind of convincing arguments, I think, in the long run.
Yes, but you say increasing years after years, but not nurses and not medical doctors. I mean, not what I...
If we talk about trained people, yes. If we talk about people about working in healthcare,
exactly.
That's
because
a different thing.
Students, they are not going to go to the hospital anymore, so they do something else. So it's probably something that should be tackled at the EU level, because I don't see any national solution to it.
Please, Jean-Luc.
Yes, thanks a lot. My name is Mart from the RVM in the Netherlands. I was just wondering, also a question to Lina. Did you see, you mentioned that your tool covers around 100 indicators. I was wondering whether they all were all considered relevant for each public health institute, or did you see large differences in these indicators between the different public health institutes?
Thanks, Mart, for the question. I'm sorry, but I didn't properly hear you.
Oh.
Did we see differences in what?
In indicators. So you looked at with 6 different public health institutes at the different indicators that were needed, and I was wondering whether there were differences between public health institutes in the indicators that they required.
Yeah, good question, and thanks for that. Actually, what we saw that all the public health agencies, they were really on the same track with what is relevant and what is not. We did a Delphi study where you are supposed to, if there is a disagreement from certain indicators, then you discuss and then decide if it's left out or excluded or taken in. But it was really few indicators that we had to discuss, because it was so clear that certain indicators are relevant and certain are not. Of course, this was also dependent on the mandate of in general, of the national public health institutes. Thanks.
I'm not sure if I can ask one more. So do we still need tools like the HEPSA, or can we just use your tool now?
Of course, we should use our tool, but yeah, but they are really different tools. HEPSA is a more general level tool. It goes across sectors, not just not only the national public health institutes, and it covers a whole lot of other aspects of preparedness than just the workforce. So yes, we need both, but I think HEPSA would need updating.
Any more questions? Can I ask you one thing, Jim? These models have often been seen as kind of prognosis, and that to a certain extent had created problems for us. Can you say something about how you have dealt with that, and what's your thought on that?
Is that in terms of people taking them literally, that it's going to, in a predictive way? Yeah.
I mean, they see it as a weather forecast.
Yeah, that's a really good, the weather forecast is a very good analogy, and I was trying to explain this one to someone about the difference between epi modeling and weather forecasting. So I imagine an area in Ireland called Belmullet in Mayo, and you imagine it's on the west coast, it's very windy, and so it would be like if a weather forecaster said, for example, tomorrow it will rain in Belmullet, and maybe if everyone went out then that night with rain machines and made the clouds move, and then it did rain. The point is that with epi models, people's behavior can change. So when I don't know if that was a great example, but it probably shows how hard it is to explain. But the point is that when you project forward in a scenario model, which is really important for ICU admissions, you got to base it on, well, a couple of things. Well, first of all, you have to convince the people using the model that I've calibrated my model to historical data, so you see the data and the model matching in history-wise, and then you say, well, here are my assumptions for how things might change, so maybe people are going to contact each other more, and then you run the model, and then it gives you a projection. But there's still huge uncertainty there, so things like who knows how people are going to contact each other tomorrow. Another big uncertainty is, and we saw this with COVID, is when, and this was shown by an article by Adam Kucharski, where he mentioned the new variants coming on stream, and they were actually in the UK. They had a surveillance system called Comix, where they surveyed people every week to see what their contacts were, and based on that information, they were able to hypothesize that the spike in the Kent area was not due to social contacts, but maybe something else was happening. So if you can get this information on social contacts and then say, well, people are still contacting each other the same, however, the cases are going up, and then that led to say, well, maybe there's a new variant out there. So I think, yeah, it's a tricky one really, and I think in communication, you just have to make sure to say that this is not a forecast. I'm not certain this is going to happen, but based on our best evidence, and also to communicate to people that modeling is a scientific process. So people sometimes forget that. You have a hypothesis, you have all the parameters, you have your model structure, you have your testing. There's a whole rigorous element behind it. And even though people might say, oh, the weather forecast is so accurate, but the modelers can't predict anything. But the point is, if the modelers are using the right process, then they're doing the best they can to try and project things. But it's you always have the uncertainty of immune escape, the uncertainty of people contacting each other, the uncertainty of transmission advantage of a new variant, and it makes it very challenging for modelers. So so maybe forget the example about Ben Muller. I have to think about that a bit further.
Yeah, thanks. We also sometimes forget that people doing weather forecasts, they have data from like 200 years, while we look at data from 2 weeks. So, any more questions? I guess that means it's lunch break, or and lunch is served outside. Thank you very much.
the middle, yeah, it's forward, yeah.
It's quite
So,
easy.
yeah.
So at the Institute, we have one at the top and one at the bottom. And this is forward and
And
this
this
is
is back, oh yeah, okay. And we have, okay.
That's for you, to be sure that I quote you perfectly. I'm obsessional.
That's so nice. I'm getting red and I'm
Ladies and gentlemen, after this delicious lunch, I hope you enjoyed it as well as the weather. It is my pleasure and a big honor to invite Mrs. Claudia Harrow. Claudia is public health expert and she's member of the Emergency Operational Center at RKI. And she will tell you all about the training scenarios and CMEX, simulation exercise, that she organized with the partners. Thank you. Claudia?
Thank you very much, Jean-Luc, and thank you for the opportunity to present today. I'm really looking forward to it. So just like Jean-Luc said, my name is Claudia Waro, and I'm presenting today on behalf of the whole Robert Koch PANDEM-2 team. And we can start with the slides. Then you can see the names of my colleagues. One of my colleagues is already there, this Clara Speaker, and she will assist me as well. And if you have any questions later on, you can ask her or me. All right. Nice. Okay, so I'm going to talk about the training scenario and simulation exercise we prepared within the PANDEM-2 project. And so, especially after the COVID-19 pandemic, we all know how important it is to be better prepared for future threats. So avian influenza, you can see here on the slide, is a possible future threat. And so we picked it for our simulation exercise. And just to give you the reasoning behind that is that birds are the national host of this disease. And so we saw a change in the last years that this seasonal phenomena from migrating birds transmitting to the captive birds has changed. Because now you can see that the persistent presence of these infections are in the EU and in the whole world. We see larger and more frequent outbreaks. And this you can see in mass mortality events in seabirds, especially during the breeding season, because then in the breeding season they're closely together and get infected with each other. So after that, we see that more than 50 million birds in 2021 and 2022 got affected and died off. And so recently it added that we have a paradigm change in the ecology and the epidemiology of this pathogen. So we saw a spread to new geographical regions like South America, and we also saw a change in the spread patterns. It infected and adapted unusual number of different bird species. So there's something going on, so to say. And in the last years, we saw sporadic transmissions to humans. This is not different, but to get an understanding, they have, you can get infected by direct contact with infected birds or contaminated environment. And you can see that if you get symptoms, you see severe disease symptoms like acute respiratory distress symptom, and this can also go to multi-organ failure. And so the high case fatality rate is there around 50%, and especially for the subtype H5N1. And this one is selected for functional exercise. And to date, there were no human-to-human transmissions. So we are going over to the potential pandemic threat there. And the EU identified transmission events. There we have seen in sea and land mammals, so this is new, and especially in H5N1. And so the emergence of the potential new virus strain can develop the ability to infect not only humans, but to show sustained human-to-human transmission. And this could place high burden of disease and also in death, and because of the lack of immunity, especially in young adults. So this is the reasoning behind this. And just to see that there's really something going on, we have recent transmission events of avian influenza, especially in this year. So I bring you 3 examples. In February this year, we see in Cambodia first 2 cases of avian influenza infected with H5N1. And these were the first cases since 2014. It was an 11-year-old girl which died of severe pneumonia, and her father, he was asymptomatic. So we saw a case fatality rate of 66% in Cambodia. And in April this year, in Chile, we saw the first human infection ever with avian influenza. And this was a 53-year-old male, most likely to be infected to environmental exposure, but it's not sure. So in May, last month, there were in UK 2 avian influenza cases which were infected while they were working in a culling process and working on infected poultry. So these cases were asymptomatic, and they were detected as a part of enhanced surveillance study. So now, moving on, we covered the pathogen. Now the purpose of a simulation exercise. So a simulation exercise can be an integral part of public health preparedness and response training for future threats such as pandemics. So they can reveal gaps in emergency plans and policies, and they allow staff members to practice their roles, familiarize them with procedures, and improve team building, communication, and motivation. And it helps to plan and test resources and save money and an actual response. So coming then to a new perspective, we can see that ECDC and WHO recommends simulation exercises on a regular up to annual basis to train, evaluate, and to adapt existing emergency response without any lives in danger. It can facilitate joint cross-border training and strengthen intersectoral cooperation. So all things we want to have. So we done a simulation exercise, but we do a special kind, an operation-based functional exercise, which we hosted for 2 days. and it defines that it creates an exercise situation that is engaging and as close to a real-life event as possible. So we use time pressures, for example, and without the deployment of any resources. The aim was to demonstrate and test both PANDEM-2 IT solutions and Public Health Emergency Operations Center emergency response. So the participants were the Public Health Emergency Operations Center staff from the Netherlands and from Germany, from the National Public Health Institutes of these two countries. And we had additional active roles for the national focal points of Finland, Sweden, Romania, and Portugal, all partners in the PANDEM-2 project. So we were in the nice position to have multi-experts as participants. We had epidemiologists, public health experts, communication officers, clinicians, first responders, and data scientists and virologists in our team. So additionally to, so to say, normal functional exercise, we were able to make it more realistic and innovative in this design in our simulation exercise. We used the dashboard developed in our project as an adaptable part of a IT training platform, and we used synthetic data created for this exercise. And we also were in the very lucky position to use the ECDC early warning and response simulation platform to practice cross-border communication. And all of you who are not familiar with the EWRS system, it's the cross-border communication tool for public health agencies. So included into a realistic simulation exercise makes it even better. And so additionally, we did live streaming of the participants interacting with the dashboard and while they were interacting with the early warning and response simulation exercise platform. So this is really added benefit. We haven't done that before, even though we did a lot of functional exercise in the Robert Koch Institute. And it's nice because the observers online could see what is happening. They can see the participants interacting with the dashboard because they saw it on the screen, like the participants were dealing with the dashboard. And also it's really nice for us as the management team of this exercise to see how are the injects working? Is it really working out? Shall we do something else, adjust it, give more time? I think I really recommend it after this experience. And you see on the pictures, our Dutch team at the Public Health POC, they're always sitting over there. And on the other side, the German Public Health EOC, and there's just Clara with her. All right, so just to give an idea, I just talked about a pathogen at the beginning. That's what was the scenario, the general thing we were coming up with. So the scenario was that a pandemic influenza, due to a genetic shift in H5N1, we called the disease resulting in AVID23. I know it resembles to COVID-19, but you know the system. And we had large number of cases and a rapid spread. And we developed the scripts in cooperation with all public health experts within this project. And we had the phases we covered. We had peacetime planning, so to say, the preparedness phase. And we had the response phase and the post-outbreak debrief. And the injects, for all of you who are not familiar with this term, are bits of information about the developing situation. For example, we had a lot of fictitious emails or phone calls or a news briefing. They were used as injects, and these give the participants specific tasks to complete during the exercise. In total, we had 44 injects based on the script. So you can see we had something to do for the 2 days. And the rough timeline you see on the bottom. I just have to get to my toes to see it. And so we started on the left side, the green, only green bottom. It's routine surveillance. The avian influenza is circulating in the birds and mammal population. And then we have the first cases, which could be a sporadic transmission, like we have already. But then we have also human-to-human transmission, and then it's getting interesting. So then pretty soon after that, the WHO declares a public health event of international concern. And then we have, of course, the mask wearing, the non-pharmaceutical measures were routinely added onto this to make it more realistic. And so it all came adding up, the situation, and it's getting more intense, so that it's more stressful for the participants and very realistic. And so the WHO declared a pandemic after a few weeks, and then we following with the lockdown. But of course, we had the Sabin vaccine coming up, so it was newly adapted. So that was distributed quite efficiently, so that we can move on to the next phase, that the pandemic will become an endemic. And so we can finalize this, not really with a managed outbreak control, but it's going on like COVID-19. All right, so just a glimpse for you, because I'm such a fan of this early warning simulation exercise platform. All of you who are familiar with this, it looks, just the screenshot is of this simulation exercise platform, and it looks like the real one. It's the same design, and you can see we have a notification here. So we use that especially at the beginning to comply to the international health regulations. So we also used selective exchange messages whenever they were necessary. So we had also the national focal points involved, so that they were sending from their side to the participants the selective exchange messaging as well. Difficult for German. All right, thank you. That was all I want to present to you. Thank you very much.
Thank you very much, Claudia. Excellent. So now I have the pleasure to invite Carlos Tille, who is a computer scientist at Galway University and who will speak about demonstration of the PANDEM-2 IT training platform. Carlos, the floor is yours.
Good afternoon, everyone. I'm here to talk about innovations in pandemic preparedness training and response. Apologies to people who were here yesterday, because we'll be covering a lot of the same material, but we also have a lot of extra stuff to go through as well. So Francisco, my colleague here, will be introducing Pandem Source as part of this demonstration. And we're presenting on behalf of the tech team, which includes Clarisoft and teams in University of Galway as well. Pandem-2 came out of some of the gaps that were noted in the original Pandem project. So things like better preparing for future pandemics through innovation in IT and training, developing cross-border support tools for public health agencies, and a participatory design process to meet end-user requirements and to ensure that the tools that we developed were useful to end users. There were two general areas that we covered. So surveillance, we were looking at identifying, mapping, and integrating pandemic-related data from multiple sources into a pandemic management database. And then also in the area of reporting, so developing pandemic social media analytics, which Omnia talked about earlier on, and epidemiological and resource modeling tools, which Jim talked about earlier on. And then also to develop a dashboard for pandemic preparedness training and response that was built on top of these things and would utilize them. In terms of the surveillance solution, Pandem Source was that solution, and I'd like to give the floor to Francisco to present.
Thank you, Carlos. So I'm going to talk about Pandem Source. Which is fun is that I cannot show much about what Pandem Source does, because it's like in a car, it's like an engine. You see the car, you buy an Audi or whatever, Renault, depending on your preferences. But unless you are a technical guy, you are not interested in the engine at all. And that's like Pandem Source, because it doesn't, well, like we added some graphics just to feel better, but it doesn't actually have a concrete interface that public health agency will see. But the data there is collected by Pandem Source. And even an agent, I could show it to you, but it's code. So we use some diagrams to explain a little bit how it works, and I will try to point today the issues and the main points of this software. So the aim was to continuous collection of heterogeneous surveillance data into current database, to combine traditional and non-traditional surveillance sources, because we went through requirement gathering process to identify what are the most important variables to perform surveillance during a pandemic, and we realized that it's not just about cases and deaths. It's also about social media, about contact tracing, and many sources, about human resources too. And also, we needed to adapt to rapidly changing data because we did that during COVID. And so we have, I don't know if you remember, there were many different sources arriving in CDC, each government reporting figures, also other consortiums like the Johns Hopkins University also. So things move quickly, and if you have a new threat, you need to adapt. So that is one of the aims of PANDEM Source. Give you that flexibility to integrate new data. And finally, integrate this data and to normalize, enable comparison into a coherent data model. And the output is an open source tool named PANDEM Source to import and visualize public real-time surveillance data. We tested using the COVID-19 pandemic use case. So we implemented and used it during the COVID-19 pandemic. And another thing that I should point is an important aim and feature of PANDEM Source is the fact that it can also generate data. Because some of the data we needed to use during training is not present, and it was not present during COVID, and also during the functional exercise. So PANDEM Source can detect what data is missing and can produce realistic data based on a set of minimal indicators. And the target user are public health agencies that need to collect, consolidate, and analyze real-time surveillance data, but also that can be used for training. And as I said, this is a diagram that explains how, I cannot point, right? No. Huh?
This one here is the pointer, I think.
Ooh. Okay, whatever. No, it doesn't matter. Yes, it does. Ah, beautiful. It does. No, it's tomato. Sorry. So we have a lot of sources that are real-world data, and as you can see, it's a very large scope of kind of data that can come from reported cases, but include a different kind of data, as I already said. And so that's the real world. And then our software, what it does, it takes these data, so it's flexible, so it can plug to any kind of data, and that's the promise we are doing. Whatever data you have in whatever format, you can use PANDEM Source to plug to this data and to get it. And it will go through a standardized process that is shown here into the middle. That is going to, so it's doing change detection on the source, standardization, error control. It will calculate indicator, and it will integrate with machine learning algorithms for the social media analysis, but also for the simulator that was developed by the university, UCL, and also include the feature of data generation. And finally, after this standardized process, it will provide an API that can send data to the PANDEM-2 dashboard. So what you see in the PANDEM-2 dashboard is produced by PANDEM Source, or is captured by PANDEM Source and produced by PANDEM Source, but also can feed other tools, other systems that can be used. And this slide is to give you like an idea about what we were dealing with during the development of the surveillance part of PANDEM Source. So as I said at the beginning, there was a lot of many different sources, and it was a heterogeneous landscape of sources, and we needed to manage to capture and standardize different kinds of data. So you can see, so our main source was ECDC COVID-19 datasets, but sometimes this dataset doesn't contain enough regional granularity, so we went to check other sources like data published by public health agencies, and we use the COVID-19 Data Hub package that allows you to download data directly from public health websites. And but also we have different data, for example, some templates that we use with end users to get data from RKI, THL, and RAVM. We also get data from some projects like Open Sky, or the zero tracker to get information about zero prevalence studies. Some data like the excess in mortality was not present either at ECDC or in the government web pages, so we went through our rolling data database to get that particular piece of data. We also get information about public health resources like beds and nurses from Eurostat, but you don't get ICU beds from Eurostat. You don't have them because Eurostat doesn't have them. And so we need to go to a different source. So all these complications, I'm just trying to explain you that it's not just easy, because if you don't have to do it, sometimes you doesn't realize the inner complexity of mixing all this data and putting into a standardized model. And so that is what we did. This is an example of a screenshot of the interface of the application, so you can see all of the sources, seeing the integration process, and when the last check, when the next check is going to do, and some information about potential issues that were found because of the different validations that are performed. And the key output, so is this data integration tool for heterogeneous surveillance data that includes, as I have been saying, data from traditional sources and non-traditional sources. I didn't talk about participatory surveillance, which was also an important part of this project, getting data directly from InfluenzaNet. And it's multi-pathogen, and so it can do real-time monitoring of sources that was tested during the COVID-19 pandemic, and is flexible by design to add sources, variables, and indicators. It includes realistic data generation for training purposes, including next genome sequencing algorithms. And it has produced 2 reusable data sets that can be used for training. So the COVID-19 dataset training, which is data from COVID-19, including all of the missing data that we generated with Pandem source, and we have an influenza functional exercise training dataset that was used during our functional exercise. Thank you very much.
Thank you, Francisco. So the dashboard was built on top of this. That's where all the data coming from, or all the data in the dashboard comes from Pandem source. So the reporting solution was the PANDEM-2 dashboard. The idea behind this was a single source of truth, so one place where you could go and interact with multiple tools. So as part of this, the modeling team in University of Galway developed epidemiological and resource modeling tools alongside their colleagues in RIVM. And the team as well, the social media analytics team, developed a social media analytics algorithm that Omnia talked about earlier on. So all of these combined, the target users for the dashboard are public health agencies wanting to analyze, explore, or report on pandemic-related data. So there are 3 units within the dashboard. The Pandemic Preparedness and Response Analytics and Reporting Unit, the Social Media Analytics Unit, and the Integrated Epidemiological and Hospital Resource Modeling Tool. The Analytics and Reporting Unit provides visualizations, exploration of data, comparing and comparing regions, generating reports, and saving data. The social media analytics is GDPR compliant. It analyzes the sentiment and emotional state of social media discourse in response to government measures. It also extracts suggestions from social media discourse with regard to improving or changing government measures. The EPI and hospital resource modeling tool support preparedness training, so how the impact of countermeasures and resources on cases, hospitalizations, and deaths. It provides capacity analysis and identification of possible resource coverage deficiencies. It provides a set of models that can be extended to include an all hazards approach and exploring the impact of a pandemic on regular health services. And it provides a technical framework for integrating modeling with pandemic planning and response activities. So I'm going to get into a demonstration of the dashboard now. Before I do, as part of the functional exercise, I took out just a couple of tasks to highlight these. So These were used in the functional exercise, and these were the kind of actions users had to take using the dashboard. So to use this fancy thing here, create situation report, looking at cases, deaths, and 7-day incidents, and then also looking at the social media analytics tool. So to check out stories in the news and see what kind of reaction is happening and possibly how to combat that. Nope. Search. Sorry, 1 minute now. Okay, bear with me now. I have a tiny little trackpad here. So we have 2 dashboards here. So this is the, can we switch to the other tab, please? This is the functional exercise dashboard. I'd go into this in a minute, but first I'd like to go through the real data dashboard. Thank you. So this is the first page that you get when you log into the dashboard. It's an overview page. So there were a few ideas that we had that we wanted to implement with the dashboard. One was that we would start with high-level data, high-priority, high-level data, so that users in a crisis situation could log into the dashboard and see what the situation was in their region pretty much straight away. Then we provided further data that users could delve further into the data and see more detailed data as they went along. We also wanted to provide as much flexibility for users. So we had to give a structure to the dashboard and present data in a certain way, but we wanted to give flexibility to users that they could explore the data as much as possible themselves. This landing page has a number of indicator cards on it. So I'm having, no. There we go. So each of these is related to a page and contains the same high-level priority data. So we can look at cases, staff capacity, bed occupancy, people vaccinated. We can arrange these or hide these. So this is where we provide high-level information when you initially log in, but then also we allow the user the flexibility to generate this page or to organize this page for themselves. So how it suits them at a stage in the pandemic, or how it suits them for their role within their organization. There's one other feature up at the top of the page here, which is important. So these dates here, these allow the user to select the date range of the data within the dashboard, so that during a pandemic, you can have all the current data there, but it allows you to go back and look at specific times within a pandemic. And post-pandemic, it allows you to look at that information as well and explore it for lessons learned. This functionality was also used during the functional exercise training. So this allowed us to load all the data into the dashboard, but then step through the data day by day or week by week to release the data in the public health emergency operation centers. The navigation is done along the top navigation bar here. So we have our indicators, things such as cases, deaths. We have participatory surveillance, primary care. So just to look at cases. So each page starts with the same idea of high-level data and then delving deeper into that data. So we're looking at cases in Europe. The page starts with a map. Each user is associated with a region, so if they log in, they'll normally go to their direct country, but this time you can look at a map, okay? The map component, you can, the map component, you can filter by different data variables. We have NUTS regions as well, so that's the nomenclature of units territorial statistics, so that's an EU standard for regions, and then you can select a region here or you can click on the map to view that region. We also have a play-by-play here, so that if you're starting at the start of the pandemic, you can play through and see how numbers progress throughout the pandemic. Or you can click on the bar and select a specific time during that pandemic. So if we wanted to look at a specific country, so cases in Germany, we have the same indicator card on the left, but it's with more detailed information. So it's same high-level priority, and then delving further into the data. Then we have graphs on the page. Sorry, no, excuse me. Is it possible to fit the screen? I can't see the scrolling bar. Okay, so we have each page is made up of a number of graphs which are showing data. This graph in particular is confirmed cases by. Currently it's showing variant, so we can switch that to gender or age group, and it will load the same graph for that. So each graph has a number of features. You can view it by different filter types, so bar graph and percentage, or bar graph and heat map. We have data range filters, so you can view data by the last month, the last 3 months, the last 6 months, or all the data together. You can view the data linear or log, and then we have the absolute numbers, or you can normalize by population. Each of the graphs have a number of features, so each of the graphs have a map like this, where you can view in full screen. If you want a closer look at the data, and also we have our heat map down below. We have our legend. Which you can highlight areas on the graph, or you can click it as well to remove it. So you can add and remove data and explore the data and view the data as you'd like to see it. Further on the page, in the cases page, we have notifications, reproduction number, further data that's related to cases. So again, we're starting at a high level and then allowing the users to delve further into that information. We have the high priority indicators, so cases, deaths, things like that. Again, each page is similar, has the indicator cards on it, the map, and then going into the data. So reported dates and mortality rate, distribution by sex or age, mortality rate by hospital admissions. So we're presenting the user a lot of data. We're not trying, this is a decision support system, not a decision-making system. So we're providing the user with information so they can make the decisions themselves. On the right of each graph as well, we have this graph options. So you allow the user to collapse a graph or view a graph, and then you can add other, if you'd like to explore the data as well. So each of the pages is grouped by indicator. If you'd like to see different indicators together, you can add a graph to the page here. So you can use search. You can look at this. So we're on the deaths page. You'd like to compare that with cases at a specific time. You can add the confirmed cases graph, and then you can where is our confirmed cases gone? The confirmed cases graph should be on the page as well. So you can add graphs on the page as well, but you can explore the data in other ways as well. So we have an exploration page. So you can add graphs, indicators to compare them on the page, but you can also come to the exploration page and view regions, compare regions together. So allow, in kind of cross-border collaboration, you can compare regions like this and see how various different countries are doing together. So you can select the regions you'd like to see, select the indicators you'd like to view, in this case, confirmed cases, and then you can view that by 7-day average just to normalize it, or you can normalize it by population as well. So you have this data together, so you can compare regions. You can also go into further regions, you can go into different NUTS levels, so you can compare regions within the same country as well. You can save and explore these explorations as well. So you can load previous explorations that you've done, and you can save ones that you've explored. So you're looking at different indicators and you want to save these, you can save them to the system and load them up and show them to another user at a different time. In terms of reporting, so we talked about generating situations reports in the FX. So we have a situation report page, which allows the user to generate their own report. You can edit any features you want here at the start of the page, so you can delete items or edit items here. You can select the region and choose the dates that you'd like to generate the report for. Then with the box down below here, you can add different items. You can add a graph, you can add text, you can add a footer, or you can add a map. So just to highlight this, similar to the adding a graph on a page, you can select what you'd like to show on the map, and that will load into the report. Then you can add further graphs. And build up the report as you'd like it. So we can build up the report, add as many graphs as we'd like to it, add further information to it, and then we can save the report to the system. So if you have to generate weekly or monthly situational reports, you can come along here, you can open up a previous report, or if you don't have one, or you can save this current report. You can save the location, give it a name, and save it to the system. Then if you have to generate weekly reports, you can open up this same report and just change the dates. So if we go up here and we want to do for the month of January only, we select 1st of January to the 31st of January, and the report automatically updates with data for that month. So you can do this, so you have an easy report generation system here that you can come along and just load and change 2 dates, and you have monthly or weekly updated reports. In each of these reports, we have left in high priority indicators. So confirmed cases, hospitalizations, and testing. We figured, or we thought at the time, that no matter what situational report that you're generating, that there will be a certain amount of data that you'd continually like to show. In terms of, then I'll move on to the social media analysis. So we're looking at the functional and exercise dashboard now. So this is the dashboard that is using the data that was generated for the functional and exercise. We look at interventions first. So this is looking at non-pharmaceutical interventions and how they interact with the data. So let's select Germany, and then what kind of interventions we're looking for. And then we can add indicators to the page as well. So we'll look at confirmed cases as well, again. So this allows users to come along, look at a region, and see indicators alongside the non-pharmaceutical interventions that are happening at the same time to provide context for what's going on in the public and how it might be affecting those indicators. So we have full contact tracing here, so you can see these are the dates that these interactions or interventions were taking place, and then we have the cases graph above it. So we can provide context for users. In the social media analytics, we're looking at, Omnia talked about this earlier, so we have top 10 topics. So these are the topics that have been pulled out of the social media discourse that's going on at the time in the country. So we have things like contagion, mask wearing, healthcare worker. We can choose each of those topics. We can see the emotion associated with that. We can see the sentiment associated with that topic. And we can see then over here, we can have a look at how that's progressing over time. We have, as with all our graphs, you can zoom in for a specific time if you'd like to see a closer look at a specific time frame, if there's peaks that you'd like to look at. We also have the emotion analysis alongside this. So that shows the general emotions that are associated with these topics as well. And the volume of these tweets over time. So the volume of these topics during that social discourse. It's suggestion mining as well. So these are looking at the tweets and then pulling out any suggestions that are in those tweets. So in terms of mask wearing, so missing masks, these are the subtopics, missing masks, and then the suggestions within those subtopics. So these have been pulled out from tweets. So make a decent mask stock during peacetime, ensure mask availability. So these are suggestions from users on social media. This allows the comms teams in places to see what's being discussed on social media, see maybe what misinformation is out there that in terms of topics that are popping up that shouldn't be popping up, and that they can possibly generate a strategy to combat this misinformation or to deal with the emotions or sentiments that are coming out of this. To go back to that was the functional exercise, social media analysis. We have had feedback since then, and we have implemented the comparison so that you can look at topics across regions. So you can look at the same topic across a couple of different regions and see how those countries are doing in terms of, I suppose, the response from the public to those topics in those countries. And then also the suggestions from those countries as well. So this allows for a comparison of different items. You can see there are spikes in different emotions at different times. So your comms team can possibly look into this and see why these things are happening. Then the modeling tool. So this allows users to run what-if scenarios within the system. One of the challenges of the modeling tool was how to simplify the process of interacting with a complex model for the users. The model information is down below. It contains assumptions about the model and has a bit of information about the model. So this, again, is part of the idea of data transparency, that we're running these models, but we want to make the users aware of any assumptions that are made within the models so they have that knowledge available to them when they're looking at the results of these models. To create and run a scenario, there are three parts to this. So there's the model configuration. So you're selecting the model that you want to run. You're looking at the configuration, the base configuration to use. So there's a default configuration within the dashboard. But then if you've run previous models and changed that default configuration, the user shouldn't have to do that every single time. So any previous models that you've run, that configuration is there previously. So if you've run a model and you want to change that model a little bit, you can load up that previous configuration and then work from there. We have a basic reproduction number, and then there's the region that you'd like to run the scenario for. Then we're looking at metadata surrounding that model. So this is information for the user themselves, how to name the model so they can find it again or name it relative to what they're looking at, add further descriptions to it, and add any tags that they'd like to add to it so they can search through and find it easily. And then this is where you're looking at editing the model parameters and making changes. We've grouped these. There's I think over 100 parameters. So we've grouped these into different areas for the users so they can find them easier and interact with interact with their regions to see how their regions might affect the model. So in instances, terms of public health policies, looking at vaccines, how efficient the vaccines are, when they're available from, the initial capacity, things like that. Then mobility, are there mobility restrictions in place? Is there testing available? So we have all of these parameters in the model. So, and you can click on the information button there to see what those parameters are and why they're there and how they interact with the model. And then once you've changed those, you can save them and then run the model. And this will give you the information that you'd like to see. Here's one I prepared earlier, thankfully. So, again, there was a lot of information coming back to the model. We wanted to present that information to the user, but again, we wanted to let the user explore that information themselves. So we have, in this section here, we have their exploration section. So this is where the user has access to all the data that comes back from the model, and they can add it to the graph themselves. So these are the kind of outputs that we have, and that the user can select. And then we have apologies. So the outputs are divided into different categories. So the EPI indicators and exploration. Apologies, is it possible that I could come back to the back of and use the laptop back there? Would that be possible? Yes? Okay, thank you. Hello? Yeah. Okay, so we have different breakdown, categorization of outputs here. So we have the epidemiological indicators and exploitation. We have the hospital occupancy and stress indicators. These do not seem to be loading either. I'm just going to have a look at the okay, here we go. So this was the functional exercise modeling page. So we've since rejigged it based on feedback. The information isn't broken down into areas in this modeling section here. So all the information is just above and below. So we have the epidemiological indicators. So looking at cases, attack rate, admissions, and deaths. Then we're looking at resource gap notifications here. So as part of the modeling, we were looking at composite resources. So staffed wards, beds available, see when they are available or if there are any issues within the scenario. And we can see here that a gap in staff ward beds appears on day 170. We can also expand this to see why that gap happened. So the ward nurses, there was no issue with ward nurses, but the physical ward beds no longer were available on that day, and that's what triggered that gap in the resources. We also have staffed, equipped ICU beds. So that is made up of ICU beds, nurses, and ventilators as well. So any gaps in those will trigger a gap in a staffed, equipped ICU bed and its availability. Then we were looking at estimated peak demand versus resources available. So the peak demand for each resource is the highest estimated need in a single day, and then how the resources made available for the pandemic could cope with those peak demands. We looked at other information then as well, so generating a heat map, looking at different resources, so physical ward beds, available nurses, staffed ward beds, and this gives a clear view of where the stresses in the system might be as well. We have a patient Sankey diagram here as well that shows on any given day, you have the day that you can choose here, and you have the patient pathway going through the hospital, so the admissions, and then if they're going to ward or ICU beds, or how many people are being discharged as well. As part of this, there's the stress indicators, so looking at ward demand and ICU demand. You can zoom in and as well on these maps and see when ICU demand is highest. So looking at the model, we have at about day 170 to day 235 or 240. And then a hospital stress code. So looking at how the effect on resources affects general hospital as well. So some routine services may be postponed as the yellow. In orange, then critical services are only available, and then when it gets to black, no more planned work can be delayed, and life or death protocols are put into place. As part of this as well, there's potential additional deaths depending on the scenario, nurse absenteeism, and then again we have the exploration page. So what we've shown before this is data that we have presented and we've generated that will be with user feedback that is useful to users, but again we wanted to make all that data available, and users can interact with it here as much as they want. They can look at ward, ICU, PPE, ventilators, peaks, hospital totals. I was hoping to show here as well what we have. Okay, we have some of the data here that you can add a scenario for comparison. So so that we wanted a situation where you don't want to just run one what-if scenario. You want to maybe tweak it and change things. So this allows us to do that you can go into the system, you load back up your results from the previous time, the input parameters, and then you can tweak them again, run that scenario again, and get presented with the results side by side and compare the two results together. Each of the model scenarios has a number of things. You can edit the name, you can add a description on here, you can get the information on what parameters are within that made up this model, so what has been changed and what has not been changed. And then you can also delete scenarios or share scenarios. Any previous scenarios you've run and saved are available within the system. So this is one of the reasons behind adding data and metadata to the model, is that to the scenarios, that you can save them to the system and come back to them. And having that extra metadata allows you to search through and find these models much quicker and much easier. I think that covers, so that covers the SMA tool, the modeling tool, and then the data analytics and visualizations within the dashboard. I do apologize for the problem with the demonstration. It's always when you're trying to present at something that things go wrong. So then to go into lessons learned. So lessons learned from the process of developing the dashboard is the importance of engaging end users. I think this was across the board. The modeling team worked very closely with RIVM, and their input was critical to developing the model. Social media, we worked with social media, we worked with all the end users. We had a participatory design process where we'd do up designs, we'd send them to the end users, get feedback, and make changes based on that feedback, and then loop in the development team as well. So there was a constant iteration of the dashboard, engaging end users and getting their feedback on that. In terms, I suppose, in Francisco's area, key data is missing or poorly available, so contact tracing data, resource availability, comorbidities. A lot of the problem here is that dreaded acronym of GDPR, which leads to the next point. There's a lack of legal and technical framework for linking and sharing data. And then data as well does not have a some data doesn't have a machine-friendly interface. In terms of the FX, so we had the issue of how to realize data for a new functional exercise focusing on new pathogens and scenarios. So we don't have data for future events, for possible diseases, or for possible pathogens, so we had to create this data for the functional exercise. And how we did that was using PANDEM-2 tools. So the modeling team created a model for avian influenza and generated some data out of that. They created a P2 Synther package as well, which can generate synthetic subgroups of real data, and then Pandem source can generate data as well, and orchestrated all of that data generation together into the database. So that allowed us to have two databases, two use cases. So we had the COVID-19 dataset use case and the functional exercise dataset and use case. And we had the time jumps as shown. So we created the date changing functionality that allowed us to do time jumps for the functional exercise. Finally, why you should use PANDEM-2 tools. So they provide response and preparedness training, cross-border analytics, reporting, social media analytics, and EPI and resource modeling. You can share actionable data with partners, so the data within Pandem source has been normalized and is in the same format, so it's easily shared among partners. It provides service to key public health or CBN stakeholders. It could support other CBRN applications. It can improve existing surveillance databases, and you can monitor or scan threats or disease in open data sources. Also, you can find gaps in different data sources. You can also use it for data generation for your training purposes. The project coordinator is Professor Moira Connolly, and the project manager, Dr. Jessica Hayes. We are open for questions, or if you'd like any further information, please contact one of the team or Moira and Jessica. Thank you very much.
Thank you very much, Carlos. Very good. And sorry for all the technical issues, but you manage very well. So you are mature enough for crisis situation, I can see. And Moira, I suppose we have time for a few questions. So in the audience, the floor is open for questions. Yes? Philippe? No time for questions then, Jessica? Oh, he's here, but I know. I saw him. He's very visible. So, if not immediately a question. I have one for you all, basically. So I like, as you know, to make a bridge between projects whenever possible. So you know that we work on training quite a lot. I'm not going to cite the project because I know that Jessica will be upset. So, but so how to bridge actually when we try to bridge eNOTICE and PANDEM, if we want to do it, something that is striking to me, it's quite complex. I mean, for an end user like me, medical doctor, by the way, so we are not very strong in IT usually. How do you see, what are the requirements in terms of training to use this software both in a simulation exercise like you did, and basically what is the most interesting for the audience in the perspective of a future pandemics? What would be the requirement, what would be the target of this software? I give you the mic. But you have the mic. It's a collective question.
Well, I suppose leading up, we did actually run training. So we had that issue that we were developing this dashboard, but users hadn't used it yet, so we had to train them on how to use it. So we ran a number of training sessions. I suppose our users had the advantage that all throughout the process we were engaged with them and showing them bits and pieces of the functionality that we were developing. So they had an idea before the dashboard was developed, and they had that. But we did run hour to hour and a half long training sessions for users, both in general and for the functional exercise, where we tackled specific items that were related to functional exercise training. So I think, like any system, if you do an initial training and then users use it generally, that they will develop a knowledge for it. It was designed as well that there's a certain level of similarity throughout it. You know, that the indicator pages are formatted the same way, so that it was designed to be as easily usable as possible, you know, even though there is complexity there. And that was one of the things with the modeling as well, is to try and make it as easy for users to use this, even though they're interacting with complex models.
Yeah, thank you. As a non-tech person and as a possible end user, I have to say it was quite easy to get into the dashboard and its logic and to apply all the functions. So I attended the training, and so because we were the exercise management team, we had to know how to operate everything. And honestly, we already had a dashboard as well as the Robert Koch Institute in the context of the COVID-19 pandemic. So we were kind of used to operating a dashboard, and it was even easier to operate with a PANDEM-2 dashboard. Yeah.
If I might add something, is that I think we got a nice experience about doing a training with a dashboard that includes everything that is going on during a pandemic. I can imagine how the functional exercise would have been without the dashboard. It could have been much more directed. Like, you have this graphic and this graphic now, so what decisions are you going to take? But I think in real life, you have a lot of information and you have to try to interpret, and sometimes the people doing the functional exercise were looking things differently about what was maybe expected, and so what was a lot more of freedom and more real life interpretation of data, and I think that is something that make a difference. And also in a different aspect, I think the experience we gain doing the data generation should be can be reused, and our tools allows to keep doing that for other scenarios, producing data for different scenarios, and using the dashboard or maybe feeding other tools. Because it's quite complex when you just have the number of cases and the number of deaths, and you need to create data about social media, about resources, about interventions. So it's a complex topic, and I think we managed to automatize most of that process, and I think that's something that can be reused for other projects.
Thank you very much. Any burning question in the audience? The last one? And if not, then I'll have the pleasure to invite Philippe Quevauvillet from DGOM. Sorry, one. Sorry, Philippe, we have to wait.
Sorry, Thierry Schweizer from the Italian Red Cross. I attend the source training. I'm a bit of a geek. I like computers and stuff like that, but within 20 minutes, I could do it. It's a fairly easy once you have understood the process more than the way of doing it, but how the thinking of it. So it's quite, I like the source part. For the dashboard, for me, it was more difficult because I'm not a medical person. So I see data that I understand, but not like fully understand. But both of tools are beautiful.
Thank you very much. So, but I guess this tool is for Public Health Institute, Crisis Center, and managers. Yeah, okay. So, Philippe, now I invite you for a second time to moderate the panel, general discussion, Q&A session with input from research, industry, policy. That's something you know. Yeah.
Why could I moderate? Because you did all the job, you know.
To be creative.
Yeah, okay. Well,
situation.
You see, I feel a little bit illegitimate here, you know, arriving like a hair in the soup. I'm sorry because I've been between two meetings, and actually one meeting that I attended this morning and yesterday was very interesting for PANDEM because I quoted your meeting and PANDEM-2 because we had a discussion about new projects on health emergencies and health issues, in particular on mobile laboratory. And Sunrise, I think you are involved in Sunrise about health issues, so mobile laboratory for pandemics, but also for infectious diseases related to animals. And I think that your project, PANDEM-2, has a role to play also. You are close to operational here. You are reaching a point where I think you will continue, certainly not in the research landscape, but certainly more in the operational landscape, but keeping a tie with research. And I would encourage you to look at what is coming up in disaster resilient society area, because there are very interesting projects, and to cluster one, because there are also issues, and I recommend you. I see that you have excellent contact with DG ERA, DG Santé, ECDC, but also look at the research programs, because there are some opportunities also to open different doors and looking at horizon. It's not at all for me moderating a session, I'm afraid, but I think that it's also important to look at the clustering aspect. And one other thing that I wanted to say is that we are more and more looking at the citizen dimension. And in our research programming, which I will do over the next year, is to put research which are related to the citizen involvement in research. And here you have also a role to play clearly. Any advice from your community on how to set up clever topics, in fact, that involve the citizen in pandemic crisis management will be welcome. So just I would say a kind of a blinkle to you just to send some comments. Having said that, well, I don't know, do you, moderating this session, I'm just arriving here, do you have any things more to say? It's quite delicate because, you know, just arriving like that, moderate the session. Well, I was very interested by your session, but have you something to say? Please, because help me, because here it's a little bit disturbing. Yeah, please.
Hello, so I'm Virginia from DG Santé, from the Health Security Unit. Very interesting presentation, but I am puzzled by, all this, the platform, data management, surveillance. What about, in fact, these legal frameworks, data protection issues, linking, how do you go? I think there is a big problem there, is it? health data are not so
yes,
treatable.
There is a problem there, but I think it's a solvable problem, you know, to work within GDPR and share data along those lines. The dashboard itself uses all open data, so in terms currently there is no issue with data sharing. All the data is aggregated, so there's no publicly identifiable information within.
So disaggregated data.
Yes, yes. I think Francisco was our data man.
Yes, I think we announced the topic, and it's one of the conclusions we have about the lack of a framework, and I would say even the lack of a platform for data sharing. I think based on where we are now and what are the next steps, I think we need a platform which is already GDPR compliant, in which we can perform public health surveillance at individual level, and that can be used by member states and by research. So we need a way. So it sounds like the European health data space. It could be a good fit for that, but for that we need to create trust into that platform, which I think is far from assumed. We cannot assume that governments and citizens will trust this platform. So I think that's the main challenge. So I think technically we can do it, legally we can do it. The legislation is coming, but then if it is going to be used or not, it will depend on how we build trust into that platform.
Thanks a lot.
I'd just like to add as well that data sharing arrangements could be made within regions themselves. PANDEM-2 could be installed locally within its own area where you don't have a publicly accessible front, so that you could load your own data into it that you have access to yourself. So in those terms, you could make better use of it, possibly with more, I suppose, private data that you wouldn't be sharing, that you'd just be keeping in-house. And then I don't know, I'm not familiar with how organizations might have data sharing arrangements, but that would be possible if you had two different organizations and they each had their PANDEM-2 installation, that they would be able to share data if it was legally allowed.
Maybe it's a question to you, Virginia, but what is the positioning of member states in this respect? How will they, are they been informed about this platform, this tool, and can they, I would say, do they have an incentive to use this platform in case, in fact, all of the next pandemics? How will it happen? And is there links made, for example, to the health committee? Have member states been informed about this?
From a member state perspective, if you have not that high investment into your IT infrastructure, which are some member states are in this position, then they can use this platform. It's freely available, and they can, just like Carlos said, they can load up the data into it, and they can use all these functions and features, so they don't need to create them on their own. So this is really an added value, and I think you don't have to convince anyone in the situation that they can just pick it and use it. And this is really something to sell, I guess.
Yeah, I'm convinced about the usefulness. I'm speaking here about the after-sale. The after-sale service, you know, because you have done a very fantastic job. They can use that. Will they use that? Did you do some communication after-sales service so that to ensure that indeed they know and that they will use?
You mean if Germany as a member state will use it?
For example, yeah. Germany, yeah.
Yeah, well, we already used it during the test trial for COVID-19 data. We already used, you saw it was kind of biased on Germany. And so we use it and we tried it out and everything else. But during the COVID-19 pandemic, it was a bit too late, because we already installed solutions and used them, but nonetheless, we used our experience as an end user and feeded it into the PANDEM-2 project so that we can say, well, this worked out for us, this didn't, and so we are moving in the right direction. So I would say it's really something that's state of the art, it's easy to handle, and thankfully by Pandem source, it's really, you can use any data and feed it into it, so it's quite handy. I would say yes.
Well, so in fact, I'm turning back to my colleague from Asante and ECDC. Well, you are monitoring the risks, like Rescue does as well, you know, because to prepare member states in terms of coordination in case a pandemic arises. What is your feeling about integrating this platform into, I would say, EU tools that can be used to prepare member states coordination in case of pandemics?
I'll give the floor to ECDC first because of the surveillance part. I mean, they do the real job there.
Okay. I think it's one of the things that is missing, a list of those tools produced particularly from the last generation of this type of projects for the member states to be used. We have discussed it many times. ECDC is a little bit reluctant to go into that because for different reasons. And they think, for example, that it's the Commission's work that you should advertise those. But I mean, I found it impressive. I agree that, for example, for the regional level, and maybe there are people here from the national institutes, they should also say what their impression is. I think it would be an excellent tool for any type of crisis, not only a pandemic. Yeah. But it does need some promotion.
So someone has to deal with hot potato, you know, because I'm always getting the hot potato back. In rugby, we call that an hospital pass, you know. You just pass, and then there is a monster arriving, boom, you know. So it's a little bit delicate. But in fact, I will refer to this to the program committee of the cluster 3. But the problem is that they are not engaged with, for example, health agencies or Ministry of Health. So I think that here we have to be directed to member states who are dealing with pandemics response and prevention preparedness response of pandemics. And we cannot, I don't say Commission here in our program. We do have access with the research community and security community. Here it's more to see whether DG Santé or DG ERA can take this over, just first for information to member states. Virginia.
Yes, absolutely. Actually, I was about to. I was thinking of saying something about this in my presentation because I will present something after. So, but as you know, I mean, member states have different organization, administrative levels. They are centralized structure. They are some member states are heavily decentralized. Germany is an example. Italy is an example, and some others are centralized, like France. Then, there I think is a real challenge as well because it's data collection there. It was a real challenge during COVID. But if you add the layer or governance, then it's even more difficult to sell. I agree that at the centralized level, that would work much more. I mean, it's easily applicable, but then it has to find a way to feed up into the information management system. Already using the early warning system, I mean, Commission, as you know, like it's already, yesterday Cynthia has walked you through the new developments for EU WRS, but it's already there, very difficult to move along with the new developments for security exchanges. So yeah, but again, yes, Philippe. Then I'll find a forum for dissemination of this. I mean, I'll talk about it later.
Thank you.
If I might, so there is no more. So COVID is around, but there is no pandemic anymore. There is no public health emergency anymore. So you won't use PANDEM-2 to monitor COVID-19 if there is no issues at ICU and if you are not doing resource planning. But of course, we cannot wait until the next pandemic arrives and try to, oh, look at that. 50 years ago, we developed a tool named PANDEM-2, and it's great, you will use it. Because now we are in the phase of preparedness for the next pandemic, and I think this tool is expected to be used for training. And if you are trained to use Microsoft Excel for doing calculations, when you have to do a calculation, you will use Excel. And in the same way, I think the approach we are taking is to promote PANDEM-2 as a training tool. And that enters into the new ECDC mandate about preparedness, and of course into each public health agency. So I think that's the approach more. I think you may complement that, but I think that's the approach we are trying to follow. And yeah, so I think that's the way how we are trying to address different member states and the ECDC.
Can I add on that?
Yeah, please.
Mart from the RVM, the Netherlands. Indeed, I think the dashboard is really fit now for using doing exercises. I mean, during the functional exercise we used it we were very enthusiastic about it. It also was like all the different expertise is coming together in one room, sitting behind it and covering all these different aspects. It was really great to see, and I think we should really definitely explore how we can further use the dashboard for these kind of international cross-border exercise, because it's really meant for that, with all the different comparisons that Carlos also showed in his demonstration. I mean, there are so many interesting elements in it that are currently not in national dashboards, because they're focused really on the local level all the time, and what's in this dashboard is really unique in that sense. So we're not only exploring it, I would not only explore it for functional exercise, but at the RVM we would also be interested in seeing if we could really use it in a response situation. Yeah.
Oh yeah, I agree. You will agree also with Jonas. It's strongly a tool which is very strong in implementing the decision 1082. Actually, it's no longer. I have a trend. It's a regulation. It's even better. Yeah, very good. Well, I think, you will certainly discuss about this in the last session. Well, yeah, Moire.
Yeah, thanks, Philippe. So just to follow on the discussion, if we go back to the origins of the project, it was in 2017, it was a recommendation, and Agorista was on the review panel with the Commission, and the recommendation was that IT systems in public health agencies were woefully inadequate and were not fit for purpose for a pandemic. So that was the job we were given to do. We submitted the proposal in August 2019, and then we all know what happened in January 2020. So we came into this project with a massive investment by member states in public health infrastructure across Europe. So it was a completely different landscape to what we'd originally predicted. It gave us huge opportunities. It was a really good time to be given 10 million euro to look at IT systems. It brought challenges in terms of data management and the use case of COVID. And now we're at a situation where COVID is done, it's over. But what we've got is a very useful platform that I think could be the cornerstone of EU preparedness training. One day we see what the CBRN network are doing in terms of common training platforms implemented by CBRN centres. We need to do the same for public health. Laboratories are quite well organised around influenza. CBRN are well organised around CBRN, but the public health and EPI side of it is not the same. And one thing we've learned from the defence sector, we've got the Irish Defence Forces here, we need to learn from the military and how they prepare during peacetime. And the only way you prepare is using a standardised tool. The same weapon, the same whatever hose, if you're a firefighter, you want to use a similar fire engine so they're compatible. So and I think the work of ECDC over the past 2 years have really helped that standardization process. So when we talk about contact tracing, we're measuring the same thing. We talk about hospitalization, ICU capacity, we're actually forcing a common understanding of the indicators. We're not there yet, there's still a lot of work. So I think for me, the focus, and it was really good to hear from Mart and RIVM that not only are they interested in looking on this as a training platform, which is safe, it's a safe space, there's no GDPR issues, you know, you can do an exercise over 24 hours and really see how well your capacity is to respond. You can bring in other sectors, you can bring in One Health, you can bring in agriculture sector, you can look at your reporting mechanism for influenza in animals and bring that into the dashboard. You can look at social media analysis, you can model, and you can actually do a flight simulator and implement interventions and see where does your plane land. Does it get on the Hudson? Do you land the plane safely? And if you haven't, you know then next time that you need that actual information, that knowledge, those skills, that you will use them better. And you also build a network around that. So we have within our consortium 6 very experienced public health agencies who've been absolutely crucial. And you've got computer scientists who have really engaged in public health and the world of epidemiology. So it's not perfect. There will be GDPR issues in terms of real data. Contact tracing is a particular nightmare, but we can use this in as a training tool and then see as member states gradually look at this. And we have made a commitment within our consortium that the first thing we do is go back to our ministries of health, back to our member states, back to our public health agencies and says, look, this is what we developed. We in the University of Galway are going to continue to work on it for the next 12 months. We've identified some budget towards that. So the work will continue, and the issue would hope to be, I would hope by this time next year, we'll be able to say we'll do a 1 or 2 day exercise of a cross-border nature using the avian influenza, using the synthetic data generated by Jim and the team. And I think within, or there is no sensitive data on the platform. It's all open source, it's all Orwell data, it's Euromomo, it's, so there is nothing sensitive on it, as it stands. Isn't that correct? Isn't that correct? Yeah. But if you were to go into a real world situation and use it as a response tool in RIVM, then you would have to be looking at those GDPR issues. No. And I think that's where the answer has come, because I think it will be specific to each member state. There's an overlying governance issue, but again, we'll ask the questions, what can we do with contact tracing data to make it useful? Because we saw the experience of Southeast Asian countries, where it was quite draconian. But if we have another pandemic with the same mortality rate of SARS-1, we will have to look at contact tracing data, perhaps, with the issues of individual privacy and restriction of movement, it might get a lot more difficult. So, and these are the questions that come up in the course of an exercise. And I think on counterterrorism, CBRN and all hazards, there's a lot of opportunity there. So I think one positive thing, I've been doing exercises for years. I was in WHO for 15 years, and we did a lot of tabletop exercises with pen and paper. Even the contact tracing tool, the Clarisoft, that came out of pen and paper analysis of contact tracing data in the Ebola outbreak in West Africa. And then we developed an IT tool, and that has transformed how we manage data. And I think when a common IT platform and linked to the EWS SIMEX, that was really helpful. I mean, we used that at the very beginning of the functional exercise. So this, in a way, is an extension of that that is still work in progress. So I hope that answers some of the questions and queries.
Thank you, Moira. These were wonderful conclusions, for this general session, which I've been very happy to moderate. Jessica, do we have another session after, or is it the coffee break now? Okay. So, sorry that just to have jumped here. I'm very happy to moderate this session. Very interesting, inputs that I will come to take back home. And I wish you a nice continuation. Thank you very much.
So I would like to grab the opportunity to give a big round of applause to Maura. I think the moment is right because she just gave an excellent summary of how this project started, not knowing how we would soon be all over our ears in a pandemic. That would actually be a very fruitful opportunity to conduct this project the way we did. So I'm just being bold here and ask you all to please stand up and applaud to Maura and thank you so much for guiding us through the project.
meet you. Sorry to just super very quick. And we have some this my what? Yeah, I was fortunately. I fortunately maybe but we have 2 more mornings. I am not on the main line, but apparently now I am, but I'm not sure what this one.
start the last session. And we're going to start with letting Claudia sort of finalize the previous session before we get into the real final session. So please, Claudia.
Thank you, Anders, and welcome everyone after the break. Well, we discussed a lot the operational strategy already because it's so tempting to jump into this topic because it's really exciting. But honestly, I have prepared some slides for you on this topic. So I'm leading into this, and then I'm giving over to our colleagues from the EU agencies and to follow up with the discussion. So yeah, this is one of the last tasks left in our project, the development of the operational strategy. And so we want to lead you into this. So just because we said it already, but just remind ourselves of the overall project aim. We're repeating here that it's to enable the EU member states to better prepare for future pandemics through innovations in IT and training. So our task at hand, the development of the operational strategy, we are partnering with the University of Galway, Car Communication, and the UCL. And so the topics are here we are covering. We are working with the EU agencies and WHO, and with all stakeholders, partners, you are, to define how the technical PANDEM-2 outputs will be used in practice. So it's pretty hands-on, and in particular in terms of cross-border collaboration. And sharing data, we learned it's a difficult topic, but still it's good to discuss it and see where might be the solution. And also then a part of this is integration of national data sources, and also think of the local information here. And the also important topic is here the strategic perspective on integration of PANDEM-2 outputs into the activities across all member states. So the target group are here the public national health agencies. Oh. So just to wrap up what we approached so far. Most of these solutions and trainings and tools we discussed in detail today. So we're just reminding ourselves with this slide what is there, what we can use. So we have on the left side the IT solutions, we have PANDEM Source, the dashboard, the social media analysis tool, the integrated epidemiological hospital and resource modeling tool. On the training side, we have trainings in communication with the media and the public, and also we have the simulation exercises. We discussed the functional exercise earlier. And so we can test the PANDEM-2 solutions in there, but also we can test our preparedness and response. And at the tool aspects, we have the media training toolkit and the communication toolbox, and also, as we heard earlier, the workforce capacity mapping tool. So how did we use it during the project? The trainings on communication we had trainings for public health partners, and there were practical guidelines developed, especially the media training handbook and the communication toolbox as well. And so the simulation exercise was another thing for training and preparedness and response by using our developed tools in this. So we had one tabletop exercise, so this is the discussion-based exercise, in which we tested the communication part, and in which the tabletop exercise was a scenario on an EU-imported Ebola cases. There were only a few, but as we're all seeing, they are putting a lot and enough stress on the system once you have a few in the EU borders. And so we used the communication there and the tabletop. And then we had the functional exercise as well, where we tested plenty of our tools. The dashboard, including the social media analysis tool, the integrated API and resource modeling tool, PANDEM Source was also a part of it, and the communication part. So yeah, we were thinking a lot, and we were discussing already. So we came up with possible use of the training and the tools to better be prepared for future pandemics. And regarding the dashboard, we see there an adaptable part for an IT training platform because it's compatible with different data sources. It's a part also for a digital surveillance platform to enhance early threat detection and assessment. And also it can be an efficient automated IT solution for countries with low investments in infrastructure. And we also are working on a multilingual approach so that these countries use their solutions in their own national language. And also, we are looking forward to strengthen contact tracing. It's a very important part of it and was missing so far. So an idea can be to import data from systems like GoData. Regarding the PANDEM source tool, we can see here the integrate data from various rapid alert and information systems, and going here in an all hazards approach because we have done all in one platform. And also it can offer interoperabilities between information systems in health and also in the veterinary sector, so that moving more in the One Health direction. And also we discussed it earlier in Galway at our meeting to integrate socio-economic indicators for a whole society approach. The social media analysis tool we've seen today and presented by Omnia. So this is really something that national public health agencies can use in the EU because it runs on European service, so because it's compliant then with the national data protection regulations. It is a media monitoring tool which can fight against misinformation, especially regarding vaccine hesitancy. And also it can analyze text content in 6 languages, and we are aiming to include all EU languages. Regarding the integrated API source modeling tools, they can be used to support training, preparedness training, especially in showing impact of countermeasures on cases, resources, and hospitalization and death, which we already showed during the pandemic, during the functional exercise. And also the models can be extended with other methods so that we can work as an all-hazard approach there, an impact on regular health services, and also on micro-simulations on regional level. And there is a technical framework for integrating modeling with pandemic planning and resource activities. The simulation exercises, they're material for conducting simulation exercises on regular basis at national level. And so we are able to have joint cross-border trainings. And like we did during the functional exercise, extended with the use of the ECDC early warning and response simulation exercise platform. So it's a flexible, easily adaptable stress test and training. And also we can extend it to different exercise goals. For example, cross-border ventilation sharing, operable beds, and also to go One Health. The hospital modeling tool as a decision support tool during training proved quite interesting. And also, like mentioned earlier, the nice thing is that we can reuse the synthetic data we created for the functional exercise, and also the training data on COVID-19 is possible to reuse it again. So the workforce capacity mapping tool, there could be implemented in all EU member states. There are for the agencies, and they can be adaptable to their individual mandate, and also can be used on sub-national level. And also it's a great opportunity to use it to support the mapping of existing workforce, and also to forecast member state workforce needs in the EU, especially to quantify the surge capacity. So there is potential contribution to ongoing work in the EU for Health initiative. Regarding the communication, we would propose to disseminate it all to the member states for improving risk communication capacities to health professionals, but also to the public, to debunk misinformation, which proved to be a really challenge during the COVID-19 pandemic. And it's adaptable to the member states' needs. And also the media training completed is a complement to other media preparation sources on how to build and maintain public trust. And it's a potential use within future European research projects. So now, have you just seen and skipped through all the possibilities we have and can have, I would just go over to the discussion questions. How can the PANDEM-2 solutions be used to support future pandemic preparedness and response activities by member states and EU agencies? And especially, how do the PANDEM-2 solutions address priorities and research and training? Thank you.
Thank you very much. I think the project now is at a difficult stage when it needs to move from being a project to something integrated into existing structures and work. And that's why I'm very happy to have representatives of the different structures that could take this on. I think that maybe we could look at that slide with the products from, I think the second one or maybe the last one, whichever. So we have that in front of us.
Yeah, I think you need to activate it, the technical support. Thank you. The second slide?
I think that's okay.
Yeah, okay.
So let me start to ask Virginia from DG Santé here. I mean, really two questions. One question is, what does DG Santé take as its priorities now when we move out of a pandemic into something where we should be better prepared for the next pandemic? And how can those priorities be sort of mapped to what the PANDEM project has produced so far? Please.
Thank you very much. It is very, very important to us because we have the new regulation that we are implementing. It was adopted last year, published end of last year. And we have a novel article in this regulation that is all dedicated to training. So meaning that there is, we have agreed with member states to work on training for public health and healthcare staff. So definitely PANDEM tools are useful and will be hopefully disseminated at the very least. So just to say, I will go a little bit in deeper in my presentation, but yeah. So from DG Santé side, I mean, there is a full article just for training now. And it was not there in Decision 1082, but in this regulation we have it. So there is, and with, of course, with such a decision comes funding, comes strategy, comes, you know, many things. So we are very happy to have Article 11 that is training in our regulation. Maybe I pass to the other. Yes.
Yeah. So from the ECDC side, I think everything that I've heard this afternoon is extremely interesting. Unfortunately, I cannot commit to very many things, but the use of pandemic source, the use of the dashboard as a training tool, the communication toolbox, and the media training toolkit are going to be extremely useful at the member state level, and you will see some of the lessons that we have gathered that these are things that the member states are looking for. So what I can commit is communicating to my colleagues who are working with training and communication and risk communication to kind of make them, you know, to get them to know those toolkits and see if we can use them definitely. Because also we are few in numbers, and if we cannot reuse what you're already preparing and what actually we have already paid for, it's really really sad. Okay, I don't know if Hera wants to say something. It's okay.
I think we discussed a bit yesterday already when we were discussing about the deliverables and how we can create synergies. And within DG Hera, you know that one of our objectives is also to work on simulations and exercises as a way to improve coordination, decision making, and so on and so forth. We are also developing an IT tool. As colleagues say, it's not that I can commit to something. We know that there are funding opportunities that will come up in the EU for Health. There are some that are currently there. There will be more in the future. And there's also this link that we need to make sure that member states are aware. So, and this, as we said yesterday, I offer, higher stakeholders and maybe some of our governance bodies to where you can go and present your activities. But yeah, we need also to diversify the funding sources. It's not only the EU, but the opportunities are there and the synergies are possible. It's just a way that we have to now start really making sure that they are understood and known by everyone so that we can, in fact, cooperate.
Okay, that sounds promising. So maybe we will let DG Santé say something more about your future plans. Please.
All right, I just... okay. How does this work? There's your presentation, and then this is forward, and this is backward. Okay, perfect. Yeah.
So this presentation I prepared is just focusing on the preparedness chapter of our regulation, the new regulation. My colleagues, Cynthia yesterday already walked you through the very, I think, very element of the regulation. So I'm going to, for the sake of the panel, I'm going to focus only on the preparedness chapter, on which we are now working. I forgot to say that my name is Virginia Arnecki, and I work on health security unit at DG Santé. And we will try to have a very focused discussion, I imagine, on priorities for training and research. So I will just jump into the next slide. Perfect. So as you know, the regulation on cross-border health threats has been adopted last year. And it is, I need to say this very strongly, it has been drafted while responding to COVID, meaning that while we were working, coordinating at the EU level, of course, with member states, all those response measures, there were people working on actually incorporating early lessons learned into legislation. So this is just to give a little bit credit and raise a little bit of the spotlight also on those people that actually work on drafting new pieces of legislation. And this legislation is it's a milestone. If you look at the past years and also at the EU level, we had a decision which was a little bit weaker in terms of obligation on member states. This regulation makes the difference. So, in terms of, I'm going to focus only on the preparedness chapter, which is the second chapter. If you ever want to look at the regulation in, the exact wording, I'm going to focus only on few lessons learned. And the first lessons learned is that, of course, in the response to COVID, we have noticed that we not only were not prepared, like at the level of member states, but also us at the EU level were not prepared. So it was really lessons learned for all of us, for Commission, but also for the member states. So first thing, we decided to actually broaden the framework for reporting on preparedness. So in Decision 1082, we had already a reporting framework on preparedness, which was developed together with ECDC. And this now in our regulation, it has a broader scope. And there is, again, there are lessons learned that is to do with the training of investing in training for the workforce, for the health workforce, because this is also something that came up very strongly. I mean, you know it better than myself. And then also the need for regular CIMEX and testing exercise together. So especially intersectoral collaboration and coordination. So this came up
came out of the crisis very strongly. Which are the elements really that I wanted to bring to your attention here? First of all, we have Article 5, totally new article, which is basically that we have to develop, for the first time, an EU crisis and pandemic preparedness plan. So this is, again, a result from lessons learned from COVID, where Commission is now going to see how to better coordinate with the services and with member states, which in turn will have their own preparedness plan. So this was not there before. So this is also something new that is coming into the forefront of preparedness. The second is enhanced coordination between member states and the Commission. So again, member states will have to update their preparedness plans. They will have to revise their preparedness plans, because you might remember that when COVID broke, many member states didn't have emergency plan. They had influenza, pandemic response, influenza, but they didn't have all hazard, and also those plans were not really updated. So this time we have an Article 6 there, after Article 5 on the EU plan. We have an article that says, right, member states, let's work together on the updating of these plans, and let's work in an all-hazard approach. So generic preparedness. Many countries have, like more of a one hazard to hazard approach, but we are trying to move towards a generic preparedness plan. Then I reached the Article 7, on which we are working right now. It is in the making, so I cannot really say more about the Article 7. But if you look at the regulation, sorry, I have to really make a spot on the regulation. I need to sell the regulation to you, because it is really, really a work of which you are very proud at the Commission. I mean, it doesn't happen every day that you revise those cross-border frameworks for health threats. So, Article 7, it's about reporting on preparedness. So basically now is an obligation for member states that every 3 years they need to report to Commission about the state of preparedness. And interestingly so, in this, we have been working with member states in the Technical Working Group on Preparedness, which we have set up under the Health Security Committee. Under this Technical Working Group on Preparedness, we work, by the way, we work on all these articles in the chapter. The Article 7, we have been working on Article 7, so basically working on preparedness capacity, on the definition on what we put, on which capacity need to be, assessed and reported on every 3 years. So we have 16, 17 capacity, identified 16, 17 capacity. I mean, they are all listed already in the article. And now we are arrived at the finishing line, and those will provide all of us with the baseline after 3 years. I mean, they report at the end of this year, and we will have analysis and data for preparedness, so that we can assess where are the gaps. And of course, we can then support member states in filling those gaps. But I will come back to Article 7 later. After, and then maybe ECDC will also talk a little bit more, after Article 7, so after having done filled this reporting tool on EU WRS, then we will now try to conduct some analysis and studies together with the member states and see where we can support, where there are preparedness gaps. And then
the novel article, which I think everybody should be interested in here in this forum, is the training and knowledge exchange activities for healthcare and public health staff. Here, I finish this and go to the next slide. Now, in this slide, I selected just a few elements from the lessons learned from COVID. So elements that we have added into the reporting tool of Article 7. And so that you can see that we've added European Commission coordination and support functions, meaning that here, member states will report on how they coordinate with us. So again, EU level, coordinated response, coordinated preparedness as well. And then, and this is very important, cross-border, interregional, and intersectoral elements. So here again, I think also it is important to highlight that one of the lessons learned for COVID was exactly this, right? I mean, we have been talking about this for the past 2 days. The need to have at least a multi-sectorial response. So this is right there. So we ask member states, do you have that capacity? Do you have, are you doing this when preparing for a health crisis? Then we also add research and development and evaluation to inform accelerated emergency preparedness. Here is again something very new, but it was a lessons learned from COVID. You remember that, I mean, when we were responding, there were need to understand what is coming next. I mean, what kind of medical countermeasure we need, what kind of clinical trials, I mean, what kind of, I mean, there was like a need for research in response while responding. So here again, we will try to see if this capacity is there in the preparedness planning. Then another element that I wanted to highlight, I mean, there are many, many elements and many, many lessons learned, but I needed to, to focus on few ones. In this reporting tool, we also ask, as per regulation, what are the actions that member states have taken to improve and to address the gaps? And this is, this changed a little bit of the scenario there, because you need to look and see at least every 3 years how, if you are prepared or not. And this is an obligation. This is by law. So we are happy that we can have a baseline to further work on preparedness. So, and we are very happy again. There is a movement also. So the article I think that is most relevant here to be explored a little bit better is the Article 11, and I really invite you to read the Article 11. We cannot read it here. I mean, I know it's boring, but it is titled Knowledge and Skills, and here you will see that Commission will have to organize. I mean, shall let's say organize training on various skills. So we will have One Health. We will have well, the majority of the skills here will be on preparedness planning, of course. So including, of course, the preparedness capacity under the International Health Regulation, to develop and implement the National Prevention, Preparedness and Response Plan. Then, of course, knowledge and skills to implement activities to strengthen crisis preparedness and surveillance capacity, etc., etc. You can see it on the slide. Then, again, here, training as well on cross-border regions. I mean, try to, because again, crises are local at the end of the day. So the very important link here that are those regions linked to each other? Do they have, for instance, do they share their preparedness plans? Are they inter-regional preparedness plans? I know that they already are in some of the European region.
But also there is space, and I also will invite maybe Pandem here to focus also on those joint cross-border training, that dimension as well. We now move to the latest development in our DG and in Commission generally. Okay, first of all, we have the regulation and we are going to implement this regulation. So we are now 6 months into the implementation. To implement this regulation, we have set up technical working groups under the Health Security Committee, which is composed, as you know, by member states. And particularly, we have divided our work into the areas of this regulation. So for preparedness, we have set up a permanent working group on preparedness. Within this permanent working group on preparedness, which has worked on Article 7, now we have carved a training task force focusing on working on the implementation of Article 11. And it has been set up in April, so very young task force, and it is composed by member states and EEA countries. There are focal points from, of course, DG Santé, DG ERA, DG ECHO, and DG Home, so ECDC, WHO, HADEA, of course. And then we will have, and here you are most welcome, and this is what I wanted to say earlier, that if there is a forum where you can disseminate results and raise awareness, this can be one of those fora. The general objective, as I said, is to support the implementation of Article 11. And here we have facilitated exchange, information sharing, contact among EU member states on health preparedness training topics and target audience. So we hope to, we are now starting, and we are now at our third meeting, so we didn't have many meetings, but one of the key objectives here is to develop a EU health preparedness training program. As Cynthia already anticipated yesterday, this is really the first EU preparedness training program. So we will definitely make use of every piece of advice, tangible, concrete result that we can harness from every project out there, being DG Home funded or Horizon 2020, every project that can help us deliver a good EU preparedness training program. Now, for this to implement Article 11, we have launched a tender as it is. We have launched we have a service contract, so not a grant, a service contract, meaning that the results belong to the Commission, so member states. We have signed this contract in January, more or less, and so we are now starting to work on the development of the EU health training program. So our consortium is called EPIC 11, as Article 11. And it is EU preparedness training programs for health specialists, emergency preparedness, integrated courses. And I highlight integrated courses because it's very important. Again, here, not only first responders, not only public health, try to have a little bit of diversity in terms of sectors. You can see the task there. There are 4 tasks. So we are now on the first task, so the identification of the training audience and the training needs. So we are just there. I don't want to read all because you can see, and then I might answer question. But, well, it just started, and those are the ongoing work. So basically, we are working now with the task force, with the training task force, on the training need assessment approach. We are reviewing the key capabilities required for health emergency preparedness and response system used to assess the self-reported ability of country to develop, implement, and monitor emergency preparedness and response plans, and to identify key actors responsible for the planning and delivery of the different capabilities. So first of all, which are the key capabilities? Are still the same after COVID-19? Do we need to revise them? So first of all, identify those core capabilities, then target audience, and so on. There is the training need assessment will be the object of a workshop, which will be held in Portugal in September. So this is the ongoing work on training that we just started. So again, I think there are opportunities for Pandem, eNOTICE and Proactive to come and share what you've been working on, because it is definitely very useful, especially the last presentation. I think we can have a discussion within the task force on training with the help, of course, of ECDC and DG HERA here, which again, I want to stress, we all work together, DG HERA, ECDC and WHO and DG Santé. So it's not only us, but all together. And then also I know that you had a joint action terror presentation, I believe, the first day. So I wanted just to raise also this flag that we have a joint action terror that actually focuses on health preparedness and response to biological and chemical terror attacks, and whose objective is really to create those intersectoral, collaboration between sectors, so between the civil protection, security, and health. And so here, joint action, as you know, are very peculiar because they are actually funded also by member states. So there is a strong, there you have a strong, wish and need. So basically they say, we have identified this as a problem and we want to work together. So that's joint action are normally very strong. And so we are looking also forward to those results in terms of cooperation between sectors. Just today, we're having the CIMEX exercise on cross-sectoral collaboration in the response to a biological or chemical and terror attack. So it's happening again, another simulation exercise today. Now, since we're going to talk about the priorities, the priorities for training and research, I believe this is what we're discussing later all together. Then I wanted to highlight what, for me, for a lot of people here, I guess, the priorities should be. Some of the priorities. So for me, training on cross-sectoriality and multi-sector is a must, and also those aspects of inter-regional and cross-border and coordination with EU level. This, for our point of view, from the EU level, these are very important. Then, in terms of research, yesterday I really liked. I don't know who said that because the audience wasn't filmed, but public health and crisis management. I think maybe yes. Actually, I actually liked a lot. I need my voila. I think you said the need to train public health officials to become partners in crisis management. And people in public health think in a different way. I think we need to do this. We need to have more of network of public health training center to do just that. So and here also, I think that here is what we should be doing. I think somebody else said that as well, for the networks on public health, to do more CIMEX together and understand this different, not so much, worlds between public health and crisis management. Myself, I come from crisis management, so I see the need there to talk to each other more. And then I'm done. Thanks a lot.
Thank you very much. I mean, some very interesting developments that are going on. I think we'll go on and ask DG HERA to give their priorities and what you're doing right now, and then finish with ECDC, and then we can have a general discussion after that. Unless there are some specific questions you need to ask right now. Otherwise, write them down or wait for the panel. Okay, everything clear. Very good. So please.
I'm waiting for the slide. It's there. Okay. Oh, yeah. I'm looking to the wrong place. So good afternoon. My name is Luciana Santos. I think I see some new faces from yesterday. Okay, so I hope I will not repeat myself too much. So I work at DG HERA at the emergency office, and I'm here with my colleague, Maria Loureiro, that also works with us, but in intelligence gathering unit. So in terms of what we're going to present to you very fast, so we're going to identify, or we're going to list some of the lessons learned from the COVID-19 pandemic from the perspective of the European Commission. I'm going to speak again a little bit to present what is the DG HERA, and then we're going to speak about some of the HERA, as we call it here, selected flagships, which is main initiatives that are aiming to work on pandemic preparedness. So as I think Virginia already went through a lot of the lessons learned of the COVID-19 pandemic, I don't know how it is for you. For me, COVID-19 is something that happened yesterday and a long time ago, because I just want to put it behind us. But sometimes we need to take a look back and to see what exactly was happened, especially in the beginning of 2020. And these lessons, they are coming from the first communication of the Commission on lessons learned from September 2020 already. So very early in the process, the Commission started looking at what went wrong, because it was obviously that not all, nobody basically was prepared to deal with the pandemic and to work together at EU level. It's true that we have very limited, when I say we, the European Commission, we have very limited competences when it comes to health, but the coordination of the health response was one that was very difficult to be managed. You know, as we were seeing the hospitals filling in and lives being lost, countries, they just started with predatory practices on procurement. They were blocking imports. They were just basically bypassing everyone. I don't know if you remember the story in the United States, the state of Washington. They bought masks from China. They had them transported in an airplane to a location that was not disclosed. They were guarded by the National Guard, which is a state National Guard, because they were afraid of the federal government of the United States coming in and stealing, stealing is not the correct word, don't say it outside, but, taking their masks. So this was the level of, let's say, complexity that we arrived, because everybody was basically running after for the exact same products. I think my own country, Portugal, they bought some ventilators from China, and they're still not used because there were some, items that were missing. Half of the ventilators came, the other half, God knows what happened to it. But there were good things also. For instance, research started very early. And there was a lot of data that was being exchanged between the countries. There were a lot of research, clinical trials that were being implemented. I think that in Europe, we had more or less 600 research clinical trials. The problem was that they were very small, they were not coordinated, so the data is not always possible to compare. So this is an issue. The other good thing also that happened, and we all remember, and I guess we all have our 3 shots at least, was the COVID-19 vaccines. They were, I guess, developed in 6, 7, 8 months, absolutely extraordinary, but then where are the factors to produce them? Where is the equity? How do we ensure that everybody in the world, regardless of where they live, regardless of their nationality, religion, economic power, social status, so on and so forth, they are also getting one vaccine, one shot in their arms? So these were problems that the Commission saw very early on and that we started to work on. Virginia now and Cynthia yesterday, they already spoke about how the Commission tried to enhance coordination at EU level, and I guess the colleagues will also speak about how ECDC had enhanced mandate, the EMA also increased their mandate, and then we have the creation of DG HERA. I would say the best decision. I'm joking. So DG HERA, the Health Emergency Preparedness and Response Authority, is here to look at the entire value chain of medical countermeasures. So our mandate is limited to ensuring the access and availability of medical countermeasures. That's, this is our remit. We are, of course, working under the treaty, so we are working only on cross-border health threats because that's the only coordination power that the Commission has. And by health threats, we understand everything, be them man-made or natural health threats. So we will respond to a pandemic just like we'll respond to a chemical or a nuclear attack, for instance. So the idea for DG HERA is to keep a constant eye on what are the risks, on what is being developed in the market, on making sure that these products, innovative products, they reach the market, and then on ensuring that they also reach the member states, because in the end, we want vaccines in arms and not vaccines in a warehouse somewhere. And I will pass on to my colleague now, to Maria, who will speak a bit about the HERA flagships.
Thank you. Yeah, so I'm just going to really give you a couple of examples, a selection of examples, let's say, of how these lessons learned impact the actions and the work that we do at HERA every day. Starting with my personal favorite, the intelligence gathering and threat assessment activities at HERA, they have 3 main goals. One is to pick up on signals and threats that require a response in terms of medical countermeasures, and then prepare this response, basically. Obviously, these threats can come from a pathogen itself, or they can come from the lack of MCM response or a problem in the supply chain, etc. Then we also need to provide an anticipatory assessment of the health threats that are identified, and then the response options for concerning medical countermeasures, and then obviously tracking the medical countermeasure supply chain and addressing any vulnerabilities that may exist in these supply chains. So in order to tackle this activity, HERA has recently launched a call for tenders to develop an IT system that will be helping with the intelligence gathering and threat assessment tasks. And this is Athena. Athena has 3 main goals. The goals of Athena, the 3 main goals correspond to 3 main lots. The first lot will be for the development of really like the backbone, the basis of this IT system. It will count with a survey module, a case management module. This is for the cases in terms of public health and medical countermeasures. And this will run for 2 years, I think. So in 2 years, the backbone of Athena will be ready to start getting used by the policy officers at HERA. The second lot will conduct a functional analysis of other Athena modules. So, for example, the module for linking with the IT systems of other stakeholders to gather data, to share data, etc. The threat assessment module, and the simulation and analytics and the emergency response module. So these will be further analyzed based on the business needs. The functional and non-functional requirements of these modules will be drafted. And then, while Athena is being developed, it's important that HERA still has access to data to guide the intelligence, the threat assessment activities. Therefore, we also have 1 lot to gather market analytics on medical countermeasures and on public health intelligence. Athena also, with Athena came the need to make sure that the IT systems of member states are interconnectable with this HERA system. So we have the EU HIP. It's an action that was set up by HERA to support participating countries in making sure that their IT systems are interoperable with Athena, enhancing and improving their national IT systems, and also either building new IT systems or aligning their existing IT systems with for intelligence gathering on health threats with Athena. There's also a focus on promoting data comparability and streamlining the reporting coming from these systems to the Commission and among the different participants. And I'm also going to tell you a little bit about other actions that were obviously influenced by experience that we had with COVID. And the two examples that I brought have to do with wastewater surveillance and also with increasing genomic capacities, both at EU but also at global level. One action that we have, again, this is just an example, we have even other actions on wastewater surveillance, but this joint action that we have, the goal is to increase the surveillance capacities, including metagenomic capacities, to control infectious diseases and antimicrobial resistance. And the idea is to integrate wastewater surveillance systems into other types of routine systems that are already in place for surveillance, and increase the monitoring and the early warning for future outbreaks of these other health threats. We also have the HERA Labs lab network. This is the Durable, also known as the Durable project, and it will include 18 European laboratories that will be providing scientific information for European efforts to prepare and respond to cross-border health threats, and they will be providing information on the development of diagnostic tests, for example, identification of characteristics of the pathogens to support the development of novel countermeasures, for example. And this initiative is coordinated by the Institut Pasteur. It was launched recently. And again, this is just one example of the type of international partnerships that we have. There's a cooperation with WHO AFRO to scale up the capacities for pathogen detection and characterization of pathogens in Africa, strengthen the human resources for genomic surveillance, and also enhancing data management and data sharing with other stakeholders. Anything back to you?
Yes. No idea. So we also have, and this is immediately also a lesson learned from the COVID-19, and it's a project that started very soon, what we call EU FAB. So it's a way that we have found to ensure that we are able to reserve manufacturing capacity for vaccines in the EU. So this is a network of different vaccine manufacturers that will need to ensure that they are able to produce a certain number of vaccines, and it should go up to 700 million doses in 1 year. And they would be obliged to ensure the production of at least half of that in the first 6 months. So it will be vaccines that maybe they develop themselves, or vaccines that were developed by other companies. And these are the 3 types of vaccines that will be covered by this contract. To make sure that next time a pandemic hits, we have the capacity to very fast scale up the production in the EU. So these companies, they will have to prepare during, let's say, peacetime, so in preparedness phase, they will have to demonstrate that they have preparedness plans that ensure that they are able to source the materials from the raw material up to the end and to the production. So they either have to demonstrate that they can purchase in the EU, or they have stocks in their companies to ensure that the production will actually take place. And when we activate this resource, we will have a preference right towards these vaccines. So in principle, it should guarantee us up to, as I said, 700 million doses of vaccines in 1 year. And there's also a project, I think, that is quite close to our hearts, at least our hearts in the emergency office, which is the stockpiling done with HERA and with DG ECHO, so the European, the Directorate for Civil Protection and Humanitarian Aid of the European Commission. I think you probably have heard of rescEU. So rescEU is an initiative of the European Commission that was immediately response to the fires in Portugal in 2017, when the Commission decided that it was necessary to ensure at European level capacity to respond to some disasters. It started with fires, it moved on to medical capacities, and at the moment it ensures, for instance, medevac or a certain number of stocks. Relevant for you would be the medical and the CBRN stockpiles that are established in different EU member states, because the idea is that they are deployable in less than 12 hours. So these are physical stocks distributed throughout Europe to ensure that we are able to reach as soon as possible a country that asks for these stocks. These are situations of overwhelming disasters, let's say, when the capacities of the member states are completely overwhelmed, because the idea of rescue stock is that we go for the low probability but high risk events whenever a member state or an international, a non-EU partner is not able to deal with the situation. So as you see, the CBRN stocks are now currently being established. The first 4 are in France, Finland, Poland, and Croatia. We have currently another call that is being evaluated now to further develop these stockpiles. We try in as much as possible to discuss with the member states and also civil and military authorities, but also with NATO, to try to see how our stocks are complementary. But again, all data protection issues, all sensitivity and all confidentiality that you know so well around this type of items is sometimes a very big obstacle or something that we try to bypass, but it's not always easy. But the principle is a member state has, of course, the obligation to respond first, and then if they are not able to, HERA would come in with DG ECHO and we would deploy these assets. Finally, and I already spoke a bit about it, and Virginia spoke also already about trainings. Our part of trainings as comes regarding DG HERA is, of course, limited to medical countermeasures, so the management of medical countermeasures. So our objective is to ensure that member states, they share best practices. This is not only for the management, for instance, of stocks, but also for research to support policies. For instance, research policies on development of medical countermeasures, on how to ensure or how to encourage production in the EU. So the goal is to go from the policy making, to go from the start of the MCMs up to the end of development, up to the end until the response coordination. So we will try to ensure training and also exercises that will be able to foster a common understanding in the EU, how coordination and how response and how decision making and how information sharing should pass along all member states. As I said yesterday, our target is public health, national authorities in different member states, but we will try to see how we can englobe different groups, different sectors, because I guess this is more than obvious that we cannot only rely on, a public health response goes much beyond just the public health sector. And I think that's it for our side, so thank you so much.
Thank you.
Last one. Okay. Hi, everyone. I promise I will be very fast because, the presentation was mostly on lessons and what ECDC did. But I think you're mostly interested in what we're doing. So I will go very, very fast. You know ECDC, but we grew a lot during the pandemic. This is what we do, mostly on diseases, but also on some cross-cutting issues. Our biggest challenge, of course, was the COVID pandemic. We haven't gone through such a big crisis before. And you will see there is a timeline in our website if somebody is interested. we remained in what is called the public health emergency level 2, 1100 days. That was the first time we've ever done that. We've gone through 2 restructurings of the plan in order to be able to do that. So that was one of the biggest lessons we had, that some crises are really protracted, and we were not ready for that. And of course, these are some of the things that happened as COVID was evolving and the pandemic. We mostly worked, myself, I mostly worked on guidance. These are our weekly reports, which are still produced every week, and we tried to summarize in a, let's say, in a way that everyone would understand in public health and a little bit in policy making what is happening. And at the same time, at some point, if somebody remembers, we did this level of concern scores for all the countries and for the EU as an average. Of course, we increased a lot our bioinformatics team, and that kind of increased all our capacity in reporting on the new variants and following up on them. And of course, this a snapshot of what we were doing every day, every week. A lot of raw data were made available for everybody to download and work with. What we realized at some point is that we had to kind of consolidate what is happening with COVID in one working group, and we created this strategic analysis of variants, which is a SAVE, we call it a SAVE group, which was meeting every week and was reviewing what is happening from the micro, bioinformatics, EPI, what was in the news, the vaccines, what the countries are telling us and everything. Modeling, again, we increased our modeling team, and there were 2 things: the forecast hub, which was giving forecasts per country every week, and they were creating some scenarios, and this is, for example, a document that we produced with the scenarios that we thought what will happen. And the lessons. I want to stay here for 1 minute. This is work that consolidates, again, lessons from different activities, from inside the ECDC and outside from the countries. As you see, the first one is investment in the public health workforce. And this, as far as we are concerned at the ECDC, we do offer the landmark projects of EPIET and UFEM. Capacity building, a lot of training material, simulation exercises and all that. However, if the countries do not invest in public health workforce as a career, we are in danger of losing a lot of people. A lot of people are under pressure, they're leaving. A lot of people are aging and they're leaving the profession. So this is actually a huge issue. And without the public health workforce, none of the other pieces can work together. Preparing for the next public health crisis, of course, you heard also Virginia's favorite regulation. Together with that one, with the cross-border health threat, came another regulation for ECDC, increasing our mandate, namely asking us to do the assessments every year, the famous Article 8 assessment, and also providing from now on recommendations. This is a lot of, it changes a lot our work. We're also preparing a lot of the material, kind of, again, drawing from the lessons and from our review of what happened with the non-pharmaceutical interventions to kind of offer the member states something to work on their preparedness. But a lot of the countries have said that we are updating our plans, which means that now is the time to offer them the tools that you have created. Risk communication, we put it as a separate piece of the puzzle because all the countries identified it, and even the ECDC ourselves, the experts from the ECDC said that it was the biggest challenge in this pandemic. And it was not only we have a risk communication strategy. a lot of the public health institutes said we didn't have anyone trained for media training. We didn't have any capacity to do misinformation, disinformation monitoring. We cannot do social media. I mean, these things are real, okay? So again, what you have produced will be really helpful, I think. And this is something that we are starting again to work, hopefully offering mostly training and training material. And then last but not least, the collection and analysis of data. I think all of you have gone through this, and what we saw during the pandemic is that we had to diversify our data collection, connect with different registries, try to get data from different sectors, all this, but most of all, make our surveillance systems up to date, more agile, able to surge capacity. These are things that need to be done now. A lot of countries have already said we're working on it. Our operational guidance says do integrated surveillance for respiratory viruses. It's not an on-off thing. It will take us some years to make it work. We are also working more on our TESI, our big collection of data system. And the colleagues in surveillance are kind of revising the whole mandatory surveillance. We are working on all our other platforms. We're working on how the reports will look from now on. But again, I have to come back to the public health workforce. We need to find a way to strengthen and see what will happen in the future. Okay, that's for me. Thank you.
Thank you very much. I mean, you really put in a lot of information that we can probably spend days discussing here. But I'll give you the possibility to have questions from the floor. But let me start with one, I think, overreaching thing that comes back all the time, and that's intersectorial collaboration. It comes back in almost every area. And I wonder how you're going to operationalize that, because now I can see that in certain areas there is more to be done. I mean, you talk about training the public health workforce, but we know that the pandemic is not going to be controlled by the health workforce. It's going to need a whole of society approach. And how do you see that training and other parts of what we have now discussed? How are you going to be able to make it operational on an intersectorial level?
Maybe I go first. First of all, the targeting. When we develop the training programs, we will also target, and that targeting will be already inclusive, let's say. So, or I think we start from there, from the basis. So look at those stakeholders that are relevant in crisis preparedness and of course response. And then I think one tangible, what would be nice to have, and again I am repeating something that I heard yesterday, is if we have, as a minor result of our work on training, to have really those training center, a network of training center, just doing that. I mean, taking into account this cross-sectoriality and providing training on that. I think we are good if we have those network of training center on public health and law enforcement and civil protection. Etc. Also, I came from Umeå, which is in Sweden. I mean, two weeks ago, I was there to attend a conference of the Association of Law Enforcement and Public Health. I mean, for instance, those examples. I mean, an association of law enforcement and public health. I mean, I don't have seen many of these in Europe. So also that, I think it's a good it's a good example of how the future could be. So this is what.
I think the most important thing is to build on what went well in the pandemic, and this is the time through after-action reviews, maybe, but also kind of working with the people that the public health has worked, like in education, transportation, in interior, civil protection, kind of establishing what went well and also building that in the preparedness plan. If it's not in the plan, it will not happen, because then the other ministries have to also sign this famous plan. Otherwise, it's just a health plan and it's a theoretical thing, okay? So it's a, you know, it will take some time to build this, and it takes a lot of personal commitment, a lot of personal relationship with the other sector, but also a lot of trainings, a lot of simulation exercises, maybe this type of thing.
Yeah, and that's just to remind all of us of some of the major failures during the pandemic, and that was reaching vulnerable groups, which also means that you need to involve people from definitely other sectors that you are normally maybe working with so much, and also the elderly homes and those structures. So I think we really need to think very broadly. We cannot get stuck in health and those blue light services. There are plenty of others around that needs to be involved. Hera, any comments on intersectoriality?
Yeah, in my my particular field of work, I think listening to different sectors also means trying to get information and data from the places that you normally wouldn't go to. And this was definitely a lesson learned from COVID. Sometimes you need to go search in the hidden places and talk to people you normally wouldn't speak to try to get more information to aid in your decision-making process. At Hera, we were working on this during the COVID emergency, and now we are implementing those lessons learned, and we're trying to mitigate this issue also with Athena. So, for example, this week we're already meeting with the Copernicus Health Hub to try to get satellite data, for example, on meteorological data, to try to inform the threat assessment process and also the preparation of a response to a particular health threat. This is particularly important in environmental health threats, vector-borne diseases, threats caused by exposure to extreme heat, etc. So this is essential. Also going to the private sector, looking at commercially available data. Also going, for example, to Europol. We've been meeting with Europol to try to get information on chemical threats, try to get information on bioweapons that could be a threat to us, and that can be something that we need to prepare for. So all of that, also for us, it's also a way of involving different sectors in our threat assessment activities. I don't know if you want to add something.
So just to complement from the point of view, for instance, of the emergency office, one of the things that we're trying to do is to map all relevant actors within the member states, but also at EU level, and trying to create this network. Because in the end, when the emergency comes, you need to know who to contact, and you need to know who has the capacity to respond, where, and how fast. So this we're trying to establish. But of course, you know, when COVID hit, everybody gets, or when a pandemic hits or when a disaster hits, everybody gets into working mode and everybody cooperates. The problem is to keep these networks and to keep these links. So that's why, for instance, one of the solutions that we think will help will be through the exercise and simulation. So try to involve these people, or try to involve different groups and different sectors in as much as possible to also to smooth up and to work on our communication links, on our information sharing, to make sure that everything is working correctly. Just to give you an idea, for instance, also even within the Commission, sometimes it's difficult. So we are, for instance, we established a memorandum of understanding with DG ECHO. We're now developing standard operating procedures so that we know who to contact when something's necessary. This exists already at corporate level, but we are doing it at service level, so just between us. So, and we keep, for instance, weekly coordination meetings. So I guess that this is a bit the way forward, is to make sure that the information is passing, which is already, we all have to say no, it's already a challenge. So once the information passes this, how to make sure that it keeps circulating and it reaches the correct person. So for us, it's either through the creation of these networks and then through the simulations and the exercises.
Thank you. And Maura.
Okay, thank you all for the work you put into presenting it, and it really does help for us to understand the role of your agencies, your respective agencies. And I think it's a very positive thing. The regulation now gives you that, I thought, that ability to make a change, make a difference, to strengthen pandemic preparedness and response. So the question I had is about, if we look back at the pandemic, we had an estimated 700 million cases reported officially, 7 million deaths, but excess mortality is in the range of 23, 24, 25 million. That's nearly half as bad as Spanish flu in 1918. So the question I have is, not only was that essential, the issue of regular care, I think in terms of a health community, we dropped the ball on that. I think we're looking at really significant mental health impacts in terms of closure of schools. We currently don't measure the non-health, even beyond COVID. We know how many laboratory-confirmed cases occurred in Europe. We know how many people died. We know how many people were hospitalized for COVID. We have very little information on the broader impact. And we really need to get our indicators, or we need to do this better next time. We need to be able to monitor the impact of school closures. We need to be able to have indicators that support our epi data that allows policymakers to make that decision. And I suppose the question is, ECDC, your focus is very much on infectious diseases, okay, broadening out to an all-hazards approach, but at what point do you bring in, and it is a whole-of-society approach, and I'm based in Ireland, so we had one of the most draconian lockdown measures in the world, and there was some concern that our public health structures and our NEFIT, or National Emergency Team, was too focused on public health. So I'm wondering at what level of the Commission could recommendations come, because in a way it's almost at the level of the head of state how you do that. So it's a question. I think we have to do it better next time. I was part of the decision making with the Department of Health. I was part of decisions to keep, I tried to open universities. I tried to get, because as far as I was concerned, it was the older age group who we cocooned, but we shut the entire society down. So I think it's a broader question, but it's all about data. And if we don't measure it, we don't know. But who can actually put that together? One of our last meetings in the plenary session in Galway, we actually came up with a list of indicators which feed into the dashboard, because it is quite comprehensive and more detailed than what a standard member state would collect. So I suppose the question is, at what level, where in the EU could this be spearheaded and be supported? Or if you think it's a good idea, that's the other issue. Anders wants to say something here.
No, just that we are coming back to intersectoriality and whole of society approach again. And I definitely agree with you, Moira, as you know. We have been reasonably good at tracking the COVID cases we found, but we have not really looked very carefully about all the other effects, both of the COVID itself, but also of the measures we've taken. And I think that's for us to take the right decisions next time. We need to be able to measure both those sides from early on. Now we failed miserably when it comes to measure the second part of it. But ECDC might have the solution to this.
ECDC, yeah. So we did these two meetings with experts, one last year and one this year, on monitoring the non-pharmaceutical interventions. So even from last year, where we were, still handling the pandemic, and mostly this year, one of the basic recommendations, which will be in the document that we will eventually produce, is that our advice to the policymakers should be, do not implement something that you cannot monitor, and have a big net to see the effects of what you are implementing. And of course, it should be time limited, it should be evaluated very frequently and all this. And one thing that I forgot in my lessons is that in the risk community and community engagement part of the lessons, one of the biggest things that came out is that, of course, we need the input of behavior and social scientists in the production of our documents, and particularly in how we shape the measures, actually. One of the good examples that was in the last meeting was from the Netherlands, who said that they have developed and incorporated a social science, if I'm not mistaken, group, which is going to be part of the basically crisis management organization, a structure. And they will be continuously monitoring and advising, which is an awesome idea, yeah.
So this should also be probably be part of the pandemic plans, that you know what you're doing, at least a little bit better than this time. Please.
I'm from Israel, and I would like to go back to the misinformation that I think is a very polite way. We call it infodemics. And I think that we are undermining the impact of infodemics. In Israel, we see a decrease in normal vaccination rates. We had a polio outbreak, and the attempt to vaccinate kids who were not vaccinated failed, and we can see a direct link to COVID-19. So my 2 points about that. First, we have at the moment no tools to deal with infodemics. We are fighting the old war, the war where we had press conferences and media releases, and we don't understand really how to deal with a situation that we have the best experts, trained person in front of a camera delivering a message, and while he or she are delivering the message all over social media, it's bullshit, it's wrong, it's fake, and for a very interesting reason, they have more impact on society than the expert. And at the moment, we are really hopeless. So when it comes to research, we need serious research about, okay, what can we do with that? What tools, technological tools, we have to understand that something happened because we are not monitoring all WhatsApp groups, Twitter, etc. And the other thing, and I will be very harsh here, is there any dialogue with, for example, DG Justice about legal measures? Because it's one thing, and the WHO said it very clearly, it's okay to be hesitant, to have questions, to have doubts. That's part of life. It's absolutely okay. When someone deliberately is spreading news that they know they are wrong, are we having this, this discussion? It's a very important societal question that comes together with draconian measures about the closures and things. And maybe it's a discussion that we should have for the next one.
Thank you. I mean, it's a very important...
I know I was provocative.
No, not at all. I don't think you provoke anybody. I mean, but this is a very important question, but also a very difficult question, because we're getting very close to our open societies and Freedom of Information Acts and many different things like that. But I think you definitely have a point. We need to understand better how we can interact with these forces in social media.
Yeah, thank you. I absolutely agree on this. It's really an important issue. We all experienced it during the COVID-19 pandemic, how difficult it is to get our message out and that it was received and well received by the public. This is really still an ongoing challenge. But honestly, my PANDEM-2 colleagues know me because I'm a trained infodemic manager, trained by the WHO. And so I really enjoyed this training. I did it during the pandemic because this program just started 2 years ago. And so it's really promising, the work around Tina Purnat, who is leading this initiative. And I think there's really something developing. They just released a methods paper and a methods book about how to counter and to tackle infodemics and misinformation, disinformation. I know there's still a lot of work to be done, but this is really promising work. And also it's good to see how public health agency needs to adapt in the future, because we are used to be very accurate, and we took time for it to be accurate because we needed all the evidence to be there. But in a pandemic situation with ongoing misinformation, we need to be faster and answer faster, and this is why we also need social media analysis tools that we can use so that we see what is going on online, and not that we get all over us the misinformation movements we haven't realized before. I think we are on the right way here, but still a lot of work to do. Thank you.
Any? Yeah, and sometimes I can also feel that we have to be a bit careful because social media is only a very small minority of the population. So we need to also have tools to understand what the population at large, where they are, so you don't sort of counteract that. I see Jean-Luc got hold of a microphone, please.
If I can, just a comment on what has been said on infodemics, which is absolutely true and very, very important. But I think we forget also that it has been a pandemic of experts that are not all experts, first. And secondly, there have been a pandemic of journalists who have no training and no understanding at all. And they have a strong impact on the population which read them. So I think it's not only bad people, you know, fighting vaccination or fighting this or fighting the expert. I think, as you said rightly, that's the whole society that has a role into that. Journalists need to be formed, educated to the biological reality, and expert, when they are this designated expert, they need really to be the expert and the voice of something that is recognized as the truth or as the message coming from the government and authorities. If not, they should shut up. But these people influence really strongly and feed the infodemics. That is my opinion, at least. But I have a question, because I've seen all of you also using the word training, and we are all convinced that training is one key element, of course. So excuse me if it's a stupid question, but I understood yesterday, that will not be the first time I ask a stupid question, by the way. I've understood yesterday, when this was also commented, that e-learning was the key of your training strategy. So my question is based on a survey that was done during Pandem, by Pandem, actually by my group, on first responder perception of the information they had on the pandemics. When I speak about first responders, they came all from Portugal. More than 1,500 for first responders were interviewed and responded to the questionnaire about their perception of the information they had on the pandemics. It was striking that they say, we have no access to updated information. Getting information accurate is very difficult. We come back to infodemics, because these people, they also have contact in the environment, and if they don't know what to answer, it's a problem. So do you think, that's my question, that e-training is enough?
Well, I think maybe it's a rhetoric question, but of course it's not enough. E-learning only, no. I don't believe that. We definitely are human beings, and I think hopefully we stay that way. That we need to interact, to know each other, and to learn from, I would say, the human the normal human interaction. So I believe that we have to have a mixture of course, e-learning, but also regular training, CMEX, physical and physical. I don't think we can avoid to do that. I mean, we should not, in my opinion, then.
No, and then, of course, that's where your dashboard comes in. It's like, I mean, having an easy, user-friendly way to present what is happening accurately is extremely important. And these are the capacities that we need to build now in order to have them in a future crisis. And actually, this is how, at least, again, I refer to that meeting that we had because we had also some communication experts who said, yes, despite all that is happening, you need to rebuild your position as a trustworthy source of information. And then when the crisis hits again, then you will have your position already. I have to say that that's what happened in Sweden. I mean, people there just trust the system. I mean, okay, this, we can talk about it forever, but yeah, so then their source of information is public information, period. And if you make it more user-friendly, then yes, everybody will access it and they will know, okay, yeah, we have 3,000 cases and yeah.
No, but, I mean, definitely trust is at the core of it, but building trust takes time. And you need to understand, you need to build trust in all different parts of society. And in Sweden, we were very good at having centuries-old trust among the majority part of the population, but we didn't build that trust with our newcomers. And that really proved to be a big problem for us. So I think trust, and you need to start building it today, because if you try to start building it when the crisis hits, then you're way off. Please.
Yeah, I had a comment that was triggered by a remark of, I don't remember who, about the integration of other types of indicators in such a dashboard. So I was thinking that I was part of a discussion panel a few months ago from the Pandemic and Disaster Preparedness Center. That is a center developed by Marion Koopmans in the Netherlands. And they will publish a white paper next week, which will be in Dutch, but I think Google Translate will help you. Because they were speaking to a panel of economists, the social scientists, but also the Center for Statistics, and they came up with a framework on how to really integrate economic indicators, social indicators, in, and then, of course, aligned with biomedical indicators in pandemic response and policy advising. And it was really tough, but the atmosphere was good and people were really open and really understanding towards each other's viewpoint. And I felt that that meeting was very innovative because we all feel, you know, this was a big struggle and a big eye-opener during the COVID pandemic. So I really appreciated their attempt and their effort to at least try to incorporate and combine also economic indicators. And I don't think they provide the full answer, but I really would like to draw all of your attention to that paper that's being published next week and that then you can hopefully translate using any online translator. Yeah, that was it.
Thank you. I'm sure we'd be happy to share that in the system. And I know there is a number of other, OECD is also having a development in the World Bank, and there are a number of other actors who now in the aftermath understands how important it is to follow more than the number of deaths every day, for example. Any other? Moira has another issue.
Can I ask another question? Is that okay? So I've got a question about prevention. And it is a security project, and the risks are greater now than they were 10 years ago, 5 years ago. So I have three components, and I suppose the question I'm asking is, what is the Commission doing in terms of prevention, and what is the plan over the next, because it's not just to prepare member states for a response, we also have to look at prevention, because having worked in WHO, there are colleagues there who said that at the very outset of the pandemic, if there was early warning and if state parties followed the IHO regulations, we could potentially have contained the initial phase of the COVID-19 spillover event. So that the issues is first on the IHR amendment. I presume that's something that the Commission will be heavily involved in terms of amending the IHR to give it more teeth and more power, a little bit what you've achieved on the regulation within the European Union. The second is the risk of accidental release, and that comes back to biosecurity and the work that Jean-Luc is doing. There are labs mushrooming at a rate, not just in Europe, but outside Europe, and the risks, again, are increasing year on year in terms of accidental release. And there's gain-of-function research that's been done across the world with very poor regulation. You look at the research being done on H5N1 in ferrets, on poliovirus, on West Nile fever virus. And then the last point is the issue of deliberate release. Now, this is where the security side is really important, and it's something that I think we've kind of hesitated from getting too involved because it deals with interdiction and attribution. Well, in the public health side, from the public health, we need more crisis managers and we need more that security side. And I think that's something that we need to have mechanisms in place to be able to detect it, because what's happening now with the technology of the availability of genetic engineering technology, biohackers, what do you call it, synthetic biology, garage biology. So again, those risks are so prevention is always better than response. You've got prevention first, then preparedness, and then response. But I suppose it's the general question of what the Commission and what the EU agencies are doing on prevention.
Okay, so what do you want to say about prevention?
I'll take you to CDC.
Okay, the only thing I can say from the CDC side, I don't know if you remember, but we have a silent P in our title. It's a European Center for Prevention and Control. So they are doing a prevention framework. A lot of colleagues are working on that. Unfortunately, it doesn't have CBRN in, and it doesn't have intentional release. This is something that, because of our new mandate and our other tasks, has been deprioritized. We were doing some trainings, we were doing some work with Europol and everything, and this will kind of slow down a little bit, unfortunately. It's the, the new tasks, but there are other players.
Yes, at DG HERA, what we are trying now to develop is a biosecurity strategy. So we will, the colleagues are starting now to work. They are also working with partners in the US and with WHO, and they are trying to start, but it's really embryonic, so it's really at the starting point. In terms of deliberate acts, what we are trying to do, as I said, we're trying to work with different networks. So we are engaging with Europol, we are engaging with NATO to try to also understand if we can have access to their risk data and to their risk analysis to see how we can then inform our own actions on that. So, and I guess I always forget the name because these names on NATO, they are very complex, but the center in Koblenz, for instance, which one of the centers, exactly. It's one of the centers with whom we are trying to work with. And I'm not sure, but I think Maria also has something that can be useful for you. Sorry. We hijacked the
we have our own. Yeah. No, you go. Just saying that a lot of the prevention strategy can also have to do with speed of information and speed of communication. And I think, at least in my part of the work, that's what we've been trying to do, connecting the dots between stakeholders that normally would not connect. And again, this is what I was telling you about before, for example, with Europol, with Copernicus colleagues. This may seem small now, but the fact is that, for example, prevention doesn't only have to do with diagnostics, with treatment. It also has to do, for example, with vector control measures, which is something that you can start thinking about when you have access to this type of information that we're talking about. So yeah, that's my comment, that it's also a prevention measure to make sure that you have access to the information when needed and that the right people are speaking to each other. And I think this is part of the work that we're doing now.
In fact, Hello. Yeah. No, in fact, I do have something to say as well on this. For the intentional release, so the deliberate threats. GA terror comes. The very joint action is the result of Health Security Committee discussion after the Novichok attacks in UK and then in Germany as well, so chemical and biological agents. So there has been a lot of talks. Actually, the Health Security Committee, I believe, historically came into be on this basis of intentional release of biological or chemical agent. Then, so GA terror this is what they try to achieve, come up with a strong coordination methodology. It starts all with communication channel, if I might say, because first of all, we need to know to whom we're talking to. I mean, I say that as well within a commission. I mean, we have DG Home, so we need to have open communication. I mean, and we do have, but it's the same at the level of each member states. You need to open up those communication channels to share situation analysis as well, to anticipate. Because law enforcement, I mean, they are very secretive on, of course, I mean, that's understandable, but they might benefit from understanding what an agent can cause in a mass, on how many people will it affect, what is in terms of really public health impacts. So here there is ongoing work from the joint action, at least from our funding and member states funding. So again, they have recognized this as a priority. So they work together. Then in the regulation, of course, ECDC has a mandate to do risk assessment on biological aid, okay? But the other agency now, the novelty there is that risk assessment will be done by the chemical agency, by the environmental agency, and there is also the involvement of Europol in some case, the DG Home. So risk assessment is being also revamped in the regulation. That's our backbone, basically, where we. Okay, no.
But let me take that before I leave it to Jean-Luc, because now we are touching on what somebody called in-crisis research or whatever, because you cannot make a risk assessment unless you have some data to work on. And I think that's another sort of semi-failure in this pandemic. We were not very quick at collecting the best data. And to do that, you need to have the structures in place beforehand, just like you need to have the trust in beforehand and so on. And so once again, and we discussed this after the previous pandemic. Actually, I have a very nice from the previous pandemic, what the lessons learned, and I can read them up now. They're exactly the same this time. So when you get old, you get cynical, and sometimes I'm a bit cynical about this. But I think that this time we have the chance again to put the structures in place, to make the right kind of research early on. And once again, it needs to be a broad intersectorial research. It cannot only be sort of that we're going to sequence this and that, or that we're going to look at this and so on. You need to have the full picture to make the right kind of risk assessment. And that also comes back to deliberate threats, to understand, do we really worry about the right things or the wrong things and stuff like that. So what are in the plans for putting structures in place so that next time we do the right research very quickly and just don't send data to WHO and others and do not really see very much done with it?
I think Hera on threat anticipation.
No, and the research. Yeah.
On research, yeah. Just a bit what I can say is that we're trying, for instance, one of the things that we are trying to do together with EMA and also with DG Santé is to enhance coordination of clinical trials. So this will also be, and to make sure that we try to start as soon as possible. Another thing that is integrated into the emergency framework regulation, so whenever a huge crisis hit, theoretically the Commission is able to to implement a set of measures, exceptional measures, that are listed into this regulation, and one of those measures passes by the implementation of research plans, and these plans are currently being developed. So hopefully they will be properly developed very soon, and they will also be able to give us some data. Then in terms of also, once this regulation, this emergency framework regulation is activated, another set of data that we are able to tap into is data coming from member states and from manufacturers, because then they are obliged to communicate to us data, for instance, on stocks and on raw materials. While now, in our preparedness phase, you know, it's on a voluntary basis. Some are kind, some are not kind. And this work is also being developed with EMA, because these data will be provided on critical medical countermeasures, so based on a list that will be developed. So it's a bit of hints. I'm not sure if I'm fully replying to your question, but it's the best I have at the moment. And I can follow up with colleagues.
Okay, and in addition, like a very down-to-earth public health operational research, not clinical trials, not vaccines, not this type of thing. But it has been identified by many member states that they lack the ability to do what we call operational research, like the first few hundred cases, secondary attack rates of a new pathogen, this type of thing. We've seen particularly the smaller member states said, we don't have this capacity unless you give us something ready-made. One of the things we are working on is like simple protocols that are agreed ahead of time, and we can kind of switch them on when time is needed, when it is needed, sorry. But I think it's still difficult. I see it as only few member states can do that. And this comes back to the workforce. It's a few people who need to do everything and mostly go after cases, go after contact tracing, all this. So when you ask them to do research and all, it's like beyond their capacity.
But it's exactly, that's why we need to have the structures in place beforehand. And I don't really think we need to say that we don't have the workforce to do that, because we need to use the workforce to do that. That's my strong opinion in this area. And because there's a number of questions we need to have answers on. And this takes me on to modeling and another part of what Pandem produced. Because this data is also needed for the modeling people to do their things early on. And we have really shown us that how important it is that they can do a good work from the beginning. So I would have no problem in stopping contact tracing if I got some good data instead. Jean-Luc, please.
Artist to bounce back or just what you said about research. I think if you want to provide a good training that is e-learning or more, and should be more, we all agree, you should have updated training. As we said, research is evolving very quickly, technology is evolving very quickly, can bring good things, can bring nasty things, and emerging threats are increasing, new threats related to climate change or synthetic biology. Thanks, Moira, for commenting upon. So how do you see the mechanisms to update as quickly as possible? I know workforce is limited, this I understood, but we need to have a mechanism into place, as Anders commented. Really, it is important. How do you see this update? Because things are evolving so quickly, but many things are done in research and should be exploited. So how do you see that?
For me, it's hard. It's really hard, I have to say, particularly in a crisis, yeah. One thing, yeah, there are many comments, and thank you for the discussion, actually.
Solutions.
I have to tell you that only, for example, I think it's only 2 years now that, for example, they updated the modules in EPIET and they included R, for example, where we saw in the pandemic that every report, everything was analyzed with R. So, yeah. It again falls though on how much capacity we have, and then I will repeat something that we agencies are not good at using what projects produce. This has been forever since I was sitting in your place. So and this is, we have to make it work. I don't know.
Just to piggyback on that, I think DG Research has been for ages now trying to see how to best exploit the results, and nowadays they even have a project that helps you exploit the results. So that's the circle that we are closing in. And for instance, for us, in particular for trainings, one of my major questions now with developing our training strategy is exactly that: how do I make sure that I have an updated training needs assessment that is being constantly fed, because it needs to be relevant and it needs to be in line with the needs that are constantly changing, potentially, needs that are being updated. It needs to be updated with content that is being changing. So that's one of the things that we're going to try to see how we are able to work on that. I know that the colleagues at the CDC from the training, they have the same questioning. And for me, I still don't have the answer at the moment, but I hope I will have, and I hope I will have the resources to do it. Because you see, I also need, I need to have the resources to be able to update the e-learnings, to update our in-person trainings, because all of these things takes a lot of resources, and it's not always that we get them from, whoever needs to give them, because we all want to forget the emergency very fast.
Okay, thank you. We had a question in the middle. Yes, please.
Thank you. Very short. When you were mentioning that we need to get data from different areas, different sectors, that's very important. But one thing that also happens in the health sector, the information tends to go up, but doesn't go down. So you need to provide something. What's in it for me if I'm a different sector? When I provide data and information, what will be the return of that information, because it will be useful for them to also decide. So that's why I feel that the role of the dashboard and the integrating information from multiple sources, and Maria was addressing that, trying to find new sources of information. The dashboard might be one of the key tools that can be shared by different stakeholders, and they will then see the value of adding information to those data sources. So I think that's something that we should really push forward, especially when we're dealing with other sectors. Within our sector, eventual syndromic surveillance is at arm's length, and eventually participatory surveillance, which is also a poor relative, but maybe we should also consider it as an important one. Thanks.
No, I mean, this is clearly very, very, very important, and we sometimes lose track of that because we don't feel we have time to do it. But as you said, it's essential to do it. But it's also essential to analyze the data you get in. You cannot just send it back like it was. You need to do something with it to show that you can actually provide an added value to the people out there. And I think that's what we missed this time.
Yeah, and also
we need to have the structures in place to be able to do that. And it does not have to be that fancy, very advanced analysis. Just simple things is a good start.
Yeah, no, just to add before the comment, translated also. Many times, when we present the data, it's not enough. You need to translate it so that people understand what they look at. Yeah, please.
Hi, thanks. Conor Hayes, I'm a computer scientist from the University of Galway. I just wanted to maybe address Jean-Luc's question there about how do we keep...
You need to put your mic much closer.
You hear me? Yes. Okay, did you hear the first part? Conor Hayes, computer scientist, University of Galway. I wanted just to address the question there about how to keep on top of training, and I want to bring back the question back to PANDEM-2. So I was part of the technical team that worked on PANDEM-2, and one of the things that we learned was the necessity of good data, and data that's focused on a particular maybe crisis we're looking to explore in a training context, and we did that for the FX. And my view as a computer scientist is I would view PANDEM-2, the platform and the source application, as a type of console in which we plug in data. And a third part of that, and it's something I think that was out of scope of this project, but it strikes me from listening to what people are talking about here, is the need to have what I would call sort of plug-and-play generative data cartridges that are parameterizable for particular scenarios, for particular CBRN scenarios. So it means that, when I talk about a cartridge, I'm talking, like the old Atari cartridges that we might have played when we were kids, but really I'm talking about a software cartridge, right? So where that is generated using modeling techniques, but we can say how much data we want, what type of data we want. We can put in parameters to do with populations, to do with what we understand about hospital capacities, and about the nature of the CBRN event that we're looking to explore. And that gives us a sense of being able to provide something that is not just the same every time. I mean, I come from an area of machine learning, and one of the things that you have in machine learning is that if you have the same data set all the time, you actually learn nothing. You have to constantly find new data sets on which to train. And I think here, this is a similar type of question. It's not machine learning, it's people training, right? But so I think that's something that we could look at as a future for what we're going to do in PANDEM-2.
Thanks. And I think that really comes back to what I was trying to push for, and that's prepare beforehand, so that we also collect the right data. I think we are getting towards the end of this session. Do we have 2 more minutes, Maura?
Yeah, sure.
I would just let everybody say one thing about what are you going to go back home and do now. What's your highest priority?
No, actually, I'm going to put a reminder to myself for next week to look for the report from the Dutch. That's one of the first ones. And my second one would be to make sure I speak to my colleague that is developing the biosecurity strategy. There are many actors who are interested, and maybe they can support us. So it's, a two-way thing.
To put a reminder to talk to Combs and John Kinsman, who is our risk communication person, about the social media monitoring and the other toolkits. Yeah.
And myself, 2 tasks. So first one is to get in touch with our consortium, the contractor that is working on developing the EU training program for health, public health staff and healthcare. To get in touch with Moira again, and then setting a date possibly for you to come and explain and disseminate the results of the project Pandem. And the real priority that I have now is to finalize the process about Article 7. So this reporting tool, which needs to be online by end of September latest, and it's open for member states to fill. That's a big questionnaire for them. So these are my 2 key things. Yeah, why you are special?
No, I'm going back to my agency and remind them about how important it is to sit down and discuss lessons learned. I think we're all in a position right now when we went from one crisis to the next, and we didn't really have time to do this in a proper manner, and I think that's a shame. And I think that this project has really provided a possibility to do that a little bit more than would have been done otherwise. So I think there's a lot of value in that. I think we're losing an opportunity when we are moving into the next crisis without thinking about one we just passed.
Yeah, I really agree with Anders, absolutely. And the first thing would be, like Jessica just kindly reminded me, to finalize our last deliverable, of course. Yeah, of course, this is top of the agenda, nonetheless. And also, we are right now in the process of doing several after-action reviews, and we are just doing in specific areas concerning the EOC process. So we have very defined positions in our EOC. We have similarly a military structure adapted on it. And so we're in the process of this, and we this week was on scanning new information, the position with the email scanning, and so we're putting all this together within the next month. And then the next thing will be to update our preparedness plans, of course. But now today I really understood how huge it's going to be, this process. I knew it wasn't easy, but now I have the full picture, I guess. So I will go back and discuss with all of our directors how to manage that, because we have contacts to the disaster management units, but these are all project specific. They are not really fully structured, and there are no SOPs in place. It's all based on good reliance, because the people know each other for decades, but it's nothing you can have in the next pandemic to trust on. So I absolutely agree with your points. Yeah, thank you very much.
I'm going home to read about this infodemic manager training you were telling us about. So I'm gonna do that. And also, I'm going to try to have a conversation with my colleagues about what the colleague from ECDC was talking about, making sure that the information that you're presenting is translated so that all the stakeholders involved in the process can understand what they're seeing. I think this is super important for Athena, for the platform that we're now implementing, not only because we have stakeholders from different areas, but also within HERA, actually, we have colleagues from very different backgrounds, from different areas of expertise, and it's essential to make sure that you're taking all the benefits you can out of the data you have, so that everyone can understand it. So, yeah, those are my two priorities.
Thank you for the discussion. It was really active and really nice.
Thank you.
Okay, so we're in the final 5-10 minutes, and I just want to make a brief summary of the discussion we've had this afternoon. I would like to thank our 4 participants on the panel, given the heat and the end of the day. Thank you for all the effort and energy you put into this afternoon's session. So in terms of take-home messages, I think one issue that I think comes out the strongest is the importance of the regulation and what it actually offers us as European member states. And this is a really valuable opportunity, and we need to take this baton and run with it and support ECDC, Santé and HERA in whatever way we can in terms of additional, in terms of the research that we've done to date. In terms of the Article 11, there is such potential there for joint cross-border training, and to extend the work that we've already started with ECDC on the EWS CIMEX platform. And again, it's a safe space. There's no issues with GDPR, and we can look at our standardization and our procedures, our standard operating procedures, and we can ensure that there is the capacity then to engage in cross-border responses. The area of strengthening the health workforce is crucial. Nothing will happen unless we have a strong health workforce. And that includes healthcare workers and public health experts. And the issue of stress tests, again, is something that we can provide a framework in which to do that. As Conor mentioned, those plug-in options where you can take a CBRN event, or you can take a pandemic or an environmental event, for example. In terms of the public health agencies, I think it was a very strong message from Cynthia yesterday and from Agarista and Virginia today in terms of the public health agencies and how important it is that we go back to our public health agencies in our respective member states and showcase what we've developed and see how the tools that we've developed, and there's a range of 6 of them, how they can be implemented. I was particularly interested, Virginia, when you spoke about One Health and IHR, and on the use of digital tools, because that will transform how we manage the next pandemic. It will, in some ways, make it easier. And I suppose one area we didn't discuss today, but the potential for using artificial intelligence for contact tracing is something that really we could be looking at once we sort out the GDPR issues. In terms of some really interesting work, the work, and Virginia and Jessica and I had a very fruitful meeting last week at Massimo Ciotti, who I know from his days in ECDC, and we will work with Massimo to ensure that what we have developed with funding by the Commission feeds into the work that he is doing. From HERA, it's really interesting to see the work on wastewater surveillance and genomics. It's really good to see a target there of trying to get 5% of samples sequenced in European member states. That's something that certainly I'm sure Anders and many of us in public health would endorse, because there's huge variations in the capacity at EU level, at member state level. The Athena platform, we're aware that this is a process, a tender process it's been undergone until I think the end of June. And obviously key work there in intelligence gathering and analysis. The stockpiling, again, that's very relevant to the work we've been doing, and the link with eNOTICE and Proactive on CBRN stockpiling and on medical stockpiling. And it's something I think that we dropped the ball on during the pandemic, the fact that the European Union capacity even to produce PPE left us behind the game. So we need to make sure we've got that capacity in Europe to prepare to produce PPE for a future pandemic. And I think and then in terms of Agorista, the importance of the investment in the public health workforce, and what we really need are European benchmarks. We need to be able to say, well, if you have X number, if they have X number in Germany, we need to have the same number in France. Or that's the only way that you have to measure it, and then countries have to get kind of, forced into reaching it. Yeah, exactly. And that does work. If you don't measure it, it doesn't happen. And I think we've seen it, and it can be sensitive, and even things like number of ICU beds per 100,000 population, that's something that member states did not particularly want to share. That was okay for Luxembourg, was okay for Germany, but for my country, it wasn't a comfortable indicator to be providing. So there's sensitivity around that. But ultimately, we have a duty to protect EU citizens and to make sure the governments put money into preparedness, pandemic preparedness. Preparing for the next crisis, I think that's really, as Anders said, the opportunity now is to embed what we've learned, despite a lot of political pressure to forget it and move on, as what happened in 1946, 47. It's human nature to move on. Risk communication and community engagement. This was born out of the Ebola outbreaks in Africa, where we sent in microbiologists in hazmat suits, and it led to riots because they weren't working with the local population. And what we were trying to do was very much at odds with the culture. What we did in Europe was also at odds with the culture, but I think the risk communication work was actually in most countries, was very well done. There's an acknowledgement that public health agencies needed that expertise, and I think that came from the Ebola outbreak, because I remember the last meeting that we had here in Brussels for the Phase 1 project. It was just after the Ebola outbreak in West Africa, which was a communications of crisis. It was a crisis. It was a crisis that was to do with communications, not health. It wasn't a health crisis as such. And then I think in terms of the area of vulnerable groups, it's one of the lessons I take home from the eNOTICE and the proactive presentations. We need to be incorporating vulnerable groups in our research. It's a lot easier to take males from 18 to 45 and do clinical trials on them, or have them involved in exercises. And here you work on clinical trials. It's important to make sure that we are inclusive in terms of our study populations. And then that helps inform our communication strategies in the event of a crisis. And obviously the last area, the whole area of collection analysis of data and evidence. This is the information age. Information transformed how we responded to this pandemic. It allowed us to do homeschooling. It allowed us to do remote working. It was advances by our colleagues in computer science, who I understand probably 15 or 20% of the work they do, but we owe it to them. We owe a great credit to the work that they've done. And the work that's been done on this dashboard, on these SMA tools, on the workforce capacity mapping tool. There has been huge amount of work that's been done by the team, and I'd like to particularly acknowledge the tech team here, and I'd like to acknowledge Jessica's leadership on the tech team, who has done an absolutely superb job. And I think I'll come back to that in a minute. I think it's been an absolute pleasure and an honour to have worked with you all over the last 2.5 years. I don't think anyone would have predicted that when we put the proposal in, what we would be dealing with in 3 months' time. And you may know, Agrista, we actually had within our proposal, we had an accidental release scenario of a novel coronavirus in a Southeast Asian country. So that was something that, to think that it happened 3 months later. We see great links have been made with the security domain in terms of CBRN, the multi-sectoral whole of society approach, and it's more than buzzwords. We've got to have practical outputs and how we incorporate these approaches, these concepts, into our daily work, whether it's in ECDC, whether it's at member state level in RIVM, whether it's in a university department. And I think, let me just see my notes here. Yeah, I think that's everything. So what I'd like to do is, firstly, I'd like to say a really big thank you to Olga for all of the work that she's done. Olga and Jean-Luc and I worked together on Pandem Phase 1, and so it's nearly 10 years now that I've known you guys, and it has been just a really enjoyable professional experience to be working with you. And Brussels has always been a home in a way, where I think we've managed to engage with policymakers, with industry, and with researchers. So it's a very fruitful forum to be here. I'd like to thank Jean-Luc for, again, putting all the work that was done on his team and keeping that guidance and security, keeping us aware of the security component of our work. And I think one positive thing is that we had conversations before Phase 2 with first responders who said, we're really not that relevant. It's not, and then we see their role as contact tracers and vaccination and, quarantine measures and helping with, various interventions during the pandemic. So yeah, and a huge thanks to all of you. I mean, we are, I think, about 65 researchers. It's been a real pleasure. I haven't given up on P3. We are working on P3. We've just got to deliver on P2 first. And either way, I believe that Europe will be a safer place on foot of the work that we're doing now. It may be in small things, but the collective commitment, the intellectual brilliance, the experience of COVID, the fact that you all worked on this project from your garden shed, your kitchen, your sitting room with kids and dogs and whatever else, the fact that that was done, and we lost a lot of that human contact that keeps us working together. So it was a difficult environment for all of us. We might not have been and we've got our hospital consultants who are working in the front line, providing healthcare, and then coming to research meetings on how to make it better next time around. So a great credit to the frontline first responders and the frontline healthcare workers. While we had the luxury in a way of dealing with information and data, that was really a challenge, and to maintain that commitment to research and doing it better next time. So at risk of, I'll just say a big thanks to everybody, and thank you, Alma, for your acknowledgement earlier on. Thank you so much. And I would just like to close with a very big thanks to Jessica Hayes, who is the most incredible project manager. Bravo. She is a formidable project manager with incredible talents and skills. And if anybody else tries to steal her from me, there will be war. So it's been a great pleasure, and Jessica and I mean, it's nearly 2.5 years we've been working together, and we'll continue this collaboration and hopefully to continue to strengthen Europe against future pandemics. So many thanks, and have a nice evening. Oh, and everybody wait. Oh, do you forget something? Okay, there's a photo.